Yes, ma'am. We have to present within 5 minutes. Yeah.
Correct. And you have to be there also on time. Otherwise, you may miss your chance.
I'm here, ma'am. Does that need me to do anything else?
No. I'm just just
Okay.
making things
I'm here.
sure
Yeah.
again. Yeah. So everybody else, I think we should call. Okay. Who is Shivraj Meena? Screen name with Shivraj Meena. May I know?
Um, Good afternoon. Actually, I am Dr. Neelam. I think share this Zoom ID is by my husband, so that's why I
Okay.
Okay,
couldn't
I'm
say.
renaming you. I'm
It's
renaming you, ma'am.
perfectly fine. On the right side of your na, there are three dots. So when you click there, you can rename your name.
Okay.
Yeah. Atul, can you just run the PPTs?
Just wait, ma'am. I'm just doing something, and
Okay.
I will just get back to you in just within 2 to 3 minutes.
Perfectly fine.
Ma'am, can we go through the CVs? Hello. Hello, ma'am. Hello. Hello, Pooja, ma'am.
Good morning, Priya ma'am.
Ma'am, can we go through the CV once?
Ha, please. Hi, Dr. Sarina.
Please check, ma'am.
Yes.
First
Okay.
slide.
So I will be saying next slide and you will be changing. Is it?
You don't need to say. Just
Okay.
ask for name. I will accordingly.
Perfectly
I
fine.
have the all programs, so I will take accordingly. Okay.
Correct. Next, yes. Okay. Next, yes. Okay.
This will be in hall A, ma'am.
Yes.
So we no, don't
The
need to
common
run, but
slide for
yes,
everyone.
ma'am. Yes, ma'am. This is also a common slide.
Yes. Yes.
This is the end of.
Okay. Done. Done.
Okay.
Okay. So I just wanted to communicate with Dr. Serena. Hi, Dr. Serena. Am I audible to you? Unmute yourself. Narendra Pratap. Who is with name of Narendra Pratap? Screen name is Narendra Pratap. May I need hello?
He haven't joined with audio. Dr. Narendra Pratap, please connect to audio.
Dr. Serena.
Yes,
Hi.
ma'am. Hi.
Am I
Who
pronunciating
is
your
his
name
name? Narendra
correctly?
Pratap.
Pardon?
I'm correct. I'm pronunciating your name correctly. Your
Yeah,
name
Sarina.
is Dr. Serena. Is
Sarina.
that okay?
Yeah.
Thank you. Hi. Who is there with Dr. Narendra Pratap with the screen name? Atul, do you have the number of Dr. Richa and Dr. Deepika?
Dr. Richa and Deepika.
Their number is not reachable, Dr. Richa. And Deepika, we don't have.
Okay. And who is this Varun? Acha, okay. You are from the tech team.
Yes,
This
yes.
is from my team.
Okay, sure, sure. So Deepika is not available and Richa is also not available.
Not reachable, I think.
Not reachable.
And Deepika का number नहीं है हमारे पास. That's why.
Deepika का number नहीं है आपके पास.
Mine got.
Okay. So we have only 5 minutes left. Let me.
We joined with Dr. Narendra Pratap. Please identify yourself. Otherwise, I will have to put you in waiting room.
Okay. Sure. Thank you.
Is the Dr. Deepika in the name of Narendra Pratap? Okay. So Dr. Randhir has not joined yet. Priya ma'am, good morning. So Atul, I'm reminding Dr. Randhir to join, and
Yes, ma'am.
also
Yes, ma'am.
I'm
Yes,
trying to find out the number of Deepika.
yes, ma'am. Yes, ma'am. Please,
Okay,
please.
fine.
Thank you. Dr. Randhir saying that he had joined.
Okay, okay, great.
Hello. Hello.
Yes, yes, sir.
Am I audible?
Yes, sir. Yes, sir. Perfect, sir.
Okay. Thank you.
So, ma'am, we have 2 minutes to go. So, we will do live at 12 o'clock after the countdown, sir.
Okay.
Atul,
Okay.
just
So,
give me a few seconds. I'm just coming.
Okay, ma'am. Okay.
we have got how many papers?
5 poster.
5 posters. So, okay. Each 10 minutes.
5 minutes for presentation and 2 minutes for discussion, sir.
Okay.
It's 7 minutes.
Okay. So marking we have to give by after the session is over. Many marking pattern is there? Out of how many
Hi
marks?
sir, good morning.
Good morning.
कैसे हैं आप?
Fine.
Thank you for coming. I was just about to call you कि आप join कर लीजिए and then you join.
नहीं. But yes, अच्छा बात कर लिया मेरे को because tomorrow I am so busy. Today we have got many meetings and all because I am local president also of Doctor Association, no? So
Yes.
Corona and all, no? So yeah, I'll leave
Right.
after this. Yeah.
So we have just 1 minute left to start the session. So I'll ask everybody to open their camera and come on the camera so that we can just interact for a few seconds and then we'll go on air.
Yeah.
So for flow will be Atul. I will introduce today's session. Okay, just by greeting
ma'am.
all
Yes,
the
ma'am. Yes, ma'am.
audience and everybody. And then I'll introduce the judges. And also I will take the name, whosoever is present. I think Dr. Priyanka is there.
Yes,
And
ma'am.
Dr. Priyanka, you are number 1.
Okay,
And
ma'am.
Dr. Serena is there and Dr. Neelam Meena is there. So we have 3 participants. So you have time and you can complete your session by 5 minutes. And then we have the discussion. So all the judges, I request you just get your questions ready for them. So just one question each. That's it.
Good afternoon, Randeep sir. Good afternoon,
Goodbye, boys. Boss. Goodbye.
Okay, ma'am. So
Yes,
it's
okay, I'm
12.
going
So
to
I will
start.
give you the countdown
Okay.
from 10 to 1 and then you will start. Okay.
Perfect.
Okay.
Ten, 9, 8, 7, 6, 5, 4, 3, 2, 1. We are live, ma'am.
Hello and good morning, everyone. I welcome all esteemed faculty and delegates on behalf of Fertivision 2021, hosted by Indian Fertility Society, New Delhi. I am sure under the leadership of respected Dr. Sudha Prasad Madam, Dr. Neena Madam, and Dr. K.D. Nair Sir, it will be an academic feast for all of you. And I'm sure you all will learn so many take-home messages. So let's begin the session. And our first session would be e-poster session. And we have today with us judges, Dr. Randhir Singh. Dr. Randhir Singh is Associate Professor, Allen Medical College and Director, BTT BC Bhopal. Good morning, sir, and welcome. On the next, we have Judge Dr. Manoj Chelani, sir. He's the Director of Ayush Hospital and Maternity Home, IVF Specialist, Laparoscopic and Hysteroscopic Surgeon. Welcome you, sir. And next, we have Dr. Priya Vashne, sir, ma'am, and she is Senior Infertility and IVF Consultant at Cloud9 Hospital, Gurugram. So with due respect and all of your permission, I would like to call upon the name of our first participant for e-poster. Number 1 is Dr. Priyanka Kalra. So Priyanka, Dr. Priyanka, it's all yours. Please start your presentation.
Can we have timer, please? We are not.
Please unmute yourself, Dr. Priyanka.
Yeah, I am unmuted. Hi, everyone. Can we have timer, please?
Am I audible?
Yes, you are audible, Dr. Priyanka.
I'll start.
I will request Atul to please set a timer.
Okay.
Ma'am, timer will be begin.
Good afternoon, everyone. I'm Dr. Priyanka. I'm an IFS fellow with Ridge IVF, Delhi. And I would like to share our center experience about the use of GnRH agonist as a pre-treatment in HRT FAT cycle. This was, we all know that GnRH agonists have been long used for suppression of, when we want to suppress the HPO axis, the ovaries, we want to suppress the estrogen production and all. And their use have also been seen in frozen embryo transfers as well as otherwise also in IVF. So our main aim of this study was to see if a pre-treatment with this GnRH agonist in the follicular phase before the start of HRT FAT cycle, can it go is it going to help us to see if the outcomes can be better? So this was a retrospective analysis of the outcomes of the patients, and that we conducted at the Ridge IVF Hospital at Delhi. And the hospital records, since it's a retrospective analysis, so we use the hospital records for 3 years. That was between October 2018 to October 2021. That was almost 3 years. And we tried to include all the patients in HRT FAT cycle that were going in this phase. However, we used a few exclusion criteria, which you could see were endometriosis, adenomyosis, scarred uteri, PCOS, recurrent abortions, etc. So all those patients who had any of these cases, we just excluded them. And finally, we used to calculate the sample size. We use an online sample size calculator to finally arrive to two groups. The one, group A, was GnRH-A pre-treatment group, and group B, which was non-GnRH pre-treatment group, and there were 60 patients in each of the groups. So both these groups, as after whether a GnRH-A or GnRH non-GnRH, both were made to undergo the standard protocol for HRT FAT in our hospital, which includes the starting of estradiol valerate. The brand name we use is Proginova, 2 milligram thrice a day, as we use it on the day 2 of the cycle, where we are planning to prepare the endometrium for the coming frozen embryo transfer. And then we do serial monitoring with TVS, and if need be, we do estradiol levels up to day 10 or day 14. Usually this much time it will take to prepare the endometrium, and then we plan when the endometrium is ready as per its appearance on the transvaginal scan in terms of thickness of at least 7 to 8 millimeters and echogenic tri-layer appearance. We plan the transfers, which can be either day 3 or day 5. So this is how the study was conducted. This is how we did retrospective analysis. We use data. And now, as you could see, that there are two bar diagrams I have put in my poster. The first one, you can see the blue one is the group A, that is the GnRH group, and the orange one is the non-GnRH group. So as you can see that both of them, you can see all the parameters, you can see the baseline characteristics, the height of the bar diagram is same. So that is just a conclusion that all the baseline characteristics for both the groups were same, whether it was age, duration of infertility, endometrial thickness achieved, embryos transferred, or whether it was a primary or secondary infertility. So the baseline characteristics were same, so we could expect some genuine outcomes. Now the second bar diagram you can see is that of the outcome. That is going to show what came as results in our study. You can see, as I told you, that group A is blue and group B, that is the non-GnRH, is orange. You can very well see that the outcomes, you can see that there's a significant difference in the height of the bar column. The blue one is almost the double, the three times. You can see that the implantation rate, number one. Another outcome was chemical pregnancy rate, then clinical pregnancy rate. So you can see the results obtained was statistically significant. So the outcomes were statistically significantly better in the group A, the GnRH group. That was the outcome we found. You can see the p-value is the third bar graph. We cannot see, just little up in abortion rate we can see, which shows that it was always below 0. That means the statistical significance was there for all the three parameters. That means it was less than 0.05. So our conclusion was that all the positive outcomes like clinical pregnancy rate, implantation rate, and were all better in the pre-treatment group. However, I would also like to mention that our results were different from all the prior studies. Like not all, like most of the prior studies have shown that they did not find any significant difference whether they were using GnRH or not. However, as I've put one reference below that conclusion, you can see Zubi et al. They published it in Human Reproduction Update. They found that it was they also found results like that of ours. So I would like to just have a suggestion that as in conclusion of our study, we found that GnRH agonist has definitely helped in improving outcomes of HRT FAT cycle. However, if you ask me that why it is not been seen in majority of the studies, then I would say that there has been a retrospective analysis. So the data collection, however, it is authentic data from the hospital records, but the quality of data might be poor because the person who was collecting data wasn't me. Number two, I would say the confounding factors, which if we do a prospective study could have been controlled, and maybe if we do a larger study, prospective study, maybe the differences can be, the results that we get might be different from what we have got. And third thing I personally feel could have affected that this is the 3-year period, is the period when COVID has affected all across the globe, and the fertility treatments, especially the elective ones and frozen embryo transfers, have not been that common. Obviously the caseload in our hospital was were also low. So that is again same. I am saying that
Ma'am,
if we
time's
do
up.
a prospective study or one, it might affect and the results might be different. Thank you.
Thank you, Dr. Priyanka. It
Thank
was
you.
a very nice presentation. A few questions I want to ask. One
Yes.
is that how much was the sample size?
Ma'am, it was 60 in each group, total of 120. I used a sample size calculator. It's an online one, ClinCalc, and I used 13% as the increase in the outcome rate, taking into reference the prior studies and with a power of 80% and alpha value of 0.05.
Okay. Second thing is that you have not mentions the major variables which are affecting the outcomes. Like what was the cause of infertility in these patients? Were they were the same cause which we are treating? Were they were of normal responder, poor responder? So there are many factors which affect this GnRH.
Yes,
count
ma'am,
regulation.
that is what I want to say. However, like it is little paradoxical. Can you see in the exclusion criteria? I even put endometriosis and
I do
adenomyosis.
agree, but
Yeah.
what were the causes in all the patients for which they were going under FET cycles? Were they the same or they were different? So if you've
Ma'am,
excluded endometriosis, PCO, so
Huh.
that might be either a tubal block
The
or
male
maybe
factor and
unexplained.
tubal block were the major ones. Male
So yeah,
factor,
you have to make a
and
comparison for these
unexplained.
things. Yes, you have to make a comparison for these things in
Yes,
both
ma'am.
of the groups.
Yes.
Second is that you have not mentioned what was the endometrial thickness in both the groups and what was the blood
I
flow
did
during
not
that
show
time.
it. It was the target was 7+, ma'am. We usually at a
And what,
center.
yes, so the both of the groups were the comparable, the endometrial thickness.
I beg your pardon. If you can see the baseline characteristics, the third bar diagram is ET, which is endometrial thickness. So it was comparable in both the groups. Average achieved was comparable in both the groups.
Okay.
Can you? Yeah. If you
So
allow
there
me to
was
share.
not a so endometrial thickness was perfectly fine, and cause you
Yes, ma'am.
said that you were confounded the variables. So that means the implantation rate was higher. You wanted to say this thing.
Yes, ma'am. In the treatment group, GnRH group, it was higher, significantly higher. I could not put the tables, but it was like 40 versus 20%. This
Okay.
high.
And any cycle cancellation rate in both the groups?
Ma'am, cancellation cycle was 2 cycles had to be cancelled. It has been written in the records because patient had spontaneous bleeding and one had severe COVID. So only 2 patients. That was all I could get from the records. There were more cancellations, but like I selected only 60 because of all the patients, the 3 years. I already knew that sample size is 60, so I selected only that continued, and I got the clinical pregnancy rate as well.
And what GnRH and what dose you have using? We
use Lupride depot 3.75 milligram in the early follicular phase in the pre-cycle.
Early follicular or
pre-cycle, in the pre-cycle treatment, like in the cycle before we are planning the HRT.
That means luteal phase.
Sorry, luteal phase, yeah.
Yes.
Dr. Priyanka, did you compare the age also and the embryo quality?
Sir, embryo quality I did not, but baseline characteristics in the age was same, if you could see. However, in outcomes, I did not compare if like elderly were giving good result. There have been studies which show that elderly people are more benefited if you give GnRH agonist. There have been studies, but as of now, I just compared the outcomes irrespective of the age. However, the characteristics like average age, mean age was same. It was 33.4 and 32.4. Like it was no significant difference in the average age of the patient.
Have you fixed that embryo quality, whether they were grade A, day 3 or day 5 embryos? They were the fixed variables, so they were also the different.
Ma'am, we usually in our center we transfer only grade A and grade B, and it was variable.
It's a very important role in the implantation rate. So have you fixed that variable, or it was different in both the groups?
No, ma'am, it wasn't fixed.
It wasn't fixed.
It wasn't fixed.
So there was it is the most important confounding factor.
Ma'am, probably that's why I'm saying if I do a prospective study, I would like to control that also.
Okay.
Priyanka, that you just tell me what were your exclusion criteria and inclusion criteria?
Yes, sir. Inclusion criteria was that I tried to study all the patients who were undergoing 60 patients as the sample size in this study period of 3 years. However, we excluded all those patients who had history of endometriosis, adenomyosis, a scarred uterus, endometrial polyps, hydrosalpinx, polycystic ovarian syndrome, and recurrent abortions.
Okay. And your results showing that, did you get up to the cancellation rate? You have not.
Sir, sorry.
Okay. So only. And then your abortion rates you have mentioned?
Yes, sir, I have mentioned, sir. There were 2 abortions in the first group and 1 abortion in the second group. But there is no. Yeah.
And what is statistic? Which method you have done for the statistics?
Sir, I have used online calculator, GraphPad online calculator, Fisher t-test I have used, and 2 into 2 contingency tables I have applied.
Thank you for my side. Okay.
So can we now move for the next e-poster presenter, Dr. Sarina?
I'm finished, ma'am. Okay.
Yeah,
Thank you.
thank you, Dr. Priyanka. Thank you so
Thank you.
much. Can we have Dr. Sarina with us?
Yes. Good morning, everybody. I'm Dr. Serena. The topic of my study is a comparative treatment outcome of oligozoospermic patients with antioxidants versus hormones plus antioxidants. Among the infertile couples, we know that the male factor is involved in almost half of the patients, making male infertility and subfertility a health problem of concern.
Reena, can you better please louder? We are not able to hear you.
Among the infertile couples, we know that male factor is involved in almost half of the patients, making male infertility a problem of concern. In our study, the initial screening evaluation of the male partner in a subfertile couple includes a minimum of 2 semen analysis, which gives an insight into the fertility potential. Oligozoospermic males, which we included, were the patients whose total sperm count fell between 5 to 15 million per ml. They were randomized into 2 groups, where group 1 was treated with antioxidants alone. The major constituents of the antioxidants which we used were carnitine, L-carnitine, coenzyme Q10, zinc, lycopene, astaxanthin, along with the vitamin E and C. In group 2, we treated them along with hormones, which were mainly injection HCG and HMG. The duration of study was around 3 months. The participants' age group was 25 to 40. We had a total of 50 patients, 25 in group 1 and 25 in group 2. The duration of marital life for the patients was around 1.5 to 2 years. Semen analysis was done with the abstinence of 2 to 3 days, and analysis was done according to the WHO 2010 criteria. And all the patients had normal hormone levels except 2 patients who had mildly elevated prolactin. So the dose of HCG which we used was 2500 international units, which was given 2 to 3 times per week. And the dose of HMG was 150 international units 3 times per week. And aim of the study was to compare the treatment outcome of oligozoospermic patients. We included the males who attended the andrology OPD of our hospital with sperm count between 5 to 15 million per ml, and the age group was 25 to 40. We excluded the patients with severe oligozoospermia who were less than 5 million, and the patients who did not fall in the age group of less than 25 and more than 40. The primary outcome of interest was the sperm concentration, and the secondary outcome was sperm motility. And the results, we found that in the post-treatment group with both hormones and antioxidants, the sperm concentration was significantly increased. It was statistically significant, but there was no difference in motility. The limitations of my study is I feel that the duration could have been a little bit more than 3 months, and the number of study subjects were also a bit less. And I could have measured the serum testosterone also. And although other studies say that antioxidants may improve the semen parameters, still more evidence is needed. That's all.
Okay, so I think Dr. Serena, you have presented your poster.
Yes, ma'am.
Yeah,
Yes.
okay. So I'll invite Dr. Priya ma'am, Manoj sir, and Nandini sir to ask questions. Thank you.
So, Serena, what was the criteria you were taking for the injection treatment? Like, have you done the hormones also, pre-treatment and post-treatment? And what all hormones you have done?
We have only the pre-treatment hormone levels. It was Normal only, ma'am.
And did you find any difference with treatment hormones level?
We did not do post-treatment, ma'am. We did pre-treatment. We selected patients who had normal levels only.
Okay, and what all hormones?
Prolactin, estradiol, testosterone, free testosterone, and LH.
Okay.
Deficit LH.
Fine. And what are the how much was the month duration of the treatment of the antioxidant?
Around 3 months, ma'am.
And the 3 months, what was the dosage of the injection which you took have given to the patients?
We have given HCG 2,500 units two times per week, and HMG 2 to 3 times per week.
2 to 3 times means matlab, there must be any common things out, no?
Yes, 3 times per week.
It was a retrospective study?
No, ma'am, prospective.
It was a prospective study. And how many patients you took on both the groups?
50, 25 in each group.
25. Okay. So what these results were statistically significant? The motility and count?
Which was treated with both hormones and antioxidants compared to the group which was treated only with antioxidants.
Okay. Fine, thank you.
So the comparison was between the only antioxidant and antioxidant plus hormones.
Yes.
It was not versus hormones versus antioxidants, right? Okay. So did you do serum testosterone after your treatment?
No, sir. That is one limitation. I could have followed it up with testosterone, because few other studies have also shown an increase in serum testosterone after treatment with hormones. I did not. We did not do that.
Yeah. Can I ask? Just inform me about your exclusion criteria and inclusion criteria.
We excluded patients who had severe oligo, like less than 5 million, sperm concentration less than 5 million, and also who did not fall in the age group of study, which was 25 to 40. The duration of married life, which we considered, was 1.5 to 2 years.
Okay, and what was your dropout rates, patients in the study?
3%, we had 3 to 4%. We had, sir, 3.4 actually.
Okay, and you excluded only on the 5 million count, or because sometimes we get 10 million count, but the motility is very less. So you were restricted only on the count or motility also?
Only primary outcome of interest was only sperm concentration, sir.
Concentration, okay. And you told it was randomized. So it was prospective. So it was randomized control RCT or not?
Yes, sir, randomized.
How you did a randomized control, with computer or how, which software and how?
Allotted into 2 groups, sir, like 1 and 2.
Manually, not by the computer and all.
Yes, sir, yes.
And what statistics you used for significance?
Chi-square test. And
Okay, thank you from my side.
Okay, thank you so much, Dr. Serena, for the presentation.
Thank you.
And now, can I proceed for the third name with us, Dr. Neelam Meena. Dr. Neelam, please unmute yourself.
Good afternoon, everyone. Today I'm going to present a rare case of PID associated with the endometriosis after transvaginal oocyte retrieval under the guidance of the Dr. Lina Vadva. Today we know as the ultrasound-guided transvaginal oocyte retrieval is a standard procedure for ovum pickup during in vitro fertilization and can be associated with the complications. Endometriosis is a potential risk factor for PID following transvaginal oocyte retrieval. The prevalence of the endometriosis is 30 to 50% in subfertility as compared to 5 to 10% of general female population. As here my case is a 21-year-old female with a secondary infertility with previous one abortion, grade 4 endometriosis with peritoneal and the bladder endometriosis, for which she underwent cystoscopic falsification twice before in 2016 in USI Basai and the second time in AIMS 2018 in AIMS, and underwent IVF. For that she was operated there, for which she underwent in a laparoscopic bilateral endometrial cystectomy with hysteroscopy, and they found that the grade 4 of endometriosis. And after that she presented in ASI where we done oocyte retrieval, and patient was lost to follow up in COVID pandemic time and presented with a pain abdomen and the abdomen swelling after 3 months of the transvaginal oocyte retrieval, which was done in April 2020 with the ultrasound showing complex cystic mass which is 12 by 8 by 9 centimeter in left adnexal region. In figure 1 we showing there is a loose mass which is 12 by 8 by 9 centimeter. After that patient was admitted. On admission there is no history of any fever or discharge per vaginum. On examination vital was she is stable and afebrile, and on examination per abdominal 18-week size firm mass with restricted mobility we found. We investigate her and her TLC was normal, and MRI revealed a hugely dilated oviduct with left ovarian mass. We shown in figure 2 in MRI report. As already I told, she was operated laparoscopic endometric cystectomy with hysteroscopy with chromoperturbation in AIMS. For that, they put her on leproride 3.75 milligram, followed by ovulation induction with HMG, but there is no response. Finally, patient came to us. This presentation, which is a patient came with the pain, abdominal swelling, we planned her for laparoscopy, and which was performed with the detuffing with tumors, followed by drainage and the falsification of the cystic wall. Introp figure 5 shows there is a localized pus at the hemorrhage present, and figure 4 may there is a uterus was normal in size and there is a huge mass which is included ovaries and the fallopian tube. On post-op, she received doxycycline for 3 weeks and monthly injection of leuprolide. On follow-up ultrasound after 2 months, which is shown in figure 5, there is a left adnexal mass which is regressed well, approximately it's 4 centimeter in size, and in right side there is no mass at present. And now we plan her for frozen embryo transfer. As we know, the transvaginal oocyte retrieval has been accepted as a standard procedure in ART, and there is some complication which occur like bleeding from the vaginal wall puncture, 1.4 to 18.4% most commonly encountered, intra-abdominal bleeding 0.05 to 0.2%, pelvic infection and pelvic abscess 0.2 to 0.5%, perforation of the bowel and the adjacent organs are rare. Other areas are uterovaginal fistula, ureteral injury, bladder injury with hematuria, pseudoaneurysm of the like artery, ovarian torsion, and the ovarian abscess. PID is known as a rare complication of womb pickup. We know there are some predisposing factors like previous laparotomy, structural genital anomalies, endometriosis. Like in our case, patient was a grade 4 endometriosis with hydrosalpinx, and during ART, they are the predisposing factor. Endometriosis has a small pool of old blood act as a culture media for inoculated bacteria, and inoculation of the vaginal bacteria and the anaerobic opportunistic suggestive to be a cause of PID following oocyte retrieval. In endometrioma, both the pseudocapsule of endometrium and inside blood act as it prevents the antibiotic prophylaxis overcoming the transvaginal oocyte inoculation. On conclusion, we conclude that the oocyte retrieval procedure can be considered as a safe procedure, although patient and physician should be, it is not the without risk. In women with endometrioma, use antibiotic prophylaxis before the time of oocyte retrieval to reduce the risk of the PID. We recommended to collect as many as oocyte as possible, a minimal number of punctures, avoiding puncture and risk of the endometrioma. And more vigorous antibiotic prophylaxis, better vaginal preparation using povidone iodine followed by saline are recommended after transvaginal, before transvaginal oocyte retrieval in performed in endometriosis cases. Surgical treatment, preferably by laparoscopy, should be considered in severe case of PID following endometriosis. Like in our setup, we are using saline for prior to ovum pickup patients, but according to many studies, we find that if we are using povidone iodine followed by saline irrigation, it will help to reduce the chance of infection in a patient with endometriosis, and there is no harm to the ovum. This is my conclusion, and more study or theory needed for this complication that can be occur with the patient of the endometriosis.
Dr. Neelam, what is the normal incidence of PID and endometriosis post in cases of endometriosis patient in general? Like,
So it's about 0.2 to 0.5% as well. It's
Okay, so
not
Neelam, what was the antibiotic prophylaxis you took in this patient?
so, ma'am, basically we are using Doxy and Metro for 2 weeks prior to ovum pickup. For the same patient, we are using this, and after the discharge, we also prescribe her for Doxy and Metro, doxycycline 100 mg BD and Metro 400 BD, TDS for 14 days.
So you are using 2 weeks prior to ovum pickup and 2 weeks after ovum pickup.
Ma'am, because routinely when we handle the cases of that, prior the ovum pickup, we are using the antibiotic, but because the patient
In all cases or especially in the cases of endometriosis?
ma'am, we are using in all cases.
In all cases, you are using Doxy and Metro 2 weeks prior to ovum pickup.
Means for the
That means when you start the stimulation, you put the patient on antibiotic. That's it.
I'm not just just starting off that. Basically, at the time of procedure, we give an injectable antibiotic monosafe. But patient when presented with before, not I'm saying at the time of stimulation, just we plan for her over pickup. So at the mid cycle of the prior month, the prior cycle, we just started for 2 weeks.
Okay, and what about the post-op? Like, have you seen the patient post-op also?
Yes, ma'am. We follow.
But was there any puncture of endometrioma during that procedure?
No, ma'am. In my case, we had done very carefully because we know we handle the case of the endometrioma. Accessibility is also not so difficult by transvaginal site retrieval. So we are confirmed that we are not punctured this endometrioma while doing this transvaginal site retrieval. But there's chances, studies also say that when not punctured, basically some deposits may be present in near peritoneal area because it's already grade 4 endometriosis. So that can be lead to this type of complications.
And have you asked for a post-op follow-up of this patient around after 3-4 days? Have you seen her post-op also?
Yes, ma'am. We have seen patient is very basically, ma'am. We follow up after one pickup. We follow every patient. We follow her 24 hours in a hospital. We just monitor her. Then we discharge her and review after 1 week. But because of the COVID pandemic time, patient didn't follow up. She came with the complaint of this pain, abdominal swelling after 3 months of the oocyte retrieval.
Okay.
do you normally do some vaginal swab culture before taking the patient for pickups? Do you do any investigation to rule out any infection, or do you give anything prophylactically, and how you do it, or do you give any probiotics and all?
No, sir. As it we have we're not using it as a protocol, but as a infertility workup, we just starting. We do HVS to rule out on examination, and by doing HVS, we rule out there's any local infection present or not. If suppose she had or she have any infection, then we treat that infection that time. Or there is no as a protocol. So probiotic we are not using.
In this case, I think endometriosis, when I was a student by Gain Chakravarti, he taught me endometriosis is a very, very critical patient. Bad implantation, bad ovary, bad immunity and all.
Yes, sir.
So in this case, you did notice that endometriosis you should be if you see the papers, 10-20% coincidence with endometriosis in Indian scenario is a tuberculosis also. So other risk factors like tuberculosis, diabetic or any other risk for the infection, did you rule out in this patient, or you routinely do or not? Because endometriosis patients, you have to be little careful in doing all these procedures.
Yes, sir. We rule out tuberculosis, but the patient had not any neither symptom or no investigation. We had done with rule out. We shows that she had tuberculosis, but because she already basically patient presented with after abortion with a history of hematuria. For that we they investigate her and fulguration of bladder was done and biopsy taken, which shows the bladder endometriosis. Followed by again she had a complaint of the same things. The again she had underwent of cystoscopic fulguration. She and then reconfirmed the bladder endometriosis. On that time in AIMS, they plan for infant management of her. They do a DHL, or we can say laparoscopic examination of that part. They found the endometriosis. They do cystectomy plus an hysteroscopy. They found there is a bladder side, they increase vascularity. So maybe in my case, she had a grade 4 endometriosis. That's why this complication, we can say PID can is occur in this patient.
Yeah, grade 4 means you have to be very cautious during the ovum pickup, because that is very important.
Yes, sir.
And
We are very
precaution.
particular. Yeah, because we know prior to handling that this is a case of grade 4 endometriosis.
Because sometimes in endometriosis, during the patients, the only mild endometriosis, and you have planned everything, you have given depot and all everything, but still, because in lab I see out of 10 tubes in one, you get the endometrial fluid. Is that endometriosis, that color, chocolate color fluid? So I don't mix those oocytes. If I get oocytes also in that tube, I try to keep everything through culture, Manoj, because the chance of infection is there always, but you get oocytes because in that. So you have to take a precaution. That is my take home. Nice paper from my side. Okay.
Yes, sir. Thank you, sir.
Thank you, Dr. Neelam, and thank you all the judges. We have next, I can see on the screen, Dr. Deepika with us. And before that, I would like to call Dr. Richa. If Dr. Richa, you are with us, you can present your paper,
Yes.
or I will. Okay.
Yeah, I'm here.
Okay, Dr. Richa, please present your paper.
Yeah, I'm going to present a case of hypergonadotropic hypergonadism looking beyond ovarian senescence. Actually, this patient, this condition, which is resistant ovary syndrome, is a rare endocrine disorder, which is characterized by hypergonadotropic hypogonadism. And infertility is a common complaint of these women. And it is difficult to have reproduction with patient's own gametes in ROS cases. Our patient presented at the age of 28 years with the main complaint of oligomenorrhea since menarche, and she had primary infertility of 10 years. She had on workup, she had markedly increased gonadotropin levels around postmenopausal range. But when we did her ultrasound, we found normal antral follicle counts and AMH levels. And her karyotype was also normal, 46XX, and thyroid function was normal. And this table is showing reports of her various tests. Like we can see that her FSH levels were in the range of 30 and 55. And LH was also higher side. AMH was anti-mullerian hormone was 4.78, which is normal ovarian reserve, and estradiol was also normal. Testosterone, TSH, prolactin, ANA was normal, and we did her workup from autoimmune workup. We did ANA and anti-TPO antibodies, which was also normal. We did her MRI brain to see any abnormality, that was also normal. And her karyotype was also normal. In the suspicion of POF, we did her karyotype because she presented at very early age with raised FSH and LH levels. And when we did her ultrasound scan, her right ovary was of 6 ml volume, and antral follicle count were 8, and left ovary was 6.4 ml volume, and antral follicle count was 9. But looking the reports of this patient, if we would have gone by this FSH and LS value, we would have made the diagnosis of premature ovarian insufficiency in this patient. But when we did her ultrasound, we saw that her ovaries were showing antral follicle counts. So we went for this measurement of anti-mullerian hormone, which was surprisingly towards normal side. So we reviewed the literature, and we came to the diagnosis of this resistant ovary syndrome. So although we were aware that it is very unlikely to get ovulation in patients of this resistant ovary syndrome, but there were case reports of stimulation with high dose gonadotropin. So we tried her stimulating with high dose of gonadotropin, and which was not successful. And the dose of HMG what we used was 300 international unit for 7 days, followed by 500 for 10 days. And after that, when we saw that follicles were not recruiting, we stopped our stimulation. And what is the pathogenesis of this resistant ovary syndrome? Mostly pathogenesis is in the form of defect in FSH and LH receptors. These receptors get mutated. So what is the significance of diagnosing this resistant ovary syndrome? Because what is the difference from premature ovarian insufficiency? In premature ovarian insufficiency, it is not possible to have pregnancy with her own gametes. But in cases of resistant ovary syndrome, case reports are there where they have shown that pregnancy is possible. Like Granberg M et al. Reported first birth in female with resistant ovary syndrome, which was achieved after in vitro maturation of oocytes followed by ICSI. We can say that these oocytes were not, there are exact etiology we don't know, but many a times they have seen that these oocytes, which they fail to respond in vivo media, they respond to gonadotropin in vitro maturation cases. So in those cases, they just pick up the oocytes in very early stages of their development, and they do in vitro maturation and are followed by ICSI and IVF, and pregnancies have been reported. Similarly, Yu Li et al. Published successful pregnancy and live birth after IVF in the year 2016. Similarly, further, this Gavellino et al. Studies 9 patients, and they underwent 24 IVM cycles, and they reported live birth rate of around 16% and 16% per cycle and 33% per patient. And this study was published in the year of 2019. Further, many studies are there which have reported successful pregnancy outcome. So to conclude, I would like to say that do not categorize all patients with high level of FSH as having premature primary ovarian insufficiency. ROS patients do not respond to stimulation with high doses of gonadotropin. So it is wastage. Like we tried to stimulate her with high doses, and this did not work. Further, differentiate these cases of ROS from POI, as pregnancy in these patients with their own oocytes is possible using in vitro maturation of immature follicles followed by IVF and ICSI. So this diagnosis becomes important in terms of her future pregnancy perspective. Thank you.
Dr. Richa, what is the role of doing LH polymorphism tests in these case type of patients?
Yes, sir.
Is there any role?
Yes, sir. There is a role of LH testing receptor polymorphism, because studies have shown that most of these patients have a defect in receptors of LH and FSH, gonadotropin receptors. That is why if we test, we can conclusively say that this defect is because of receptor mutations, sir.
So have you done this receptor polymorphism test in this patient?
No, ma'am, we did not do. I was at that time in the setup where this test was not available, and this patient was not very kind of affording kind of patient. I was in government sector at that time. Right now also.
And you have tried only with the one stimulation?
Yes, ma'am, we have tried, because we have previously also, when in the previous cycle around 2018, stimulation was tried, but at that time the suppression was not used. In this time, we first used the suppression with 1 dose of leuprolide, and after that we stimulated the patient. But as she did not respond, sorry.
What was the logic of using suppression?
We thought that because FSH and LH are high, there was no logic. We just thought if suppressing can, in absence of these endogenous FSH and LH high doses, exogenous hormones can act. That was just the logic. And
how
because
much was the E2 level?
E2 level was around 72, 80 around.
On day 2?
Yes, ma'am. It was on day 2.
And have you checked it after 15 days of stimulation, whether it has grown or not?
No, we did not do the E2 level. We were just following her with ET and recruitment of follicle, and which we did not see. So we did not repeat the E2 level.
Did you follow up the patient 21 days also after stimulation, 21 to 30 days?
No, ma'am. After we did stimulation for around 17-18 days, and till that time there was no recruitment. So after that we did not follow the patient. Patient was coming, but in the terms of this ovulation induction, we did not do anything else.
Yes. So these patients at times, this is actually a variant of hypo only, where we have high FSH levels, and they at times they take a long stimulations. And there it's the role of taking all those recombinants. Maybe that financial constraint of the patient will not allow you to take. and we have to follow them till at least 30 days post stimulation. At times, they are small follicles.
Yes, ma'am.
We have to just track that the size, maybe that antral follicle count, they are 2 mm and they can grow till 7 mm. So you have to just keep on tracking this follicle.
We can do that in the next time for this patient, ma'am.
Track the patient. Have you tracked the patient till now? Patient lost to follow.
No, I have. She is in touch with me. She did not try for any follow-up later because we explained her about IVM and all, which is at present not available in any government setup, and she was not affording for private. That was the thing. She did not go for further treatment.
Okay.
So what was your dose for gonadotropin? You said 700 and 500?
Sir, we started with 300. We gave it for 7-8 HMG, sir. HMG. We gave it for 7-8 days, and after that we increased the dose to 450. That was given for 10 days.
LH polymorphism, you should have got it done from other centers. It's not so costly.
Yes,
that
sir.
would have helped you some.
Yes, sir. Yes, sir. We can do with that patient because she must be around 29, 30 now, and we still have time in terms of her age. Will I definitely follow up the patient, sir?
If I was going to your poster, so in this, because of high FSH also, you are labeling as a hypo. So here you got the AMH around 4, no?
4.7, yes, sir.
So this AMH you did repeat it or got only once, and which place? Because AMH is now values, yeah.
No, sir, 2 times. We repeated it 2 times. I have seen I've shown just one value, but we have repeated twice.
So you were confirmed that the value of the AMH was perfect, done by the perfect lab and all.
Yes,
so,
sir.
And AFC also you have followed many cycles or only 1 or 2 cycles?
Sir. No, sir, we have followed because we were not very sure of the diagnosis initially, for it was repeated twice or thrice it was repeated.
So in all poor responders, you start with HMG because, or you start with the recombinant FSH in stimulation?
Sir, we generally, as I told sir, we were in a government. I work in government sector.
So yeah.
That is his problem, sir.
Yeah,
so
but government
right,
also.
sir,
No, I mean government also, because now I'm in MP and now MP government is starting in all 6 medical colleges IVF unit. They have got 150 crores. So I think we are in the panel in the government advisor. So the government people also, if you advise better, I think that's good, and it's a very good initiative. Very rare patients, and I think Manoj is good. Now we have got all the papers are very interesting. Thanks from my side.
I think we have left with one more poster. Pooja, can we go ahead with the next one?
Yes, ma'am. We have the last poster of Dr. Deepika. Hi, Dr. Deepika. Please present your poster.
Hello. Good afternoon, everyone. Today, I am presenting a poster on the clinical study of fetal outcome following early and delayed cord clamping in births associated with anemia in the pregnancy. The main aim and objective of this study is to compare the hemoglobin, hematocrit, and serum ferritin at the birth and 4 weeks of age in babies following early and delayed cord clamping in births associated with anemia in the pregnancy, and add on to a study and compare the neonatal outcome in terms of polycythemia, hyperbilirubinemia, requiring phototherapy or exchange transfusion, need for blood transfusion, and intraventricular hemorrhage following early and delayed cord clamping. It is an observational prospective study, and the study was conducted in the labor room of Department of Obs and Gynae, Lady Hardinge Medical College, and it was in this the anemic women with period of gestation of around 32 to 40 weeks of gestation were included in the labor room, were enrolled in the study after taking informed consent, and a sample size of 120 women, out of which 48 subjects were in early cord clamping and 62 were in delayed cord clamping. The inclusion criteria of this study was antenatal women with period of gestation of 32 to 40 weeks admitted in labor room with anemia of 7 to 10.9 gram per cent. And the exclusion criteria are the pregnant woman with any medical disorders, including known case of diabetes, hypertension, asthma, heart disease, and any thyroid disease, kidney disease, Rh negative pregnancy, and any other hematological or immunological disorders, antepartum hemorrhage, and cord prolapse and cord abnormalities. And any, if the baby has gross congenital anomaly and baby is requiring resuscitation. In this, we have compared the socio-demographic socio-demographic profiles in both early and delayed cord clamping group, and that were included, that were shown in this table, that parity, age, height, weight, BMI, number of booked and unbooked cases were included of early and delayed cord clamping. And in this, the significant results were seen in the comparison of early and cord clamping shown in the graph. First, we have seen the cord hemoglobin that was comparable in both the groups. But when we compared the hemoglobin at the 4 weeks of neonatal in neonates, then it was raised in the delayed cord clamping. When we see the cord hematocrit level at the time of delivery in both early and delayed cord clamping, that was almost comparable. But when we see the hematocrit at the 4 week in the neonatal groups, that we can see that in early cord clamping it was 28.7, and at 4 week in delayed cord clamping it is around 31.2%. And when we see the cord ferritin, yes, cord ferritin was raised as compared in the delayed cord clamping group, might be because of the iron stores of mother in delayed cord clamping. But when we see the serum ferritin at 4 weeks, that showed the very significant results, that shown in early cord clamping it was 161, and in delayed cord clamping it was 246. So it was significantly raised. When we see the neonatal complications in the cases of hyperbilirubinemia and intraventricular hemorrhage in early, when we compared, that was found no significant results. When we compare the group of intraventricular hemorrhage, hyperbilirubinemia, and out of the total six babies had developed hyperbilirubinemia, in which the 6 required only phototherapy. And in this, as we can say, the prevalence of anemia in pregnant women worldwide is 41.8%, and the supporting study the studies that support our studies are Anderson et al. And Gupta et al. That showed that increased ferritin level and cord hematocrit level were increased when they compared with at 4 week of just at the 4 week in neonatal outcomes. So we can say that the prevalence of that delayed cord clamping can lead to the improvement in the iron stores. Anemic pregnant women have low iron stores, suggesting higher incidence of low hemoglobin and iron stores in fetus as well. So in order to tackle anemia in the infants, which is more likely in the babies born to anemic mothers, delayed cord clamping should be practiced. And it is an additional cost-effective intervention in low resource settings and developing countries for anemia management in infancy. And so the limiting factors of our study is that it excluded the high-risk pregnancies and additional variables. Thank you.
Very nice presentation. I think it was very good, and this is very known to us, and I think your paper is very good. But you have followed this results conclusion only at fertility level, or you follow up the child after 1 year, 2 year, how they behave?
So, we have followed them till 4 weeks, 4 weeks, and the additional complications till that period only.
I have not followed more than that. Yes. And this what exclusion criteria and inclusion criteria you have in this?
The exclusion criteria were the pregnancy in those who have high-risk pregnancy, that is add-on those patients who have diabetes, hypertension, any heart disease, Rh negative pregnancy, or any other hematological disorders, cord prolapse, cord abnormalities, any gross congenital anomaly in the baby, or babies requiring resuscitation. So these were exclusion criteria.
Statistics what you have performed this method?
So we have calculated by that is p-value, that is value of significant results were seen in only the groups.
Chi-square. You applied chi-square.
Yes.
Okay, from my side, okay.
So Deepika, what was the mode of delivery in these type of patients?
Ma'am, both the deliveries were included, normal vaginal delivery or the cesarean. Both both were included in this.
Okay, and were the Apgar score of the baby was the diagnostic?
Yes, we have calculated that Apgar score also. That Apgar score was not as such, were comparable in both the groups, in both early cord clamping and delayed cord clamping.
Okay. Thank you.
Okay, from my side.
Okay.
Thank you.
Thank you. Thank you, Dr. Deepika. And thank you all the participants who participated in e-poster presentation. Dr. Priya, Dr. Serena, Dr. Neelam, Dr. Richa, and Dr. Dipta. And a great thank you for my for our judges, Priya ma'am, Manoj sir, and Gandhir sir. Thank you so much. And it is wonderfully done.
Thank you to Fertivision. Thank you all the participants. You have done the great job.
Thank you.
Thank you. So now we are moving to the next session, which is oral presentation session. And I would like to introduce our respected
Ma'am, it will
judges.
be start at 1 p.m. So we have 6 minutes. So we are signing off till 5 minutes. Okay, ma'am?
We can't start it early, is it?
No, ma'am, because we don't have all judges and all participants.
We have all the judges, but I am not sure about the participants.
So I will give you again the countdown at 1 p.m. So then we will start. Okay.
Yeah, Pooja, let it be at 1 p.m. only
Yes,
as
ma'am.
per
Yes, ma'am.
schedule.
So by the
Right.
time we can check we have Dr. Juhi with us.
We can check the participants.
Yes.
Dr. Juhi.
I think she's not. Dr. Asta, I can see. Dr. Asta Lalwani. Hi, ma'am.
Yes, hello. Good afternoon.
Good afternoon. And we have Dr. Giovan Ranji. Do we have? No. Okay. Professor Sanjana Vadava.
Someone has joined 723812V9. Can you please identify yourself? Please tell me your name so I can rename you. Otherwise, I will have to put you in waiting room. I'm requesting you, please rename yourself. Otherwise, I will have to put you in waiting room. It's 723812V9.
So Atul is very clear. If somebody is not coming on the camera and not revealing the identity, please keep them in the waiting room.
Yes, I will have to, because I
Right.
don't want any clash in the room.
Perfect. So I
Yes,
am just calling the fifth name, Dr. Rita Mahesh. Is she with us? No.
We'll be joining in 5 minutes.
Okay. And what about Dr. Sanjana and Dr. Jiovan? Any news about them?
Dr. Gioni said he'll be joining in 2 minutes. Dr. Sanjana has not picked up the call.
Okay. Shalini ma'am, are we before time on the first? Or are we done? Okay.
I think all halls are going well and they are finishing. Hall B has finished. I was there in Hall A where the last session was going. So I think they also must be through with the poster session. So I think as of now, we are time in all the halls. And Atul, have you checked the number that you were announcing? Have you checked against we've been given the list of participants. Does that number matches? Because phone numbers are also given.
No, ma'am.
It doesn't match.
And I also messaged him many times,
Personally.
and
Okay.
yes, he didn't reply on Zoom chat.
Okay.
And I also asked him to start video and unmute themselves,
Right.
but not responding. So I have to put him in waiting room.
Okay, fair enough.
Yes, ma'am.
Okay. So maybe we can have the first presentation ready for the oral presentation, share screen. And before that, Pooja, you can introduce the judges just 1 minute before that, so that we start the session right at 1. Okay.
Perfectly fine, ma'am. Atul will give me the countdown of 10 and I'll start.
Yeah.
By the time, hi, Bindu ma'am, how are you? Good afternoon.
Hello, good afternoon. So nice to see you all again, even if it is virtually.
Yes. Hello, Dr. Bindu.
Hello, Dr. Shalini. How are you?
Yeah, perfectly fine, Dr. Bindu.
Okay. I
We
hope we'll
have
have an
Dr.
interesting session of wonderful oral presentations now.
Right. And the timings for that is 8 minutes and 2 minutes discussion. And immediately the scoring sheet is to be mailed. The mailing address is being shared on the group.
Yeah.
Good afternoon, Sunita ma'am.
Good afternoon. How are you?
I am good, ma'am. How are you, ma'am?
अच्छी हूँ, बिल्कुल अच्छी हूँ।
Yes, ma'am. Nice to see you.
मुझे तो लग रहा था थोड़ा जल्दी शुरू कर सकते हैं, पर उसकी बात भी सही है, बिकॉज कोई किसी सेशन से आ रहा है, कोई किसी सेशन से आ रहा है, तो लेट्स वेट टिल 1. तो हमारे पास कितने अभी पार्टिसिपेंट्स हैं, और डू वी हैव ऑल 5 या नहीं है?
No, we have only 2 right now, so we are calling them.
अच्छा, तो अभी आपके पास आस्था है और कौन है?
जूही, डॉक्टर जूही एंड डॉक्टर आस्था है, बट मैम पहले वाले ई पोस्टर सेशन में भी बाद में ज्वाइन कर लिया था सभी पार्टिसिपेंट ने ऑल।
ठीक है, तो वी विल स्टार्ट विद जूही ओनली. ठीक है.
After 2 minutes, I will give the countdown.
Yes, not a problem. ठीक है.
And is IRM, ma'am, please.
Okay, these are the two first, I mean, Dr. Juhi and Astha, they are the first two ones to present.
I am seeing a camera on IRM. Someone knows her, ma'am. Ma'am, please, can you tell your name?
I'm Dr. Jovin Ranji, sir.
Sorry?
Jovin Ranji.
Okay, I'm beginning.
Yeah. So that's the third participant. Dr. Juhi is here, Dr. Astha, Dr. Jovin.
Okay.
Yes. So, Atul, can you please change the name of Dr. Jovin? Rename her?
Yes, I am doing.
Thank you.
Dr. Jovin, your face is not visible. Can you sit against the light? Your face is not visible. You're not visible at all. Just face the window. That will be better. Darken it.
Yeah.
Absolutely wonderful. Yeah.
It's 1 p.m. So can we start?
Yes, we can
So
start.
I will give you the countdown from 10, and like before, we will start.
Perfect.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. We are live, ma'am.
Good afternoon again, and we are here for the next session, which is oral presentation. And I would like to introduce our esteemed judges for this. Can we have the slides? We have today with us Dr. Bindu Chimote, madam, clinical embryology, Hospital, Delhi, NIR. Welcome, ma'am. And next, we have Dr. Sunita Chandra with us. She is a very senior infertility expert and laparoscopic surgeon, obs and gynae, consultant at Rajinder Nagar Hospital and Morpheus Fertility Center, Lucknow. Welcome, ma'am. And now I'm going to announce the name one by one for the oral presentation. And in this series, I am calling the first name Dr. Juhi Bharti. Ma'am, please present your oral presentation. Your time starts now.
I'll just be sharing my screen. Is it visible?
Yes.
Okay. Sorry. So good afternoon, my judges and others who have joined. So I'm going to present the study on prescription practices in pregnancy after assisted conception, a multicentric study done by a working group of early pregnancy special interest group IFS. So today, it is a generation of evidence-based medicine, and evidence-based medicine has regarded the physician's experience as the lowest form of evidence. So professional experience might have been biased when the physician's experience was limited to a single doctor. However, nowadays, because of advances in computing and informatics, makes it possible to access and analyze the collected experience of tens of thousands of physicians caring for hundreds of thousands of patients, in fact, far more patients than could be ever enrolled in a single clinical trial. Consequently, the Howard Karp says that choice of treatment can be focused on issues of clinical practice where choices for an individual patient should be centered. So whenever we start any
ART cycle, and then we have pregnancies. We always are in dilemma, despite we have plethora of evidence on all these subjects, but we feel that what is the ideal method of luteal phase support, and what is the ideal progesterone dose, route, duration, whether to give other adjuvants to this patient or not, and when to start and exactly stop. So keeping these in mind, we decided to have this study. The aim was to review, just to review the prescription practices of fertility specialists across the country. The primary objective was to review the medications or drugs prescribed to women who conceived after in vitro fertilization, fresh or frozen embryo transfer in ART centers across India. Secondary objective was to review these medications and after embryo transfer, after documentation of pregnancy, and to those prescribed at 12 weeks period of gestation. It was an ambispective observational study done at multicentric, and the ethical clearance was first obtained from Indian Fertility Society Ethical Committee. All the pregnancies following IVF were included in this, whose details and prescriptions of patients diagnosed with pregnancy that continued beyond 12 weeks of gestation were available with us. The centers not willing to provide information on prescription or those with missing details were excluded. So first, after obtaining ethical clearance, requests were sent out to multiple centers. Finally, 9 centers participated and gave us roughly 310 patients. So it included the centers over New Delhi, Chandigarh, Bareilly, Kerala, Chennai, Jaipur, Patna, Lucknow. And 131 patients we have currently excluded because of incomplete data. And the eligible pregnancies included in interim analysis are 179 patients as of now. So after this, we did the statistical analysis, which is still going on, the individual patient data meta-analysis with the source being prescriptions. At least 30 prescriptions for a single center were asked for the data to be significant, and the prescription was then reviewed. So out of 179 patients, we saw that the baseline characteristics were mean age of 33.78 years, duration of infertility, the mean duration was 5.9 years, mean BMI 25.1 kg per meter square, the mean serum FSH, LH, and AMH were 6.8, 5.7, and 4.2 respectively. On doing the analysis of our primary and secondary objectives, the medicines, when we saw what are those prescribed at embryo transfer, we saw that 100% of them received folic acid and almost 94% received ecosprin, 98% received estradiol, almost 78%, 76% received prednisolone, 80% received dydrogesterone. So almost 90% patients received progesterone, also micronized progesterone. And we'll have a graph which will highlight these things later. 28% had HCG and almost 84% patients had lower molecular weight heparin. These medicines were then continued till 4 weeks post embryo transfer, that is till documentation of cardiac activity. And these same medicines continued at every center. And just the steroids and estradiol were tapered after documentation of fetal cardiac activity. So till 12 weeks, we saw that again, we'll have this in graph. So here we can see that almost folic acid and ecosprin and low molecular weight heparin is continued, but the estradiol and prednisolone was stopped. All of them received some form of progesterone. So it was that such that till 12 weeks, the patients continued receiving progesterone in some or the other form. We'll see the combination that were prescribed more often in the next subsequent slides. And then injection HCG was given in only 20% and mostly those in FET cycles. The low molecular weight heparin was given in 43% after fetal cardiac activity was demonstrated, but still almost 40 to 50% patients received this till 12 weeks period pregnancy. So on further subgroup analysis, we saw that only 21% of physicians, like only 21% of patients received one progesterone. But mostly almost 80% of patients received either 2 or 3 types of progesterone, and out of which the most common form of progesterone was dydrogesterone, along with any form of micronized progesterone. Like 67 out of 80 received intramuscular or subcutaneous micronized progesterone, and 12 received vaginal. Few of them also used progesterone gel. And there are 33% patients who received 3 forms of progesterone, dydrogesterone plus micronized and in the form of gel. So what the evidence says is that progesterone support is important, but Esri says that only any non-oral form is good enough, and it is recommended, but this is good enough for luteal phase support. So we have, but there is no ideal progesterone we can choose between among these available preparations. And but despite the evidences available, all of us know that there is always a discrepancy between the evidence-based medicine and real-life practices. This is a paper highlighting the same from 2020, and shows that 80% of clinicians gave vaginal progesterone, but there were others who gave vaginal plus oral or vaginal plus intramuscular. So and also the dose varies, as we saw what is the recommended as compared to the recommended dosages. So apart from this, there is no consensus on ideal progesterone for luteal phase support among the clinicians. And also there are various other questions like when to start and when to stop. Ideally, it should be stopped at the documentation of it.
Dr. Juhi, your time is up. Please wind it up fast.
Yeah. Also, there is no evidence on steroids and heparin. Just wanted to highlight that all these things are important, but sometimes we have to individualize and we have to see and how to interpret the data. And based on other studies, we can see that the route and dose is variable according to the type of cycle and patient, and more than one may be beneficial in selected cases, like high BMI, low progesterone levels, and in some cases, the HCG can be given. And all the regarding adjuvants, there's clearly no guideline to give the estradiol and the steroids or heparins, except in some exceptional circumstances. Thank you.
Okay, thank you, Dr. Juhi, for the wonderful presentation. It's a good study. The only question that I want to know is that did you compare the frozen embryo transfer cycles, the prescription luteal support versus fresh embryo transfers, or you combined? I mean, you did not segregate them.
The ones that I have presented here, this is a combined one because there were 30% of FET cycles in this group. And also this is the interim analysis. We are planning to do the subgroup analysis of all, but whatever it is, frozen or fresh, I completely agree we have to do the subgroup analysis. But then we saw that there is no indication otherwise also in giving 2 or 3 types of progesterone, depending on whether it is fresh or frozen. So just the idea was to see, what is the practice.
The screen has been muted.
Yeah. So actually, what is your say? Whether we are going to use 1 or 2? Because I mean, you already have seen, you have already analyzed that everybody is using 2 or even more than 2. So what is your say? Like we are already talking 1 progesterone for all. So what is your say?
So ma'am, ideally we should use 1 form of progesterone. We also have seen many papers coming on progesterone-induced hepatotoxicity. So 3 progesterone is a big no, what I feel. But yes, there are questions like addition of 2nd progesterone is beneficial. Many studies coming like that. Is beneficial in certain patients like those with high BMI or those having low progesterone on the day of transfer. So maybe in some patients we can individualize and add 2nd progesterone, but definitely not 3, ma'am.
Does the route of progesterone also make any difference? Administration of progesterone?
Yes, ma'am. So ma'am, what Eshre
I mean,
says,
is injectable better than the orals or what?
Okay, so ma'am, what Eshre says is any non-oral form is to be given. So only oral is not to be preferred. Others can be given. All of them have similar results. So, but then again, the choice can depend on other things, not because of the results, but because of the patient's acceptability, then taking injections, feasibility, all those things.
Have you tried to compare the outcomes, the final outcomes? Does it affect the outcomes in terms of clinical pregnancy or live birth rates?
Okay, so ma'am, because our main objective of this study was to review the prescription practices. The outcome we did not keep in this because there are so many confounding factors for the pregnancy outcome. So that will require very, very large number of data to have the subgroup analysis. It will not come as statistically significant. And apart from that, we already have available evidence reflecting upon the live birth rates and all those things. We just wanted to highlight what is the evidence and what is the prescription practices that we are following.
Okay, thank you so much. Wonderful presentation.
Thank you so much, ma'am. Thank you.
Thank you, Dr. Juhi, for the wonderful presentation. And now I'm moving towards the next, Dr. Astha Lalwani.
Yes, ma'am.
Yes, ma'am. You can start your presentation.
Just share your screen.
Juhi, have you stopped your, please stop sharing your screen. Yes, welcome Astha. We can see your screen, but are you muted? Unmute yourself.
Oh, the host muted me. It's coming. Yeah.
Okay.
Just
I'll give you a bonus of 15 seconds. You can start now from the first slide.
Ma'am, just a sec. My slideshow is not working. Yeah. Okay. Yeah. Here I go. A very good afternoon to all esteemed judges there and all my senior faculty members. So the topic for my paper presentation is factors affecting the response to clomiphene citrate in the subfertile patients with polycystic ovarian syndrome. It's a prospective cohort study. So as we all know, PCOS falls in the category of WHO type 2 anovulation, normogonadotrophic, normoestrogenic, and accounts for almost 85% of anovulatory females attending our OPDs. So clomiphene citrate is a drug being used for several years, but still there is an enigma as to why some patients, they respond to this simple treatment so well in first click, otherwise few definitely not, as the dose keeps increasing still. The prevalence found of resistance is almost 40% sometimes. Hyperandrogenism, obesity, insulin resistance, metabolic syndrome, and other endocrine abnormalities, they are a proven association of PCOS. But whether these factors are actually predictors as a response to treatment is still a dilemma. And what is the strength of this association, if so, is still another question. Studies done till now are a limited, giving a limited and a variable evidence about these factors which influence the response. So I did this study to analyze various clinical, hormonal, and ultrasound parameters in predicting the response to clomiphene. So I just took 75 patients attending OPD with diagnosed PCOS as per the Rotterdam's criteria, anxious to conceive, from the age group of 18 to 40 years. After excluding other causes of anovulation, after taking a detailed history and examination, and also the women on any other insulin sensitizing agents or with other endocrine disorders known or diagnosed while workup, like hypothalamic or pituitary dysfunction, were excluded from the study. The parameters recorded were clinically, I mentioned about the age, the cycle of the periods, BMI, modified Ferriman-Galway score. On hormonal assessment, I took LH to FHS ratio, serum-free testosterone, anti-Mullerian hormone, and fasting insulin for those patients. And ultrasound, I took two parameters, that is antral follicle count and ovarian volume. According to WHO expert committee in 2004, this proposed BMI cutoff were revised for Asian population. So I used them for my study. And this excessive hair growth was evaluated by modified Ferriman-Galway score. Baseline transvaginal scan was done by the same observer. I used Siemens Acusen S2000 ultrasound machine, TVS Pro frequency from 5 to 7 megahertz. Ovarian volume and AFC was calculated as per the protocol. All patients were given 50 milligram of clomiphene citrate from day 2 to day 5 in increasing doses till 150 milligram in 3 consecutive cycles. Ovulation was documented by transvaginal scan, and 2 groups were made on the basis of absence or presence of ovulation. The further analysis conducted, I used IBM statistics with unpaired t-test, comparing various parameters between clomiphene sensitive and clomiphene resistant group. Further, I applied univariate and multiple logistic regressions to study the predictors and their association. ROC curve was used to assess the sensitivity and specificity of each predictor, keeping the level of significance at a value of less than 0.05. So the results, clinical and hormonal characteristics, if we see in both the groups, as it's clearly reflected, the BMI has a significant association. Ferriman-Galway score also, LH to FSH ratio, serum-free testosterone was significantly, it's 0.01, even lesser than that p-value. AMH and fasting insulin all showed a statistically significant difference when I compared the 2 groups between clomiphene resistant and sensitive. The As we can see in this, the ultrasonographic characters are compared in both the groups. In patients, 58 were clomiphene sensitive. In the earlier slide also it was reflected. The resistant were 22. So the mean ovarian volume and mean AFC, both were actually found on unpaired t-test. I found both of them having an association. It was clinically significant. When I put the univariate analysis to predict this response, I can see that BMI was still carrying a significance. Ferriman-Galway score was still carrying a significance, but LH to FSH ratio lost its significance. Serum free testosterone and AMH still stood out to be predictors in giving a sensitivity of almost 0.006 and 0.001. And mean AFC, antral follicle count, also stood out as a significant parameter in deciding the responsiveness to clomiphene. In multivariate, BMI, Ferriman-Galway, serum free testosterone, AMH, and mean AFC were again having a strong association, on the basis of which it was decided that yes, these patients are going to respond, or these patients are not going to respond to the clomiphene citrate. When I put AUC area under curve, I can see that sensitivity and specificity for each and every parameter was actually wide different. But out of them, when we talk about testosterone and Ferriman-Galway score, starkingly, they are actually carrying most of the specificity and sensitivity with p-value markedly significant. Various studies, when I was going through, Rosenfield et al. Also found the similar results when he took hyperandrogenism as a good predictor of clomiphene citrate resistant with high AUC curve value. And he used actually additional criteria of androstenedione. Increased androgens, as we know, they convert to estrone in peripheral tissues, which provide negative feedback and decrease FSH and results to anovulation. Hamed et al. Also found significant differences. He used another parameter as ovarian stromal artery pulsatility index, but still in his study, the total testosterone was the individual best predictor for clomiphene citrate treatment response. As we all know, high AMH values, they actually inhibit the ovulation because they inhibit the FSH action and the FSH receptor response. So many patients with high AMH and high other ovarian reserve parameters, they have found to have a failure rates with clomiphene citrate. But still more studies are required to establish which one is the best ovarian reserve marker, which still is, it's like a dilemma, it's like a point of debate. So as we all know, PCOS is associated with insulin resistance and marked metabolic disturbances. Still, many studies, they don't link many other parameters of metabolic or endocrinopathies except insulin resistance. Many studies have done which have shown that cholesterol, if it is raised or if it is deranged, those patients are also at a risk of clomiphene citrate resistant, as is shown in the study, a beautiful study done by Baptiste et al. So actually, I have a strong point to conclude that before starting any patient, pre-pregnancy BMI has to be come to a normal range, and also the signs along with clinical and biochemical parameters have to be definitely assessed. If the patient is giving you on examination the signs of hyperandrogenism by lifestyle modification and exercise, an insulin sensitizing agent should definitely be added to optimize the success of clomiphene citrate, because patients keep on, in many, we don't have IVF, I don't practice IVF, but I just thought of putting this word because we just keep on giving ovulation induction without bringing the patient to a normal BMI or without testing for the other things. So the limitation is definitely there with this study, as it's not correlating the parameters with live pregnancy rate, but it's only with ovulation, and we have so many other factors which actually interfere with the live pregnancy birth rate. So, and also the sample size I took is quite less, it's 75, but and this is different studies which I have taken my references from. Thank you so much. Thank you so much.
Thank you, Dr. for the wonderful oral.
Okay, can I ask something? I mean,
yes, ma'am. Yes,
yeah,
ma'am.
Dr. Asta, it was a wonderful, excellent study that you have done.
Thank you.
I just see that you have included the age group from 18 to 40.
Yes, ma'am.
Just tell me, how do you define elderly women?
Yes, ma'am. Actually, the thing is, I took this because the sector where I'm working, ma'am, I'm in Muradabad. It's like not a very big city. So patients are coming, at the age of even 38, they are coming with secondary infertility. Ki doctor sahab, bacche chahiye. I'm in Muradabad, so they are actually grandparents. So I have to involve 40 years, and definitely it will be a reflection. AMH will be definitely, it's not comparable between the age group of 18 and 40.
Correct.
But the thing is, ma'am, I've seen the patients, the PCOS is coming till 35, 38 years of age. Patients are coming with diagnosed PCOS. I don't know how. So that's why I was having this doubt whether I'll be able to do a justice with my study, because AMH is a wide array here from here and there.
So what you can probably do is,
Yes,
within
ma'am.
this study, you can demarcate and try to find out the difference between young PCOS and elderly PCOS.
Okay, yeah, that's
Yeah,
correct.
so that will give you a better difference, because you can't take a composite, I mean, you can't come to a good conclusion, because that serves as a confounding factor.
Exactly, that is
then
actually
PCOS, and
confounding
you
factor.
said there are people with secondary infertility also.
Yes, ma'am,
So
sure.
you need to exclude them out also. So primary infertility, secondary infertility, young PCOS and elderly PCOS, because the hormone profile totally changes in an elderly PCOS.
Exactly, ma'am. So the thing is, ma'am, actually, first of foremost, AMH ka, I was not getting much of the as a predictor in all patients. I was not doing before giving them ovulation induction. But then, ma'am, I just thought to put this short study for 6 months, because at that time I was not getting good results. So the thing is, I assume that if she's a grand multi, definitely her ovarian reserve has to be good. But then, as you are correctly saying, that subgroup has to be made, on the basis of that,
You'll find out a very good difference between the two when you do that.
Yes, ma'am, that's true. Thank you so much, ma'am, for your feedback.
I guess we move on to the next, because the time is up.
Okay, ma'am. So the next is Dr. Giovin Ranji. Ma'am, you can present your paper.
Good afternoon, ma'am. I'm Dr. Giovin Ranji from Institute of Reproductive Medicine, Madras Medical Mission, and I'll be presenting my study on pregnancy outcomes following frozen day 4 transfers in comparison with frozen day 3 and day 5 embryo transfers. At present, day 3 and day 5 embryo transfers are done in many reproductive centers during assisted reproduction. Recent studies show that day 4 embryo transfers are easier, flexible, and a useful option. We all know that the day 5 embryo transfers, the blastocyst before implantation has been believed to give the best embryo selection. However, only a limited number of embryos reach the blastocyst stage in vitro, even with the most advanced sequential culture media. In clinical practice, not every patient has healthy blastocysts on day 5 or day 6. Hence, in terms of embryo selection, the morula or compacted embryo could have better selection value compared to the earlier cleavage stages. Not only they have the activated embryonic genome, but the morula also indicate the further advanced stage, that is the compaction stage. So hence, we did the study to compare the pregnancy outcomes, namely clinical pregnancy rate, early spontaneous abortion rate, ectopic pregnancy rate, multiplex pregnancy rate, live birth rate, and preterm delivery rate between day 3, day 4, and day 5 of embryo transfers. This was a retrospective comparative study. We included the subfertile women who underwent IVF in our institute in Chennai. The fresh embryo transfers were excluded. This period of study was 2 years from 2017 to 2018. Women who came for treatment were evaluated, and who required treatment with IVF were stimulated from the secondary using HMG, recombinant FSH, or highly purified HMG. The starting dose ranged from 225 to 300 depending on the patient's age, ovarian function, as well as the response to previous ovarian stimulation. Standard fixed antagonist protocol was started from day 5 of stimulation. Trigger was given when 3 follicles reached or more than 17 ml using HCG alone, or in selected patients using dual trigger HCG and triptofan. Oocyte retrieval was done 35 hours after trigger. IVF-HC was done within 3 to 4 hours of oocyte retrieval. Fertilization was observed 20 hours after insemination based on the appearance of 2 polar nuclei. The embryos were cultured in G1 and G2 medium at 37 degrees Celsius under dry gas. Fertilized embryos were frozen using ketacytovitrification media, and the embryos were graded according to Gardner and Schoolcraft grading. Patient was asked to come in the subsequent cycle for endometrial preparation. Endometrium was assessed by serial ultrasound scans in natural hormone replacement or stimulated cycles. When the endometrial thickness reached a satisfactory level, progesterone injection 100 milligram intramuscular was started for 4 to 6 days. Accordingly, the frozen embryos were thawed, cultured, and transferred. Luteal support was given with progesterone injections and oral dydrogesterone tablets. Pregnancy was confirmed with the serum detailed CG done 16 days after embryo transfer. The early pregnancy ultrasound was done after a week. An antenatal care was given, they were followed up to delivery. The primary endpoint of our study was live birth. And the pregnancy outcomes, namely clinical pregnancy rate, early spontaneous abortion rate, ectopic pregnancy rate, multiple pregnancy rate, live birth rate, and preterm delivery rate were calculated. Data were entered in Microsoft Excel software and analyzed using Stata version 14. Age, BMI, and duration of subfertility were summarized in mean and ST. Fisher's exact test was used, and p-value less than 0.05 was taken as significant. The results: we had 129 subfertile women who underwent IVF treatment and 211 cycles of frozen embryo transfers during the period of the study. The mean age of them was 32.88, BMI was 26.9, and the mean duration of subfertility was 6.8 years. Among the study population, 85 had primary subfertility and 44 had secondary subfertility. According to the day of embryo transfer, 6 had day 2 embryo transfers, 137, 64.9% had day 3, 47 had 22.3% had day 4 embryo transfers, and 21.9% had day 5 embryo transfers. Of the results, the clinical pregnancy rate of day 3 was 39.4%, day 4 was 34%, and day 5 was 42.9%. The p-value was 0.665, meaning that this was similar. The early spontaneous abortion rate in day 4 group was 6.2%. Comparably, in day 5 was higher, 22.2%, in day 5 was 33.3%, and it was reaching a better significance value, but not up to 0.05. The ectopic pregnancy rate on day 3 and day 5 are comparable, and there were no ectopic pregnancies following day 4 embryo transfers in our study. The multiple pregnancy rate was almost similar in all the 3 groups with p-value of 1.0. The live birth rate of day 3 embryo transfers were 23.4%, day 4 was 23.4%, and day 5 was 28.6%, meaning that all the 3 groups were comparable. The preterm delivery rate was less in day 4 embryo transfer group, 18.2%, when compared to the day 3, 43.75%, and day 5, 33.3%. In our study, the clinical pregnancy rate and live birth rate of day 4 embryo transfers is similar to the day 3 and day 5 embryo transfers. This is similar to the other study by Zhang et al., Zhang Ming et al., and Liu et al. Physiology behind the day 4 embryo transfers. There are 2 possible reasons underlying the increased pregnancy rate. Firstly, because the expression of embryonic genes is initiated on day 4, and thus embryos with higher developmental potential can be selected after day 4. Secondly, the uterine contractility is reduced at day 4, giving us an improved synchronicity. The favorable outcomes we observed in our study were there were no ectopic pregnancies, lesser early pregnancy loss, lesser preterm births. This was similar to the study by Lee et al., in which the term birth rate was almost 100%. Also in the study by Tang et al., it was better than day 5 embryo transfers, 95.7%, and they had a significant p-value. The multiple pregnancy rate, there was no significant difference. In a similar study by Zhang et al., they also found the twinning rate was not statistically significant. The limitations in our study are the sample size is small, so the results will become better, significant with further validation, and we need a validation and scoring system for day 4 embryos. To conclude, the key aspect to increasing the success of IVF cycles was the ability to choose the most promising embryos for transfer. Performing an embryo transfer at the Morula stage will serve to facilitate and allow for flexible management of the cycle for both the patients and clinicians. Our results show that the day 4 embryo transfer is not inferior to day 3 and day 5 embryo transfers. Day 4 embryo transfer could be complementary to our current transfer strategy. These are my references. Thank you for your patience here.
Thank you, Dr. Zobin, for a wonderful presentation. I mean, it's an eye-opener. I had also read many papers regarding this, that day 4 embryo transfer is not inferior to day 3 and day 5. what is your take at your center? I mean, are you promoting day 4 transfer at your center?
Yes, ma'am. After this study, we have found that the day 4 was not inferior, but we do have until 2021, we have an increased number of day 4 embryo transfers. So we expect much better numbers with an increased p-value. Like we hope that our further results will add to the p-value.
Yes, we can have multicentric study on that, and we can really have a good data on this day 4 embryo transfer, giving 5 days progesterone to them.
Yes, ma'am.
Yeah. Very good presentation.
Dr. Giovin, how many embryo transfers you were doing on day 4? Did you set any? I mean, did you set some limitation that not more than 2 or 3 day 4?
We had
how many
maximum
embryos?
of 3. We had maximum of 3 morulas on day 4, ma'am, but we did not have set a maximum limit.
Okay, so day 3 also you were putting up to 3, and day 4 also you were putting up to 3. And what about day 5?
Day 5 maximum of 2 blasts, ma'am.
Maximum of 2 blasts. And did you notice, I mean, though this doesn't come in your study, but did you notice the, I mean, whatever the embryos you had put and the remaining embryos, you must have left them to blast. So did you notice some degree of fragmentation, or the number they were decreasing when they were left from day 4 to day 5? When was your significant degree of fragmentation you noticed? From day 3 to day 4 or day 4 to day 5?
Day 4 to day 5 we had noticed, ma'am, but it was lesser number. So I'm not able to tell confidently, but definitely from day 4 to day 5, the degree of fragmentation was higher, ma'am, compared to day 3 to day 4.
So you conclude that fragmentation starts on day 4, mainly.
After day 4, ma'am.
Yeah, after your study.
Yes, ma'am.
Okay.
Can I quickly ask one thing, please?
Yes, ma'am.
If permitted. Okay, Joven, excellent presentation, and yes, it's a new thought process that we can implement on a routine basis too, of course, based on multicentric trials. But then on day 4, when you transfer, we need to standardize our gradation on day 4. But then did you notice then they were good compaction stage, or whether it was just about 10 to 12 to 14 stage morula? So did you see any difference between when you transferred a good compaction and just about say 12 to 14 cells on day 4?
Yes, ma'am, you rightly asked. It was always that good pregnancy rate was observed with good compacting embryos. We did have 12-celled embryos on day 4, but as you said, it did not progress. Ma'am, we were not able to tell specifically because at least one good quality morula was there. So if that 12-celled became or this good quality became, I was not able to tell according to this study. But yes, ma'am, only those good compacting morulas had clinical pregnancy rates. Thank you.
Thank you. Thank you so much.
So thank you, Dr. Jovin and everyone else. Now I'm moving towards the next Professor Sanjana Vadva for the oral presentation. Dr. Sanjana Vadva, please unmute yourself and share your screen.
Yes, I'm doing. Is my screen?
Yeah, go back to the first slide. Your screen is visible. Yes.
Good afternoon, all. I'm Dr. Sanjana, bringing greetings from ESI Basaidarapur. I'm today presenting a paper on effect of intrauterine installation of granulocyte colony stimulating factor on thin endometrium in infertile women under the guidance of Dr. Leena Vadva, Professor IVF in charge. As we all know, the normal endometrial thickness ranges from 7 to 14 millimeters in normal menstrual cycle, with maximum endometrial thickness around 8 millimeters at the time of ovulation or HCG trigger. As per 2019 Canadian Fertility and Andrology Society, the thin endometrium in assisted reproduction is defined as endometrial thickness less than 7 millimeter. The incidence of thin endometrium in ovarian stimulation can be as high as 15 to 38 to 66%, and the incidence of thin endometrium in IVF is between 1% and 2.5% in most studies. There has been multiple various adjuvants that has been used in thin endometrial patients. Granulocyte colony stimulating factor is one of those adjuvants which has shown effective in embryo implantation as it increases Th2 cytokine secretion and regulatory T cell stimulation. Our research question was, does intrauterine installation of granulocyte colony stimulating factor in infertile women with thin ET undergoing natural monitoring or controlled ovarian stimulation improves endometrial thickness and pregnancy rate? The hypothesis was that intrauterine installation of GCSF in infertile women with thin endometrium undergoing natural monitoring or controlled ovarian stimulation will increase endometrial thickness more than 7 millimeters and may increase the pregnancy rate. The aim of the study was to assess the increase in endometrial thickness after intrauterine installation of GCSF in infertile women with thin endometrium less than 7 millimeters undergoing COS or natural cycle monitoring, and to assess the increase in pregnancy rate after the intrauterine installation of GCSF in infertile women with thin endometrium undergoing COS and natural cycle. It was a prospective interventional cohort study done under IVF and Reproductive Center, ESI PGI Basaidarapur, Delhi. We started in March 2019 and it's still ongoing. Informed written consent was taken. DGCI and Institutional Ethical Committee clearance was taken. Analysis done on SPSS version 21. Our inclusion criteria were women with primary or secondary infertility undergoing natural or controlled ovarian stimulation cycle with thin ET less than 7 mm on day of trigger, previous cancelled cycles for thin endometrium, 20 to 30 years aged. Exclusion criteria included contraindications for GCSF installation. We took the study of Tehra Nijad as a base study, who observed GCSF improved thickness from 3.3 to 6.1 millimeters and had calculated a sample size to be 60. Ovulation induction was done. Regular transvaginal ultrasound and follicular monitoring was done with dominant follicle of 18 millimeters. Injection HCG was used as trigger. In cases with endometrium less than 7 millimeters on the day of trigger, 300 units of GCSF was instilled in the uterus. Post 36 to 40 hours, endometrial thickness was noted on ultrasound and IUI was done under aseptic precautions. In our present study, 200 controlled ovarian stimulation IUI cycles were analyzed. 17 cycles showed thin endometrium less than 7 millimeters and GSS was instilled, making the incidence of thin ET of 8.5%. On demographic characteristics of women with thin endometrium, the average age was 29 years, with primary infertility accounting for 70% of cases and average duration of infertility of 6.4 years. Ultrasound parameters for infertile women with thin endometrium undergoing COS cycles, the average number of follicle on the day of trigger was 1. Average day of cycle for follicle maturation was day 11 plus minus 1. The mean endometrial thickness on the day of trigger was 6 millimeters plus minus 0.6. The AMH anti-Mullerian hormone mean 6.4 in our study. 59 cases were had ovulation induction done with letrose, 41 with clomiphene citrate. Patient compliance and acceptability during and after GCSF installation. 100% of our cases had no discomfort. It was an easy installation with 100% acceptability by our cases. Endometrial thickness, on comparing pre-GCSF and post-GCSF, as we can see in the chart, there was, though there was the rise in the endometrial thickness post-GCSF noted, but it didn't reach the statistical significance. In unexplained infertile women, the mean endometrial thickness pre-GCSF on the day of trigger was 6 mm, and the mean ET post-GCSF installation was 6.3. Our study failed to demonstrate the increase in clinical pregnancy rate associated with GCSF installation. On reviewing the literature, a recent study published in 2019 on granulocyte stimulating factor in COS IUI cycles, it studied 50 cycles which showed thin endometrium and they instilled GCSF. The chemical pregnancy rate was 32%, intrauterine pregnancy rate 28%, and ectopic 4%. The study concluded that GCSF installation improves pregnancy rate and increases endometrial thickness. Another recent study of April 2021, it studied 50 patients in IUI cycle having endometrium thickness less than 7 millimeters on the day of trigger. And they also instilled intrauterine GCSF with IUI catheter. The study showed that endometrial thickness was improved in all the patients and they reached a significance value. And they had 8 patients UPT positive out of 50. Thus, the study concluded that GCSF intrauterine installation has potential to improve endometrial thickness and pregnancy outcomes in IUI cycle. In a systemic review and meta-analysis done in 2017, this review included 1525 cases in 7 studies. This didn't find the difference in endometrial thickness between women who conceived and women who didn't conceive after GCSF. On reviewing the literature on thin endometrium and ovarian stimulation IUI, this meta-analysis concluded the patient undergoing ovarian stimulation with thin endometrium may be counseled that the effect on pregnancy rates is unclear. Thus, to conclude, thin endometrium is still a challenge in assisted reproduction. In this present study, there was increase in endometrial thickness, but it didn't achieve statistically significance. Study fails to demonstrate increase in clinical pregnancy rate. But since our study is an ongoing study, maybe in near future, we might, since the larger number of sample size, we might have some difference in the outcomes. And thus, to suggest a small cohort of the study, further studies with larger samples are required to substantiate the use of GSF in thin endometrium. Thus, we have to stay positive, work hard, and then make it happen. Thank you.
Wonderful presentation, Dr. Sanjana. And now if we have time, we can have the question. Dr. Shalini ma'am.
Yeah. I'm little not convinced, Sanjana, with your method of selection. And I mean, because see, there's so much heterogeneity, normal ovulating, then clomiphene, then letrozole. Because what happens is at times the endometrium picks up on its own the day you give the trigger and the day you do the IUI. Right. So as such, there is no control in your studies. And are these patients who are resistant, who are persistently showing thin endometrium, or it is the first cycle of clomiphene, or did you again segregate?
No, ma'am, we have enrolled the patients. These are the patients who have either have done IUI previously and on thin endometrium and they have not had pregnancy. Most of the patients have been enrolled on that basis that the previous endometrial thickness we documented in our institute was thin at the time we did IUI in the previous cycle of ovulation induction, ma'am.
Okay, so even in the previous cycle, you noticed thin endometrium and not in the natural cycle, right? So it could be the effect of the drug also, and which probably could have led to bias in the study.
Ma'am, point noted. Since it's an ongoing, we can add controls and we can just evaluate that point that you have given. Thank you so much, ma'am.
Yeah, definitely. Otherwise, it's a good study, ongoing study. I appreciate your efforts. And
thank you, ma'am.
Dr. Bindu and Dr. Sunita, maybe you can ask.
I mean, I had the same question. That's fine. I mean, good. Nice presentation, Dr. Sanjana.
Thank you, ma'am. Thank you so much, ma'am.
Okay, we are good to go for the next one. Or Dr. Sunita, you have some question?
Oh, no. Actually, I have stopped using GCSF. Not completely, but I think I feel PRP is better than GCSF. I started using it around 7-8 years back, and initially I thought the results are good, but then I found that it is of no use. So I had presented my paper last Fertivision PRP, and I'm still doing PRP studies continuously. So I feel now PRP is better than GCSF. Let's see what comes out.
Yes,
yes, many studies have reported that GCSF installation has really no benefit. And certainly not with respect to the pregnancy rates.
Okay, so
it does not extrapolate to a better pregnancy rate. Okay.
Thank you, everyone. And now moving towards the next, Dr. Rita Mahi. Ma'am, you can share your screen and start your presentation.
Good afternoon, everyone. I will be presenting the serum AMH levels among different PCOS phenotypes and its correlation with clinical endocrine and metabolic markers of PCOS. So as we all know, PCOS is the most common endocrinological disorder of reproductive age women with a prevalence of 6 to 20%, and almost 75% of these patients, they have infertility due to chronic anovulation. So we have a lot of things regarding the diagnosis. We have different criteria, but we have been using Rotterdam criteria in all the adult women for diagnosis of PCOS. But the problem with this is that now we have, according to the latest international guidelines for the PCOS, that it is not only the Rotterdam criteria, we have to define these phenotypes also. The phenotypes are taking importance when we treat these patients, where phenotype A is the most severe form, where it has all the 3 components, and phenotype B is the least severe form, which is normoandrogenic. But now there is a lot of problems with the diagnosis of PCO component, the PCOM component, because initial Rotterdam criteria with these baseline ultrasound machines, it was cutoff of 12. But now a lot of studies are coming that because we have better quality of ultrasound machine with detailed resolution, so now the cutoff should be 20, 28, even some studies have shown. But the recent guideline has adopted that now if the ultrasound machine is more than 8 megahertz, so the cutoff should be 20 follicle number per ovary to diagnose PCOM. But still it is not clear, because some studies are contradicting now that are we really happy to delete those patients where AFC is 12 to 19. So still this question is unanswered. We need more data. So, and since last almost 10 years, we have been struggling that whether AMH can replace as a surrogate marker of PCOM to diagnose PCOS, because lot of ultrasound, these variations are there, subjective variation, the person who is doing the scan and the availability of ultrasound, but still the guideline has not accepted AMH as a surrogate marker to define PCOM morphology for diagnosis of PCOS. So the data is sparse from the women of Indian ethnicity, especially among all the Asian countries, on exact distribution of AMH among different PCOS phenotypes, and what is its correlation with clinical, biochemical, endocrinological, and metabolic marker, and with the diagnostic cutoff of AMH for AFC. So and there is a lot of inter-observer bias and differences in the resolution of ultrasound machine. So we definitely need a marker which can be used as a surrogate marker of PCO morphology. So our study question, my study was, can serum AMH be a surrogate marker for PCOM for the diagnosis of PCOS, and what is the relation of AMH with clinical endocrinal metabolic markers of PCOS? It was a single center retrospective study in AIIMS New Delhi over a period of almost 5 years. Database of all the prospectively collected patients were analyzed. All the clinical, endocrinological, metabolic marker and ultrasound data was entered in the Excel sheet, and the analysis was done. And we had a control group also, which was taken from the database of infertile patients who are coming to us for tubular male factor infertility. So the PCOS women were divided into 5 AMH pentiles according to the levels like 5, 5 to 10, 10 to 15, 15 to 20, and more than 20 nanogram per ml, to understand what is its correlation with different PCOS marker. And then AMH distribution was also seen among different PCOS phenotypes, and the comparison was done with the non-PCOS cohort, and we see among the different AMH pentiles. So the standard statistical methods were used to analyze the data, and ROC curve analysis was done to find the discriminatory level of AMH for diagnosis of PCOS, and multivariate logistic regression was done to see what is the discriminatory power of different methods to diagnose PCOS. So we had total 1300 patients, out of which 154 were excluded due to incomplete data. And finally, we had 608 PCOS women and 538 non-PCOS women. And where we can see, because most of these patients, these are infertile patients, those were coming to us, that 45% were PCOS A, followed by PCOS D, and then B and C were less because they don't come for infertility treatments. So here is the baseline parameters of PCOS and non-PCOS. We can see the BMI is significantly higher in the PCOS group, and AMH is also the mean AMH of the whole PCOS cohort was 12.3 as compared to the non-PCOS where it was 3.3. So then we divided the AMH among different phenotypes, where we can see the PCOS A had higher levels, but the PCOS B had significantly lower level of this AMH level, because that is also explainable because it is the phenotype with non-PCO morphology. So because of that, the AMH levels were less. So now coming to how we classified into AMH pentile. So if we can see that in phenotype A, the mean AMH is highest, 13.28, and the phenotype B has lowest this AMH levels. Then if we can see the patients who are more than 20 nanogram per ml, most of these patients are lying in phenotype A. And then if we can see the whole presentations, most of the patients, they had AMH levels between 5 to 10 and 10 to 15. So this is a normal range of patients where the AMH falls if they have PCOS according to Rotterdam criteria. And then we correlated the AMH levels in the AMH pentile with difference. So we can see the total cholesterol and follicle number per ovary, they had significant correlation. So as the AMH rises, these parameters also rise. Similarly, cycle length, LH, LH-FSH ratio, testosterone, they also have positive correlation. So this is the picture we have shown that all the patients had significant correlation. So as the AMH is rising, the duration of cycle is increasing, AFC is increasing, testosterone is increasing, and metabolic dysfunction is increasing. So then ROC curve analysis was done to discriminate the AMH level. So this is the 6.06 nanogram per ml can be considered as a diagnostic cutoff of diagnosis of PCOS with sensitivity of 91.45% and specificity of 90.7%. So then on different multiple markers, logistic regression analysis, like which parameter are the best this. So it is AMH and AFC, they had shown the minimum parameter to diagnose PCOM with area under curve of 0.98. So after so many these studies, still we are not clear. This is the latest publication that in fertility sterility. So towards a universal serum AMH level, still we are not clear. The story is not over. So they have shown that 4.5 can be taken as a cutoff with sensitivity of 78% and specificity of 93%. But actually, all these studies are from different countries from different ethnic populations. So we cannot have these cutoff in our Asian populations. So like this study from America, they said that most of these PCOS women had AMH of more than 10. And then this in 2017, they said that 5 or more can be considered as cutoff for PCOM diagnosis. So now coming to what our Asian population says, that in Chinese population, they said that it should be a specific cutoff, 8.1 in up to 30 years and 5.8 more than 30 years. And this study is from Pakistan, where they have shown that 6.4 is a cutoff to diagnose PCOM. And the strength of the study, this is a large sample size, uniform population, first study from India, but the limit is a retrospective study, and we could not isolate the PCOM phenotype and the subjective variation because 3-4 people have done the ultrasounds. But to conclude, AMH more than 6.06 can be taken as a surrogate marker to PCOM, and high serum AMH are associated with worse clinical, endocrinological, and metabolic parameters. So these levels may be used to counsel patients regarding treatment response, individualized management, and prediction of reproductive and long-term metabolic outcomes. Thank you so much.
Wonderful presentation, Dr. Rita.
Thank you, ma'am.
I just wish to ask you one thing. It's a long-term study that you have carried out, and the methods of AMH analysis have changed.
Yes, ma'am, it is over 5 years. It is over
Correct.
5 years. So we have been using that. Yes, definitely that is one.
During the entire duration of 5 years, did you use the same kind of kit to
No, ma'am.
estimate?
No, ma'am. Most of these done were in our hospital. But definitely they have been using the kit. But for last now 3-4 years, they have used from this Ansh lab. So they are using the same kit for all the patients.
Okay, but then you cannot include all the data together because then your bias arises from the fact that the method of analysis of AMH is not the same throughout.
Yes, definitely, ma'am. That is analysis, but overall we don't have any data from India. So definitely we need to have our country cutoff, like what cutoff we should use, because the problems with ultrasound machines are too many. We can't say what cutoff should be there, and there is data also, like even the guideline has said 20 should be taken as cutoff, but still we have papers in human reproduction. They are saying that are we really happy to delete those women, those who have AFC of 12 to 19? So still it is not clear. After 4-5 years, again the guideline may come that we should be back to 12. So we are not clear what should be the AFC cutoff also.
No, your effort is absolutely wonderful and it's a genuine effort. And you're right, we don't have data from India, but what I meant to imply
yes,
is
ma'am.
that
Yeah, I understand
you can
that
make a correction for that.
Yes,
so whenever
ma'am.
we do these studies, these are bound to happen. You can't
Yes,
help
ma'am.
it because
Yes,
the kits have changed. New generation kits have come up.
Yes,
but
ma'am.
what you need to do is in your statistical analysis, you have to incorporate that. You have to make a correction in estimation.
Yes, ma'am. Yes, ma'am. It is only initial 1 year. After that, we have been using the same kit. Yeah, thank you.
Okay, good presentation, Dr. Rita. Your sample size is good. And as Dr. Bindu has already pointed out, so we need correction in that.
Yeah.
And yeah. Dr. Sunita, anything to ask, or shall we wind it up?
It was really nice, and I'm happy actually they are doing a study on this based on phenotypes, because I'm really, we were thinking to have something of this kind. There is AMH value and it is not corresponding to your protocol and all these things. So, I mean, they have started a very nice study, and now we are waiting for other results and maybe in the next conference. Let's see what is coming.
Thank you, ma'am.
So thank you so much. And we are completed with the oral presentation. And I would like to thank you, Dr. Shalini ma'am, Dr. Sunita Chandra ma'am, and Bindu ma'am for the judging the session, and all the participants who have presented the oral presentation, Dr. Juhi Bharti, Dr. Astha, Dr. Jivani, and Dr. Sanjana and Dr. Deeta. Thank you so much. So now the time is for the moving to the next session, which is, I think we have 2 minutes left with that.
Thanks to all the
We can
presenters. They
continue.
all have, they all have done a wonderful job.
Wonderful job.
Yes, wonderful.
Yes,
All
yes.
papers are wonderful.
All papers were very nice. It is very difficult to say who is best, but
Very
they all were
practical.
very nice. Very nice.
Practical papers.
Yeah.
Yes, yes.
Okay.
So now moving towards the next session, which is session 7, and is sponsored by Cooper Surgical India. We have the chairperson, and I would like to introduce Dr. Parag Nandi with us. Can we have the slide? Thank you. Dr. Parag Nandi is the Scientific Director and Chief Embryologist, Cradle Fertility Center, Kolkata. Welcome, sir. Next, we have
Thank you.
Dr. Krishna Chaitanya with us. He is a Scientific Head and Clinical Embryologist at Oasis Fertility, Hyderabad. Welcome, Krishna, sir. And next, we have Dr. Gaurav Kant with us. He's a Senior Embryologist at Akansha IVF Center, New Delhi. Welcome, Dr. Gaurav. So I would request Dr. Parag Nandi, sir, to please introduce our speaker, Dr. Stephen Fleming.
Hello, good afternoon, everybody. This is Dr. Parag Nandi. Now, I would like to introduce our well-known speaker, a great educator, Dr. Stephen Fleming. He is a very well-known figure in India as well as all over the world. He is a great educator. He is a great scientist. So he is Director of Embryology of Cooper Surgical, Honorary Associate at the University of Sydney. Previously, he was the founding Scientific Director of Assisted Conception, Australia, and a Senior Fellow at the University of Queensland. Welcome, Professor. His topic today is very interesting, and the topic is lab KPIs from lab management to patient satisfaction. Over to you, Dr. Stephen Fleming.
Thank you very much. I will try to share my screen. Okay. Out the way. And okay, I think we're good. So thank you very much for that very kind introduction. And I think I don't need this CV slide now. So I'll carry on from here. So of course, I'd like to thank the organisers, as usual, of the Indian Fertility Society annual conference, Fertivision 2021, for inviting me to speak to you today. It really is a great honour, again, to be able to participate in this conference. And I'll be talking about the use of key performance indicators in lab management for ensuring patient satisfaction. Firstly, I'll review the various performance indicators in assisted reproduction treatment and their limitations. Then we'll cover using those KPIs to monitor IVF lab outcomes as an integral part of quality management. I'll also go through the value of KPIs in training and competency using examples of their successful use. And finally, I'll summarize what we've discussed. So let's start with the concept of quality indicators. These are essentially standardized, evidence-based measures of clinical performance and outcomes that can be applied to hospital inpatient admin data. They should be able to identify potential areas for quality improvement, as well as track changes over time. Now, there have been a number of surveys of embryologists, indeed that's included a survey of alpha and ESHRE members, inquiring how many performance indicators are measured by the membership, the characteristics of the reference population that they decide to use, and the degree of importance of the various indicators. And you can see by the Vienna consensus of the ESHRE survey, that was of course held in Vienna, their relative importance was denoted by the Vienna consensus as reference indicators, performance indicators, or key indicators. And along with all of these, they provided competency and benchmark values. So performance indicators, let's start with those, they reflect the quality of sperm preparation. Interestingly, with respect to the incidence of 1PN oocytes, diploidy occurs following conventional IVF in 45 to 50% of cases. So these oocytes may appear to be monopronucleate, but in fact, genetically they're diploid. But you compare that to ICSI, where there are only 7 to 14% of 1PN oocytes are actually diploid. And indeed, they have often genetic abnormalities in subsequent embryos. Blastocyst quality, which of course is determined not just by the oocyte but the quality of the sperm, is based upon blastocele expansion and the appearance of the inner cell mass and trophectoderm. Key performance indicators, however, they primarily reflect the quality of procedures within the embryology lab, and as can be seen in these first 4 KPIs listed here. Consensus competencies, so this is where you're reaching a minimum standard. They include, for example, fertilization rates of at least 65% for ICSI and 60% for IVF. Now the difference is because only metaphase 2 oocytes are injected for ICSI, whereas all oocytes are inseminated by IVF, regardless of maturity or quality. In my humble opinion, I would divide for both ICSI and IVF the total number of oocytes that were retrieved. So the next 4 KPIs here concern embryo development and utilization. And as might be expected, the competency and benchmark values both decline as development proceeds. And this reflects, of course, the increased demands of extended culture upon embryo viability. Again, as might be expected, the competency and benchmark values for implantation rates are higher for blastocysts than for cleavage stage embryos. The cumulative pregnancy rate is also a good measure of the quality of the cryopreservation program. However, the ultimate clinical KPI is the healthy baby rate, since that reflects the quality of the entire IVF program. It's also important to monitor KPIs relevant to the quality of biopsy and tubing techniques. And we define the successful biopsy rate as the percentage of biopsies that yield detectable DNA. Equally relevant are rates of embryo survival immediately post-biopsy and cryosurvival following warming of the vitrified blastocyst in most cases. But it's also very important to monitor the misdiagnosis rate. Now, the other consensus, the alpha consensus, according to that, the predicted values for oocyte cryosurvival fertilization, subsequent embryo development, and implantation rates favor the vitrification technique over the slow freezing method. Notably, the embryo development rate following oocyte vitrification should be the same as for a comparable population of fresh oocytes in the clinic. So that, of course, is the benchmark. And with blastocysts, higher cryosurvival and transfer rates are expected for blastocyst vitrification as compared to slow freezing. The proportion of warmed blastocysts that re-expand within 2 hours was recommended as an extra KPI to evaluate survival rate. And it was the consensus that the benchmark for implantation rate, again, should be the same as for a comparable population of fresh blastocysts. However, there are also limitations to using KPIs. Of course, it's possible to monitor KPIs such as ICSI, fertilization, cleavage, blastocyst development, and utilization rates. However, it will take 2 to 4 weeks before meaningful data can be obtained. And likewise, it takes 4 to 6 weeks before meaningful data is available regarding implantation and ongoing pregnancy rates. Now, when implementing quality management, one should always consider these 3 types of quality indicators. So there's structural, process, and outcome-related KPIs. And then it's necessary to carefully adapt any control charts for monitoring these KPIs to either promptly identify issues and adopt corrective measures, or, if you're fortunate, redefine the control limits in a process called progress building. And I'll explain in the next slide exactly how you do that. So this is a control chart, also known as a Shewhart chart. And of course, monitoring of KPIs is an important component of quality management. And that's illustrated in this control chart. So you can see that the mean is based upon usually the previous year's results for that particular KPI. And using the monthly variation about the mean for that year, you can establish standard deviations, and then you can set 2 or 3 standard deviations about the mean, above and below the mean. And essentially the dotted line, which is for 2 standard deviations away from the mean, that's kind of a warning sign. And the red dotted lines, that's where it's really the alarm bells are ringing and you have to do something seriously about it. So when a point does fall outside the limits that you've established using your control chart, you need to determine whether some special cause has occurred. If it's worse than what you would expect, then that cause, of course, should be eliminated if at all possible. However, if it's better, it may be appropriate to then redefine the control limits as part of your progress of building continual improvement. And ICSI is a good example of the value of tracking specific KPIs, such as the percentage of intact oocytes, the 2PN normal fertilization rate, and the 1PN fertilization rate. And analysis of these performance indicators clearly shows that it took at least 6 months for the ICSI technique to become perfected by the Brussels group, which of course successfully introduced it, after which their results remained stable. And these monthly data for good quality blastocysts are another example of performance indicator analysis. Now, the Vienna consensus for competency in terms of blastocyst development is 30%, and the benchmark is greater than or equal to 40%. And a good blastocyst development rate is defined as the proportion of 2PN zygotes, not cleaved zygotes, which became good quality blastocysts on day 5 at the prescribed time that you check blastocyst development, usually with a variation of 1 or 2 hours either side of that set point. Unfortunately, there's no internationally accepted training criteria that exist with respect to the acquisition of, for example, a license for clinical practice in embryology. So there are limited opportunities for organised education in clinical embryology, and it's therefore necessary to have in place in your laboratory adequate equipment for training where KPIs may be monitored, ideally by an experienced colleague, to determine when competencies have been achieved. So when we train a new person, or for that matter introduce a new technique, it's necessary to first define the determinant of competence for each training project. You can then use relevant KPIs as determinants of competency within a reference population or indeed a group that you define yourself. Naturally, logging specific outcome measures is essential to establish whether technical competence has been achieved. And this is one way to go about it. So, for example, there's a statistical tool known as Learning Curve Cumulative Summation, or LCQSUM, and that's designed to indicate when a process has reached a predefined level of performance. And, for example, that can be applied to vitrification survival and loss, as in this case here. And LCQSUM is applied until acceptable performance has been reached, and QSUM is used thereafter to ensure that an adequate level is maintained. So you can see that in this situation, 50 vitrification cases were deemed necessary to acquire competence, but you can see from the LCQSUM curve that was actually obtained when it reaches that upper level in a shorter time period. And according to the publication Batisol et al., based upon this system, they concluded that vitrification actually appeared relatively easy to learn, even though the trainee in this case was a beginner, and therefore the learning curve for skilled embryologists is likely to be shorter. The ICSI damage rate should improve with experience, and as can be seen here in this histogram, there's a general trend towards higher mean fertilization and sustained implantation rates as the number of patients increases, initially above 500 cycles, and in the last histogram pair beyond 1000 ICSI cycles. Therefore, splitting a single cohort of oocytes between 2 or more embryologists is always a good quality control measure. And as with ICSI, blastocyst biopsy should also improve with experience. In this study, where it was a multi-center study, and they looked at the operator performance, and they checked that for thousands of biopsies in several centers by monitoring clinical KPIs, including pregnancy, miscarriage, and ongoing pregnancy rates, ongoing implantation rates. And as can be seen, each biopsy practitioner in these different shaded histograms demonstrated pretty consistent and reproducible outcomes. So it's interesting that this should bring us around to traceability, because actually the cornerstone of quality management is traceability, since it underpins every action and operation within the IVF lab, including the handling of all patients' materials, consumables, and equipment by all personnel. So the data collected is actually fundamental to training, achieving competency, equipment maintenance, troubleshooting, and performing audits. And indeed, traceability is all-encompassing. So you have regulatory bodies such as the HFEA demanding it, and professional societies such as ESHRE recommending it. It's integral to safeguarding patients' tissues and monitoring KPIs. Indeed, the organisation, quality management, and accreditation of IVF labs depends upon it. And if we compare it to manual double witnessing, or if we look at traceability in manual double witnessing by humans, that's been shown to have an error rate of around 0.1%. And if you compare that to electronic witnessing, and in this study at VUB in Brussels, they looked at 7,500 cycles, and they saw that human error rate was reduced to just 0.03%. And these errors were mostly inadvertent mismatches, in fact, where different patients' dishes, not containing any patient material, was typically left in the same work area at the same time, so an alarm went off. And indeed, real mix-ups were actually prevented on just 7 occasions. So usually the system picks up a problem before there's a risk of a real mix-up. So furthermore, electronic witnessing effectively supports the implementation of standard operating procedures because it prevents steps in the process from being performed outside of the order that you predetermine when you establish your process map. And furthermore, it records who has done what, where, and when, and how long it took them to do it. Therefore, it helps to identify where additional training or a change to an SOP might be required. So indeed, electronic witnessing not only safeguards and improves the handling of patients' gametes and embryos, but it also records all consumables used for that patient. And therefore, of course, it can be potentially very useful in troubleshooting and doing a root cause analysis if a problem occurs, and tracking back, to those consumables. And it significantly saves time for staff that would otherwise have to be deployed for manual double witnessing. And in the days of a pandemic, it reduces the risk of infection between staff because you don't have one staff member leaning over another's shoulder. So in summary, we've considered the different types of performance indicators available for analysis. There are suggested benchmarks and reference populations in the literature, but it's really important that you define your own. Implementation of a quality management system is definitely supported by the use of KPIs and ensures continual improvement in the quality of the work that you perform. Here are the references to the citations within my presentation, but feel free to contact me if you need any of those articles. And thank you very much for your attention. If time permits, I'll be very happy to answer any questions that you may have.
Thank you, sir. Really wonderful presentation. And we will be having a separate session on the discussion part.
Okay.
So, yeah.
You want me to hang around?
Yeah. We
Okay.
always love to.
I was going to go after the weekend. No, I'll hang around. I'm keen to see my colleagues' talks.
Thank you. So next in the line, I would request Dr. Krishna Chaitanya sir to introduce our next speaker, Dr. Steve Levitt.
So ladies and gentlemen, honor and pride to introduce Dr. Steve Levitt, currently the Global Director of Clinical Applications at Cooper Surgical's Infertility and Genomic Solutions, a very well-known, renowned embryologist, a PhD in molecular immunology, has been working on fertility preservation for quite some time. And I think currently with Cooper Surgical is now looking into the clinical applications. So Dr. Steve Levitt, an honor to have you today with us. Looking forward to hear from you on best practices in embryo transfer.
Thank you so much. Can you see my screen?
Not yet, I think.
Okay, let me see if I can share it. Is it there now? Okay, perfect. Well, thank you for asking me to talk on embryo transfer, a topic very close to my heart. As you'll see from my CV here, one of the roles that I held was working for Wallace and running the worldwide business there. So as an embryologist, of course, we must be interested in embryo transfer. And then part of my working life, I spent a lot of time worldwide talking to embryologists and clinicians about the best practices. So I'm going to look at some of the evidence that's out there to support some of the procedures and processes that we use for embryo transfer. As most of you are aware, there's a number of myths that exist around embryo transfer, some of which have some basis in fact, and others have just developed over time and have persisted, even if there is no specific evidence to support them. So, of course, there are a number of aspects that go into this. There's the lab, of course, training, which I'll touch on a little bit in the LC-QSUM chart that Steve just mentioned with vitrification. You can use it for embryo transfer as well. And then an embryologist's view of some of the clinical practices that have some evidence to support them, and then just summarize at the end. So I think we're all aware that the success rates of IVF have improved over the years. It's attributed mostly to improved drug regimes, and of course our laboratory techniques have improved immensely from the early 90s when I started in embryology. It's looking at failures, so where our patients don't succeed. These are generally ascribed to embryo quality or to uterine receptivity, or both. But most failures occur after we've transferred what appear to be normal embryos, and the reason for that has perplexed us for many years, and it may be down to suboptimal embryo transfer technique. So as an embryologist, of course, we need to be aware of what's going on and that our embryo transfers are performed in the best way possible, because all of the lab work that we carry out producing the best quality embryos will account for nothing if we can't do the embryo transfer in a optimal way. So as we know now, again, with the improvements, about 80% of women that undergo the IVF treatment will reach the embryo transfer with apparently good quality embryos, but only, unfortunately, a small number of those go on to get pregnant, and even smaller number to deliver. And as you can see from the estimate here, 85% of replaced embryos fail to implant. So even now, with improved success rates, our implantation rates worldwide are still very suboptimal. And according to the paper published a long time ago now in 2002, this failure may be due to lack of good quality embryos, or receptivity issues within the uterus. It could be timing, so the window of implantation, but of course could be down to the technique of embryo transfer itself. And we'll have a look at some of the ways that we might be able to improve that. So the lab, of course, plays a crucial part in all aspects of IVF and success, and of course it does equally in embryo transfer itself. And I could probably see my colleague Steve Fleming smiling when I show this slide, because I've used it many times, but it shows the complexity of what goes on in the embryology lab. And you can see here, this was produced by Don Rieger some years ago, and it comes up with a number of 175 factors that can influence outcome within the IVF lab. And I just want to today, of course, focus on two: embryo transfer, what we're talking about, but also air quality, because that can play a part in a very unlikely way, or certainly an unobserved way. And we need to make sure that every aspect of what we do is optimal. And again, these are relatively old data that were produced that can show the effect of reducing volatile organic compounds in the laboratory. And this paper by Mayer et al. Showed that reducing VOCs improved the clinical pregnancy rate in the blue bars here. And in the next one by Catherine Rakowski's group in Boston, showed quite scarily, I think, from an embryology point of view, that in their paper, They didn't see any difference in pregnancy or ongoing pregnancy rate, but what they did do is they improved air quality sequentially, so using tower filters or inline filters or filters within the incubator, they gradually decreased the miscarriage rate. So air quality doesn't only have potentially a direct impact on embryo development and implantation, but also on subsequent fetal development. So when we're looking at embryo transfer, the environment that we work in is as critical as anything else to do with the procedure itself. Now, some of the things that directly apply to embryology, transfer media. Often asked about what's the best transfer media to use. And there are some papers out there and some data that give us some indication of what we should be considering when we're deciding what media to transfer the embryos in. So there is some evidence that hyaluronic acid present in the transfer media is beneficial. And there's also a suggestion that if you increase the viscosity of the transfer media, that may also be beneficial. But there is very little evidence to suggest that higher protein concentration is going to improve outcome. And certainly there are many labs around the world that routinely increase the protein concentration in their transfer media, but the evidence doesn't support the use of that. So the choice of transfer media is important. But what is equally important is that you control the environment that the embryos are in, from removing them from the incubator and to replacing them or placing them in the patient's uterus needs to remain optimal. So we shouldn't forget about the control of pH, osmolality, temperature during that whole procedure. That's extremely important. The volume to use, there again has been a lot of debate over the years about what sort of volumes we should use for loading. There are a few studies to look at, but they, of course, as you might expect, rule out very low volumes and very high volumes. And so we need to be working in the 20 to 30 or even 40 to 50 microliter range. And there is one study that showed that a 40 to 50 microliter loading volume gives better implantation and pregnancy rates than a 15 to 20 microliter volume. So again, over time, there were debates about whether very low volumes in microvol catheters were beneficial. But actually, it's generally not the case. So a slightly larger volume is ideal. And the other thing to say here is we don't need to get hung up on exact volumes, because if you try to load exact volumes all of the time, it increases the time it takes to get the embryos loaded into the catheter and through to the operating room to the clinician to do the transfer. And that is more critical than getting the volume exactly the same every time. It should be approximately the same, but it doesn't need to be exactly the same. We shouldn't take too much time measuring it. And then another question I'm often asked is about loading the catheter itself and the use of air bubbles or air gaps and what is best. And there are a number of different procedures that people use with full columns of media, one air bubble, two air bubbles, a large column of air with the embryos at the end. And again, they're all in common use. If we look at this paper, where they loaded embryos, and again, it's an old paper, as you can see by the fact that there are 3 embryos here. They had group 1 with the media with air either side, and group 2 where it was a continuous column of media. And the results are very similar between the two, with a trend towards better outcomes with the air either side of the media drop. Again, this needs to be validated in whichever clinic you work in, but getting that right and getting the technique right is also a discussion with the clinician to determine how much of the plunger they want to press and how much feel they want to get on the catheter itself. So loading air either side of the media drop with the embryos in certainly seems to be beneficial. So there doesn't seem to be any reported difference if you load your embryos from microdrops under oil. If you do use oil, then you need to rinse the tip before you actually transfer the catheter to the clinician to do the transfer. Very easy to do with just a pool of media next to the catheter. But as I mentioned, controlling pH, temperature, and osmolarity is paramount. And many labs that I've traveled around the world seem to forget that. They control the culture conditions up until they want to do the embryo transfer, and then they move to dishes that have been left out for a long time or are heated with without lids or without oil, and we will see changes over time. Pre-warming the catheter doesn't seem to have any benefit, and certainly in most cases, as soon as you remove the embryo transfer catheter from the warmed environment, the tip will immediately go back to room temperature. And by heating it, you may increase the production of VOCs from the plastic of the catheter or from the packaging that it's kept in. So again, heating the catheter or pre-warming the catheter isn't recommended generally. Once you load the media in there that's at the right temperature, you should have no issues. And interestingly, there isn't any evidence in the literature to show that flushing the catheter improves outcomes, although in a survey that was done, the vast majority of people do it. So it doesn't do any harm, but there's no particular evidence that that it's beneficial. So training, you saw one of these what appeared to be very complicated LC-QSUM charts that Steve showed about vitrification. But again, you can use these to determine whether people have reached a competency level within embryo transfer. And there's 5 practitioners here that are plotted on these different charts. And actually, it demonstrated that learning the embryo transfer technique is relatively straightforward. And you can see here it suggests less than 20 procedures are needed. Of course, I would argue that experience helps you when the embryo transfer is not straightforward. And again, one of the things that the QSUM part shows is whether people maintain competency. And so after you've reached the required standard, then the plotted charts here show you whether you remain competent over time. And practitioner number 5 here needed some extra training because they didn't meet the required standard. And something else that you can do is to show, unsurprisingly, that once you learn the technique, continuing to practice it over time is definitely beneficial. And this quite clearly shows that if you stop doing embryo transfers for any particular length of time, and here it's more than 10 days, you do see a decrease in pregnancy rates. So once you've maintained the standard or learned the standard, you need to maintain it and maintain your practice. And I would always, as an embryologist, monitor performance of both the clinical and the embryologist working on embryo transfer to make sure that everybody has reached the required standard. Okay, so of course we move on to the clinical aspects, the person actually going to do the embryo transfer. And it goes without saying, we need to keep stressing that this is an incredibly important part of the whole procedure. And a careful atraumatic embryo transfer using the right tools, the correct embryo transfer catheter, etc., the loading volumes, the type of media, etc., will all contribute to a successful outcome. So things to consider, and there are more than these, but time doesn't allow us to discuss any more. But whether we're going to do cleavage stage or blastocyst transfers, the number of embryos we're going to transfer, and over time, thankfully that's gone down generally. And in Europe, where we're sitting today, the number of embryos to transfer is generally 1, unless there's exceptional circumstances. We rarely transfer more than 1 embryo now. The type of catheter, how to load it, and the time from loading to placement of the embryos within the uterus is extremely important. The use of a mock or a trial transfer, ultrasound guidance, where we're going to put the embryos after we've done the transfer, to trying to avoid uterine contractions, what speed we should inject the embryos. Indeed, there needs to be discussion on who injects the embryos. In many places, the embryologist does it, but in some others, the clinicians or the nursing in the UK who do transfers now do it themselves. And the speed of withdrawal of the catheter. All of these things can play a part, and some have more evidence to support them than others. I think the use of an early mock or trial transfer seems to be beneficial to show you, one, whether the transfer is going to be easy when it comes to the real thing, but secondly, can show you any anatomical difficulties that there might be, and any extra procedures or different types of catheters that you might need to use when you come to do the transfer itself. And ultimately, if you can't do a mock transfer, if there is a real problem, then it's going to allow us to make a decision about vitrifying all of the embryos and doing a transfer at a later date. The choice of embryo transfer, I think, now is a moot point, because the evidence is very strong that you basically have to use a soft embryo transfer catheter, one that's likely to cause the least amount of trauma, not produce blood or mucus on the catheter while you're doing it, and whatever you're doing, it's going to reduce uterine contractility, and avoiding touching the fundus is extremely important in terms of causing uterine contractions or bleeding, damage, etc. So I think there's no doubt now that soft embryo transfers are definitely the way forward. And again, in the early days, there was a lot of debate about whether ultrasound guidance was of benefit during embryo transfer. And I think now there really is no debate. If your clinic has the ability and the facilities to allow you to do an ultrasound scan during the embryo transfer, it's going to produce better results. There was some contradictory data right at the very beginning, but all of the data now, including the Cochrane reviews that are shown here, that are produced by Julie Brown and colleagues, really give you confidence that the ultrasound guidance is going to give you better results in terms of implantation rates, ongoing pregnancies, live births, and a reduction in the transfers that are considered to be difficult. So they avoid some issues that, when just using clinical touch, would show you that the transfer was difficult, and it avoids any of those situations. Where do we place the embryo? There's been this discussion about this maximum implantation potential, or where to place the embryo. But again, there's no data in the literature that gives an exact positioning. We need to avoid the fundus to stop any uterine contractions or damage to the uterus. We need to be significantly away from the internal os of the cervix, so that we don't cause the embryos to fall back into the cervix or cause any loss. But somewhere mid-cavity, maybe slightly closer to the fundus, is ideal, but there is no specific point at which we can say that is the exact spot you should replace the embryos. So much so that with ultrasound now, the National Institute for Clinical Excellence in the UK recommend that all patients have ultrasound guided transfers to give them the best chance of success. And the UK are very cautious on advising on any particular techniques, but ultrasound is one where they're absolutely convinced that the evidence is unequivocal and certainly should be recommended. So it's a very brief overview. The embryo transfer we could probably talk about all day, and still probably not come up with a consensus about what is ideal. But in summary, the embryo transfer is a critical step of the whole procedure. To be able to do an easy atraumatic transfer using a soft catheter with ultrasound guidance is going to give us the best chance of success. To maintain an optimal environment in the lab during the ET procedure is vital, and sometimes it's overlooked. And minimizing the time from loading the catheter to placement of the embryos will help you maximize results. So again, not spending too much time trying to do things absolutely perfectly in terms of volume or bubbles, size of bubbles, etc. It's the timing to get the embryos into the uterus that's critical. And then if you look at the evidence from the literature, they class them as grade A, B, and C, those that have the best evidence. So ultrasound guidance, soft embryo transfers, and actually bed rest is, there's good evidence that you don't need to do that after transfer. Less evidence to support acupuncture, antibiotics, removal of some cervical mucus. We used to spend a lot of time doing that. Just removing the excess is important without causing any damage. There's no perfect position identified to place the embryos. Immediate withdrawal of the catheter is fine, and retained embryos don't cause a problem as long as you have a robust procedure in place to get that sorted and replace them as quickly as possible. And then very little evidence to support the use of analgesics, anesthesia, and massage therapy. And indeed, the injection speed, as long as you don't fire the embryos in or try to do it too slowly, a moderate speed seems to be fine. So sorry, I just ran over a few seconds, but thank you for your attention. And I'm happy to answer questions like Steve at the end of the session.
Thank you so much, Dr. Steve. That was an absolutely wonderful presentation. Every little point so well touched, and love the last slide's level of evidence. I think that's an absolute important take-home message. Thank you for your time. We will have the discussion at the end of the session.
Okay, cool, great.
Thank you. So moving toward the next, I would like our chairperson, Dr. Gaurav, to please introduce Dr.
Thank you,
Dr.
Pooja.
Rachel Chin.
Thank you. First of all, I want to say thank you, IFS, for giving me this opportunity to stand among the best people in ART. Our next speaker is Rachel Chin. She is a clinical application manager, APAC Cooper Surgicals. She has a vast experience of 19 years in ART. Rachel has keen interest in IVF lab quality control, culture system and condition, and embryologist training. Welcome to you, Rachel.
Right. First of all, thank you for having me. Let me just try to share my slides. Just wish to double check that if you can see my slides.
Yes, ma'am.
Right, thank you so much. Well, first of all, thank you to the committee for having me in today's conference. It's actually my great pleasure to be here. And my talk, during the introduction just now, it's regarding the management of this vitrifications program. The main reason is because vitrification is become the gold standard now, for oocytes as well as the embryo cryopreservations. Therefore, managing the program is actually extremely important for any IVF laboratory. Now, why do we vitrify to begin with? Well, there are many reasons, many indications why we need vitrifications. For example, it's due to fertility preservations, because of diseases, gametes or embryo donations, or maybe it's for social reasons, because some ladies now would sort of like vitrify their oocytes or have it cryopreserved, due to career as well as concentrations, or not ready to become a parent yet. Now, also in some cases where unforeseen event happens, gametes embryos can be vitrified. Now, one good example is fluid seen in the uterine cavity on the day of embryo transfer. Therefore, embryo transfer procedure is best to be postponed and have the embryos vitrified. Now, for PGT cases as well, the biopsy embryos could be vitrified to allow sufficient time for the biopsy cells to be checked. Now, in fact, a successful vitrification program can boost cumulative live birth rates. Now, as per this Euro 2011 data, the contributions of cryopreservations to the cumulative live birth rate is approximately 4%. Therefore, an efficient program is a necessity not just to maintain gametes and embryos viability, but also for achieving higher success rate. Apart from an improvement in clinical outcome, an efficient program also allows the laboratory or the embryologist to extend time for embryo evaluations, provides the opportunity to perform cycle segmentations, and in fact, for centers that only perform single embryo transfer, this will allow a systematic applications of this policy, the single embryo transfer policy. Now, let's recap some basic principles of vitrifications. Now, vitrifications involves equilibration step where permeating cryoprotectants such as DMSO or ethylene glycol are used. Now, in this first step, when the sample is placed in the medium, it will initially shrink and slowly re-expand, as you can see in these pictures. When the sample is re-expanded to more than 90% of its original size, it is deemed fully equilibrated. Now, it depends on the sample quality, the full equilibration time required will be different. Therefore, one alternative for the laboratory is to establish a medium time and use that as standard time. Now, next is the vitrification step, where both permeating and non-permeating coir protectants are used. Now, non-permeating coir protectants used are disaccharides such as glucose or trehalose. Now, due to the high concentrations of coir protectants in vitrification medium, many embryologists would worry about cytotoxicity. Therefore, they would perform this step in the shortest time without realizing the importance of adequate sample equilibration in vitrification medium. Now, this is one area embryologists need to pay attention to, balancing speed as well as adequate sample equilibrations. Now, to thaw the vitrified samples, the sample needs to undergo warming and rehydration steps, where only non-permeating coir protectants would be used. After the first warming step, subsequent rehydration steps involve progressive dilutions of the coir protectants. Now, the first warming step, which is carried out at 37 degrees Celsius, is extremely crucial, and it's highly associated with samples' post-warm survival rate. Therefore, in order to maintain the warming temperature, the media temperature, one way is to use heater block to house the dish, or put warm oil or media in the outer wall of the dish. Now, if we look into the instruction for use for all commercial ready-to-use vitrification kits, the recommended media volume is high. One of the reasons is because higher media volume can reduce the effect of errors, especially during the learning period. If small volume is used, there is a greater risk of increased in media osmolality due to evaporation, and this is highly associated with cytotoxicity. Now, our research lab looked into the changes of media volume during the 15 minutes equilibration at room temperature. Now, 4 commonly used media volume were tested: the 20 microliters, 100 microliters, 300 microliters, and 500 microliters. The results show that 20 microliters media had a 25% reduction of volume after 15 minutes equilibrations at room temperature. Now, even with 100 microliters, the reductions of 10% volume after 15 minutes is still very substantial. That is why a higher volume media is always recommended, and I would say a minimum of 300 microliters. Now, what are the tips and tricks for successful vitrifications? Well, gametes and embryos quality is the key. If poor quality blastocysts are vitrified, the data has shown that the live birth rate is only 7.3% despite it is an euploid embryo. Be fastidious with control of timings, temperature, media osmolality, and pipetting. Embryologists also need to evaluate time for equilibration, and it may differ between labs as well as the sample stage. And it's also recommended to load the sample onto the cryo device in minimal volume, typically 0.1 microliter or less, so that high cooling rate can be achieved. However, as I mentioned in my previous slides, warming rate is the most crucial. Now, this study by Seki and his team nicely illustrated how survival rate is associated with cooling and warming rate. As we can see, low warming rate gives low survival rate, irregardless of the cooling rate. Therefore, one should always try to achieve the highest warming rate, or a warming rate that is much greater than the cooling rate. Now, if we take a close look at the compositions of all commercial vitrification kits, it is actually very similar. The concentrations of coir protectants are literally the same in these kits. Therefore, the dehydration and rehydration process must be very similar as well. There is no clear evidence that certain supplements, macromolecules used, or any specific coir protectant combinations are more superior than the other. Now, all have happy users, and the key is all these kits can be learned and optimized in any individual lab. Now, we also cannot deny the fact that millions of embryos are being vitrified using different commercial kits worldwide, and vitrified samples are being transferred between IVF centers. As we know, all these commercial ready-to-use kits only have slight differences in their compositions. Now, in 2014, Lodovico Parmigiani from Italy published a pilot study with encouraging results of a single universal warming protocol, irrespective of the freezing protocol of human oocytes. Since then, Parmigiani has actually looked into using these commercial kits interchangeably, and all the data he published showed comparable prior survival, blast durations, and implantation rates. Therefore, being able to use a commercial kits interchangeably could really simplify laboratory protocols, staff training, and management of warming procedures. Not to mention, it also gives flexibility to the lab, not relying to one single media supplier. There are several key areas of concerns when it comes to vitrifications, not just in terms of safety of the gametes and embryos during handling and processing, but also need to maintain the competency of these samples to generate healthy pregnancies, healthy births, and neonatal outcomes. One also cannot overlook the potential long-term effect on babies, as the gametes and embryos will be in contact with liquid nitrogen during vitrification procedure. There is also a risk of microbial contaminations. Now, in a paper published in 2012 by the team in New Jersey, their data show equivalent aneuploidy rates among arrested embryos and usable blastocysts derived from previously vitrified and control oocytes. That give great reassurance that oocyte vitrification does not increase the risk of embryonic aneuploidy or diminish the implantation potential of blastocysts created after ICSI. Now, another study conducted by the Belgian team also, they also did not observe any difference in global methylation level in embryos from vitrified warm oocytes versus embryos from fresh oocytes. This suggested that embryos derived from vitrified oocytes do not carry abnormal global DNA methylation's epigenetic patterns. Now, this finding is reassuring with respect to the safety of oocyte vitrification technique. And this large cohort study involving more than 2,000 babies in each fresh ET and FET group also showed no increased incidence of congenital abnormalities after vitrifications. So far, the outcome from most studies have reassured the safety of vitrification technique on human oocytes and embryos. But just like any interventions, long-term monitoring and follow-up is still needed. Now, in order to perform vitrification well, the embryologist needs to be properly trained. It is undeniable that vitrification is a process that requires skills, as it involves multiple steps of high precision pick and place manipulations in a strict, timely manner over 15 to 20 minutes. Unfortunately, till date, there's no internationally accepted practical training to cover laboratory techniques and skills with an established minimum number of processes, which would consider as a prerequisite to acquiring a license for performing the procedures. So very often, the technique is learned in-house for a more experienced colleague. Therefore, how to manage this learning process? Now, I would say each lab should develop a training program for vitrifications. Here, I just wish to share an example of a comprehensive oocyte vitrification training program where it involves tutorial sessions and training sessions. Most importantly, there should also be a logbook that records all the training works or every hands-on outcome. And finally, the embryologist needs to undergo a performance check to confirm that the person meets the KPI before being signed off as competent to perform the procedures. What parameters can be used to check if competency is achieved? Well, it can be loss of samples or the status of the sample, if it is degenerated or developed further. Now, key performance indicators and performance indicators are commonly used as well, but I must stress that it should be referred to a specific reference populations or gold standard populations, and each lab can define their own reference group as well. What about the number of training cycles? To be frank, there has yet a clear consensus on the number of cycles a trainee must go through for vitrifications. Now, you saw this slide before that's presented by Steve, as well as Steve Fleming, as well as even Steve Levitt, also, for embryo transfer, talk about this LC Kusum test. Now, of course, I also will not go into the detail of this statistical tool, but I just want to say that from here, this LC Kusum test is actually a very, very useful tool to monitor if, let's say, a trainee, how much procedures is needed for the trainee to become competent in performing procedures. But other than that, it also monitor the subsequent performance of the trainee, whether they maintain the competency. And this is actually very, very important. Now, because when a person is already acquired the skill, maintain the competencies is also reassuring that the results of vitrification process or the results of the vitrifications can be sort of like consistent in the laboratory. Now, I also would like to stress that vitrification learning is not only applicable to new embryologists, but also to any experienced embryologist who has not been practicing the procedure for a period of time. In fact, any experienced embryologist will also have to go through a similar learning curve when using a new vitrification systems, especially from a different manufacturer. Therefore, continuous monitoring after proficiencies is required to prevent performance shift, and best to use KPI for monitoring ongoing performance. Now, vitrification training also include those transported samples, especially vitrified with non-familiar methods or cryo devices. For transported samples, it's crucial to obtain full documentations of the sample, the storage and transport conditions, as well as SOP or IFU for warming. If it is a cryo device that we are not familiar with, it is best to perform a mock warm test. As for the media, universal warming protocols for warming can be used as shown by this recent paper by Parmigiani. Now, managing vitrification program also involves monitoring the outcomes. Now, in vitrification program, the international standard KPI used is the Alpha Consensus published in 2012. In this consensus, the competency value and benchmark value for vitrified warm oocyte survival rate is 70% and 85% respectively, and 95% for donors less than 30 years old. Now, also for vitrified warm blastocysts, the competency value and benchmark value for survival rate is 80 and 95% respectively. Now, do take note that in Alpha Consensus, for both oocytes and blastocyst cryopreservations, some of the KPIs, such as the implantation rate, is with reference to the comparable populations of fresh cycle at the center. Therefore, it's important to manage expectations. When it comes to managing vitrification data, it should be compared with fresh cycle data. Now, top labs usually have consistent results, as this lab tends to perform high number of vitrification cases, which lead to optimized vitrification steps and very skillful hands-on experience. Therefore, the consistencies in their vitrification results. Now, as per the Alpha Consensus, it is expected that the implantation rate of vitrified warm samples is slightly lower than the fresh samples, typically 10 to 30%. Now, in a study by Kobo that involved 40,000 vitrified oocytes in an egg donation program, they observed differential survival rates among either donors or different stimulation cycles from the same donor. In fact, 1.4% of these cases had none of the vitrified oocytes survive after warming. Well, these are egg donors. Good survival is expected just as per Alpha Consensus of 95%. But in reality, in practice, it may not be the case. So
I think she has lost her internet connection.
Yeah, I guess so.
Yeah, looks like I was counter checking my internet connection.
I
But I
was,
lost it.
yeah. So, can we move to the discussion session?
Yeah, in between she's coming, we can ask some questions.
Yeah, sure. So, Atul, please display the discussion slide. So, thank you for the wonderful session, wonderful speakers. And now I would like to invite our chairperson and the speakers to start the discussion on these three topics. Dr. Krishna and Dr. Gaurav and Dr. Ragnandi.
So I think that was amazing brainstorming session.
I'm so sorry. I was having a little bit of internet clutches over there. Suddenly, I lost it. So I don't know whether I can still continue.
Oh, yes, please.
Yes, ma'am. You can continue.
I'm so sorry about that. I don't know what happened. Let me try to reshare my screen again. I'm so sorry about that. Right. Okay. I think I was here just now.
Yes, ma'am.
Right. Hope you can see my screens. I'm so sorry about that. Something just went wrong with the internet for a short while. Just I was actually trying to say regarding this monitoring of the KPIs using those standards. So I was just trying to share that when it comes to survival rate, some of the fertilization rate and embryo development rate, meaningful data actually would be available in a shorter period of time, 2 to 4 weeks. However, for implantation rate, ongoing pregnancy rates, cumulative pregnancy rates, or even delivery rate, the wait would be even longer. So for this, all these are challenging for IVF laboratory, because when we talk about vitrification, sometimes we can't see, we don't get the results immediately, or sometimes not even we get the embryos or the samples stored in a short period of time. Therefore, embryologists must abide to the SOPs at all times to avoid any drift, which can have an impact on the clinical outcomes. Now, previously, Steve Levitt and Steve Fleming both have also showed a little bit regarding control chart. Now, when we talk about managing vitrifications program, control chart can also be used as a tool to monitor the outcome of vitrification program. Now, it actually gives a very good indicator when there's changes to protocols. By plotting the outcome over time, control chart is very helpful in monitoring if there is a problem in the program that requires immediate attention or an improvement that allows KPI value to be redefined. Now, there's also another area we also ought to pay attention to, that is chain of custody. Now, data have shown that electronic witnessing system can efficiently prevent mix-up of gametes and embryos. Now, the witnessing system is to ensure correct identifications of oocytes and embryos. Now, cryo devices ought to be properly labeled with clear information, and implementations of a robust witnessing steps for each and every steps of the procedures, from retrieval of gametes to placement in the cryo storage. And also it's important to have a proper documentation systems of samples in storage, including identifications of samples reaching end of the consented or legal storage period. Now, if I may summarize, vitrification is an essential part of a comprehensive ART service, boosting the cumulative pregnancy rate. Now, commercial kits are very similar. Now, that would need actually the use of universal protocols. Now, vitrification appears to be largely safe, though long-term monitoring is still required. Each laboratory needs to verify and standardize their protocols by optimizing SOPs based on clinical outcomes, setting up comprehensive training program, continual monitoring operator competencies, and setting realistic and objective KPIs based on fresh cycles. Finally, chain of custody is a critical consideration when we want to manage a vitrifications program. Now, here I just wish to share some of the selected papers that I've used in preparing this today's presentations. And thank you for your attention, and I will be happy to answer any questions that you may have.
Thank you, ma'am, for the wonderful presentation. And now we are moving toward our so awaited discussion session. And again, I would like to invite all the speakers and the chairperson for this session.
Great. So if I may start, thank you, Stephen, for having me on. Nice to see you smile at the end of the session. So I think the first question I had for you, Stephen, was, thanks to Vienna and the Moribur consensus, we had something to refer to. There was a point where we didn't have something to refer and convince the clinicians that the lab was doing a decent job. So now that the KPIs are in place, the next problem that we as embryologists face, when should we react or troubleshoot? How soon should we be looking at these KPIs and really do something?
Good question. And I think, always, of course, the sooner the better. But in the real world where even though we plot these control charts on a daily or monthly basis, weekly or monthly basis, it's always effectively retrospective. And so I think, the experienced practitioners, let's put it that way, they can see trouble coming, and they have other potential indicators of whether it's a real or likely to be a real problem or not. And one of the things I didn't include in my presentation, but I think is a really important aspect of when it comes to troubleshooting, is to always have a timeline of everything that happens. So, if you have a new embryologist start, or if you change some of the equipment, or you've, someone down the corridor adjacent to you is deciding to paint their walls or lay new floor tiles, that kind of thing. Or if the air quality outside the building for a particular period of time is particularly bad, or when you change HEPA filters and all these kind of things, you should list every single event that you can think of that might have an impact and might give you some indication as to whether you're likely to be running into problems, and thereby, in some instances, you're actually obliged to vitrify your embryos and get them somewhere safe in the liquid nitrogen tank and bring them out at some later date when you've got your environmental conditions under control. So it's a really good question, and there's no simple answer, but that's why I think that the SHUIT or behavioral control charts are particularly useful, because they will give you some indication as to whether trouble might be on the way.
Right. Thank you so much for helping.
Could I just make a point there?
We would love that.
I think, and Steve made this point, and I think it's incredibly important that you monitor this gold standard group, and that your KPIs, when you're measuring them from a time period, are comparing like with like. I mean, many times we're asked to help when labs are seeing poorer results, and not all of the time, but then a significant amount of the time, it's the patient population going through at that time that can throw your KPIs off course. And so there's nothing specifically wrong in the lab. You're just dealing with a difficult group of patients at that time. So I think, just to reiterate what Steve has said, I think when you're looking at KPIs, make sure that you're comparing the same group of patients over a time frame that will give you the most reliable data to work from.
Well, that's quite helpful. Thank you, Steve, for those insights. So the next question probably is for Steve Levitt. Well, this has been an old.
I had a question. I'm sorry to this, Christina. This is Dr. Parag. I cannot open my video. Anyways, see, I have a question for Dr. Fleming. Suppose the clinic is a smaller setup and doing less number of cases. So in that cases also, do you really think that is it effective at identifying the KPI shifts? Which particular KPI is more important for those kind of things, and for those kind of smaller clinics with lower cycle volume? I'm talking about statistically significant.
Yeah, again, a very pertinent question. I've also worked in a boutique clinic where, oh goodness me, I think we only did 1 to 200 cycles for the entire year. So it does become quite problematic. And we always used to work by the rule of thumb. It's arbitrary, I guess, but the rule of thumb that you need at least 50 pregnancy results to provide meaningful data for a given period of time. So, and that's important because in relation to your other part of your question, which are the most important KPIs? Well, they become more important as you go further down the chain, if you like. So, as Steve correctly pointed out, the embryo transfer is critical point in the procedure, and the KPIs associated with that are going to be the most important ones. And of course, as I tried to say, in terms of the KPIs, the ultimate one is always going to be the delivery of a healthy singleton baby. So if you have restricted numbers, you just have to look at, you look at your KPIs. I mean, you can look at oocytes and embryos. You can get quite a bit of data from that quite quickly. But unfortunately, with things like, implantation, ongoing pregnancy rates, and live births, it's just going to take you longer. And I don't think there's any way around that unless my colleagues have some kind of solution I haven't thought of. But I just think that's just always one of the difficulties that you face in a small center.
And just with that, I would like to add, in those kind of clinics, if they are going to expand, in your experience, which KPIs you see during the expansion process due to the higher caseload than previous, which KPI is going to fluctuate more and to be taken care of? During the process.
Well, I'm not sure there are any particular KPIs that would fluctuate because of an increased caseload. But I mean, one obvious example I can give you, and I know there have been publications on this in recent years, but we were actually recording this back in the early 90s, and this is incubator door openings. So we used to use a Chesil chart recorder back in Nottingham back in the early 90s, and when we were becoming well known and our case numbers were expanding rapidly, and I think from memory we had about 3 incubators at that initial time period, and we had a Chesil chart recorder linked up to each of those incubators so that we could actually record the number of door openings of those incubators. And it was absolutely clear that those incubators that had the most door openings, the embryos in those incubators fared the worst. So I think if you want to look at something, then probably a sensitive KPI related to that would be embryo fragmentation, embryo blastocyst development, that kind of thing. So I think you should pick that up fairly quickly, and for me that would be maybe as good a KPI as any.
Fantastic. So thank you so much. I think Steve Levitt, the next questions for you from me. This was a traditional concept of doing a sequential transfer, putting back 1 or 2 day 3 embryos and then doing a subsequent day 5 transfer. So now in 2021, do we still have to, is there a role to do this, or we are very clear that you just do either day 3 or day 5?
Yeah, I've never subscribed to the practice of doing sequential transfers. I think it's almost like putting a safe bet on a race. It gives me the impression that people don't believe that their culture system is good enough to create blastocysts when they should form. So, but of course, we have to live in the real world. There's the scientific approach, And then there's the human approach to our patients. So if you believe that your culture system is good enough, then any embryo that has the potential to reach a good quality blastocyst should do so. So which embryo do you choose to put back on day 3? Do you put a poorer quality one on day 3 and leave the better ones to develop to blastocyst? Do you put the best one back on day 3 and then reduce the chance of blastocyst formation? I think the focus really should be on optimizing your system one way or the other, to either do day 3 transfers or to do day 5, day 6, whenever you get blastocysts. I don't think there's any evidence to suggest that at one time there was some queries over doing one transfer. If you then did a subsequent transfer, it would disturb the first embryo. I don't think there's any evidence of that, but I just think it's too cautious, and I don't really see any benefit of it. I think you do one or the other. Many clinics still do day 3 transfers with very good results. You know, you need much better, more stable culture conditions if you want to go through to blastocysts. We've seen that more recently with focus on pH, on osmolality changes over time, and particularly now with the use of dry incubators. So if you want to do blastocyst culture, you have to have a very stable, very optimized system. So, you know, in some cases, day 3 is still the way forward until that is truly optimized. But trying to do both, I think, is not an ideal scenario, in my opinion. I know others disagree.
So thank you. One last question for you, Steve, is I don't know if I've missed in your slides. I think you've focused on all the aspects. It'll be nice if you can give us a little summary or take home on the add-ons that would improve the outcomes of embryo transfer, like either the use of hyaluron-enriched media or laser-assisted hatching. Any of those add-ons?
Yeah. How much time do we have?
A quick comment.
The key factor for embryo transfer is to get the embryos from the incubator into the patient as quickly as you possibly can. And within that, you need to control the conditions that the embryo or embryos are sitting in the interim, however long that is. And I've been to so many labs around the world where they're very conscious of what they do when the embryos are in the incubator, but suddenly when it comes to embryo transfer, the dishes are out for a longer period of time, they don't cover them, they leave them exposed, and they never measure what's happening in the dishes and in that process. So before you do anything else, before you add hyaluronan, before you do assisted hatching, you need to get all of that optimized first. And you need to time yourself how long it takes to get an embryo from the incubator loaded into the catheter, into the hands of whoever's doing the embryo transfer, and depositing the embryo in a suitable way. I think there is a role for assisted hatching, but I don't think it's a universal benefit. I think there is evidence that hyaluronan in the transfer media is better, but it's not a cure-all. It doesn't solve all of your problems. It's an add-on if you've got everything else optimized. But many of the things we've done in the past, you know, I've been to labs with catheters inside an incubator to warm up. They're on top of the incubator to warm up. All of these things, there's no actual evidence that that's any better. And there are some indications that it may be detrimental. So we need to reassess, we need to take a step back, and we need to reassess what we're doing with embryo transfer and put the importance of it to the fore. I think sometimes we think, oh, we've created great embryos, so everything now is great. But the embryo transfer can make or break that cycle for the patient. So it's not only the embryologist, it's the clinician as well. They need to recognize that point. And that's why I think it's so important that we monitor performance. It's a very hard thing to do as an embryologist, to say to clinicians, and we had trainee REIs or research registrars in our clinic, and I always monitored their performance and monitored it with certain embryologists, so the pair working together. And it can produce some quite interesting data that means that people sometimes need to retrain in what they're doing. And there's certainly, if you have a busy program with lots of different practitioners, particularly doing the embryo transfer, they should all be of a reasonably equal standard. Of course, there's some variation in the patients they treat, but again, if you use a gold standard patient, you should be able to monitor that. And they should all be really reasonably consistent. Ultrasound guidance helps bring that playing field to a level status where the clinical touch works for some, but in others, using ultrasound is such a benefit. And unless there's a reason not to do it, cost of equipment or availability of somebody to do the scan, etc., then that certainly will make a difference. But the other add-ons I think are important, but certainly getting the technique right from the very beginning. And we can all make improvements, I think, if we just re-examine what we're doing and try to make it as optimal as possible. It's a bit of a wishy-washy answer, but I think
that was great. It was great. I think you really balanced it very well. You didn't really take us on one side and corner us. I think it was well-balanced answer. So thank you so much, Steve, for that. I don't know if Gaurav had another question to ask.
Yeah, I just wanted to ask the same, but I think he has already answered. The relationship between the clinician and the embryologist. Sometimes we see one embryologist giving excellent results with one particular clinician, while he's having a very different results with different clinicians. So how you see having some mocks, doing mock transfers together, sitting together over wines or coffee, knowing each other more in the OT than outside. So you have already answered that. Thank you so much. I think we have only 5 minutes remaining. I want to ask one question to Raquel, if she is there.
Yes.
So, she said that the warming rate is quite important when we are going for vitrification and warming, right? So how you see these closed systems? These closed systems have very low warming rate, although they are giving a very nice results and people are opting it. How you see that?
Your question is regarding the closed systems of these cryo devices, right? Now, when we talk about closed systems, of course, I would say it's in terms of the cooling rate would be slightly affected because that is not directly inside the liquid nitrogens to generate the very high cooling rate, not like the direct touch or the open systems. But when we talk about the warming rate, still we are talking about in terms of the first warming solution, which means the 1 molar sucrose, the first solutions, which again, whether it's an open system or closed system, it has to be at 37 degrees because that is the one in terms of the speed and the temperature of the medias that would help to give a very high warming rates. So as long as whether we are talking about open system or closed system in terms of the device, as long as the warming rate, the warming solutions of the first solutions is actually at 37 degrees exactly, correctly being measured, that is the key. So I would say using high volume of the media is always recommended, as well as either to use, if you saw in my presentations, using the heater block just to protect the temperature of the dish and as well as the media, or using warm oil of the outer well. That is one of the way. And of course, another is, speeds. Just quickly remove it from, open systems or the closed systems and move it inside the liquid nitrogens. And that also talk about how we positions our materials, like let's say the cooling bath, whether it's next to it, whether we have all the needed items that is, organized nicely. Because a lot of the time, sometimes we are human, sometimes we forget things. That's why I always recommend have a checklist, what is needed, because vitrification is really a step that, does not support any minute changes or minute mistakes at all. So I think if, let's say, you do all well, all organized, temperature is correct, whether it's open or closed systems, you will still get a very high warming rate and a high survival rate.
Nicely said. Thank you so much. Any other questions? Dr. Parag,
Since we've got 2 more minutes, can I have another question for the speakers? So for everyone, Rachel, Steve, and Stephen, one question, Rachel showed in her presentation that the implantation rate with vitrified warm oocytes could be somewhere 10 to 30% different from a fresh oocyte. But, when we look at the ASRM statement, they say it's all the same. When we look at the EV data, Anna Kober's data, it's sometimes just so beautifully put across, but in practice, we don't really see that. I don't know, we should be working more on the learning curve, and that's where that whole difference is coming. What that group is showing, we're not able to reproduce that.
If I may just chip in, because when we're talking about the data presented by all this group, they are actually from a big group. And then with the big group, what will happen is they do have high number of cases. When we're talking about high number of cases, it all translates into they have a very optimized steps, SOPs, when performing the procedures. And everything have been verified and monitored very closely. And of course, when we talk about high number of procedures, also relate to the experience, of the operator doing the procedures, because you have plenty of hands-on experience. Then from there, because of all this monitoring and number of cases, hence you can see the result. It's really, up to the par. It can be even as good as the fresh cycle, to be frank with, isn't it? Now, that is the challenge over there. Like for some other labs that may not be having such high number. So what it means is actually we really need to monitor the whole procedure itself very, very carefully. Because again, vitrification really is a procedure whereby, the drift will happen so easily. One embryologist versus the another. It could be just 5 seconds difference, but that 5 seconds can make a huge difference on the results. So how do we want to monitor that? That would be the key, actually. So which means is everybody should always sit down and then discuss, monitor each other, using control chart maybe, also monitor each operator. Don't take it at heart. It's not because we want to monitor, we want to point out your mistakes or whatsoever. No, we just want to make everybody's producing the same outcomes. I think that is the key.
Thank you, Rachel, for that. That was really nice.
You're most welcome.
Can I add something to that?
Please, sir.
Essentially, coming back to Steve's point of you must be very careful that you're comparing like with like. And in the case of the EV group and Anakobo's data, you have to remember that the vast majority of the vitrification cycles that they perform are on donor oocytes. You're going to get very, very different results from donor oocytes than from oocytes from, let's say, a general population seeking assisted reproduction. And in fact, their own results. If you look at the, there's a very nice webinar that was produced a few days ago with Professor Antonio Pellicer and Laura Rienzi, and that showed quite clearly that even within their own data at EV, their rates are not quite as good, even with a high mix of donor oocytes compared to fresh oocytes. And very clearly, they showed that if they compared their donor oocytes, let's say, to patients of the same age group that had endometriosis or had some, they were doing oocyte freezing for fertility preservation and other, poor ovarian reserve, that sort of thing, that the results were clearly not as good as with their donor oocyte patients or their elective, even the elective oocyte freezing population don't achieve the same results as donors. So I think you have to be realistic, and it's because of that mix of patients that the average fertility centre receives that it's quite reasonable to expect your results not to be quite as good following oocyte vitrification as it is with fresh oocytes.
Thank you so much. That's like a savior thing to answer a clinician back sometimes. But thank you. That was an amazing session. Thank you.
Thank you. Thank
Very
you,
welcome.
everyone.
Thanks for inviting us all.
Yeah, thank you, our esteemed speakers and chairperson for chairing this session and for the wonderful lectures we have. Thank you so much. So moving towards the next program, we have now the session 8, and I would like to introduce our chairperson. For this session, we have Dr. Silpi Sood with us. She is consultant and managing director, at Safal Hospital and Diva Fertility Center, Nagpur, Maharashtra. Welcome, ma'am. And the next in this line, we have Dr. Piki Saxena. She is the Director Professor, Department of Obstetrics and Gynecology, Lady Harding Medical College, SSKH, New Delhi, India. And the next, welcome, ma'am. And the next is Vashwani Rao, ma'am. And she's a consultant IVF specialist at Milan Fertility Center, Bangalore. Welcome you all for this session as a chairperson. And I would like to introduce the speaker, and I would also request Dr. Silpi Sood, madam, to please introduce Mr. Naval Shah. So we have today two speakers, Dr. Naval Shah and Dr. David Gardner, and I would request Dr. Shilpi ma'am to please introduce Dr. Naval. Thank you.
Thank you, Pooja. Over to this session of topic alarm and monitoring system in IVF lab. I invite Mr. Naval Shah. He's a head quality assurance and operations embryology at Indra IVF with special interest in audits, quality assurance, vitrification, and training in embryology. Over to you, Mr. Naval Shah.
Mr. Naval, you are not audible clearly. No, I think there is some connection error. Please check.
Yeah, is it audible now?
Yes. Yes.
Perfect. Okay, thank you so much. So I'll just share my screen. Yeah. So is the presentation visible?
Yes.
Okay. Thank you very much. So first of all, before I start, thank you very much IFS and Fertivision for giving me this dais to speak on alarms and monitoring system. At the same time, I'll give an extended thanks to even Shivani Scientific for inviting me in this industry sponsored session on a topic which is a bit relevant right now of alarms and monitoring system. So over and above, I'll start. And from here, I will just like to tell one thing, that yes, with regards to conflict of interest, we are using lab care alarm and monitoring system from Shivani Scientific at Indira IVF Hospitals Private Limited, and it's pan India. So going further, let me start with my session. Why do we require an alarm and monitoring system? Okay, so if I consider, I think everyone always thinks that my lab never makes a mistake. Are we saying, or are we being like an ostrich by saying that? Because whenever there is a predator, the ostrich just hides the face inside the soil, thinking that nobody's seeing him, but the world is seeing him. So by thinking that my lab never make mistakes, are we also being like an ostrich? So let me just tell you that all is well till the disaster strikes. I don't know how many of you would be remembering Captain Smith. The name may not be that familiar. The date, 15th April 1912, maybe again not that familiar, but here maybe now you'll understand what do I want to say. Titanic, the ship which was unsinkable. Remember, in the old days also, there were the alarm systems, and the manual alarm system was there, and the other ships in the vicinity did mention to Titanic ship and the captain that there is a floating iceberg, be careful. But they didn't listen to it. In their motion, they didn't reduce the speed, and they kept carrying on, and ultimately they dashed, and the unsinkable ship at the end of the day sank in its first journey. The luxurious ship was lost. So that takes us to the Murphy's law. And what is that? If anything can go wrong, it will. And that's the reason we need to have a quality assurance system into our system, which can be done by the alarms and monitoring system. But let me tell, even if it is a standalone private clinic, what do they need to monitor? The CO2, O2 levels in the incubator, temperature, pH, and at the end of the day, this all leads to the osmolality. At the same time, the other factors which we also need to monitor is air quality, humidity, VOC. Monitoring all this and keeping it to the best leads to the pregnancy rate, good implantation rate, and reducing the miscarriage rate. Can we have alarm systems for last three mentioned? No, sorry. So at the end of the day, the things which are in our hand is CO2, O2, pH, osmolality, and other factors like air quality, humidity, and VOC. Now, to keep them in control, we do have definitely process and SOPs in the picture. And to monitor them, what was the conventional way? The conventional way to monitor them were to use with registers. Yes, that is also a very important step. It started taking us more towards the disciplined practice, and the user records and the data was manually written and periodically updated, and the checklist was maintained to have this all logs into the picture. But at the end of the day, an embryologist filling in these papers feels like, oh yeah, I would better do embryology rather than just filling up the papers. And if anything goes wrong, the lab director just at the end of the day has to go through those books again and again and see, oh, where did we went wrong? And the logs has to be found every time. So it was really difficult. Also, maintaining the consistency was a problem because you don't know, did the user reported the right values? Was it backdated or was it the live entry? And all these problems were still there along with the manual recording of the QA/QC records in the lab. And here comes the importance of automated precise monitoring system. So when the importance of data logging was recognized, regulatory boards made mandatory to adapt the data logging. No human interference will definitely have a better logging, and lot of data can be monitored without any issues, and this will also let industry reach to a newer horizons. Remember, log is just keeping a record, but when it comes to data, the word is different. It has a facts, it has an information, and it is maintained over the period of time so that we can track it back whenever the problem arises. And that's why even lot of instrument or equipment makers now have a data logger facility which they give with their equipment so that everything is logged and it avoids the human error. So as I mentioned that with regards to this automated system coming into picture, there were regulatory guidelines which also started mentioning about the alarms and monitoring system. So what are the certain guidelines which they mention? So the ASHRAE guidelines, which was revised in 2015, has also clearly mentioned that the critical items of equipment, including incubators and cryo storage units, should be continuously monitored and equipped with the alarm system. There are a lot of things with regards to LN2, especially there are a lot of regulatory requirements. Even the golden standard, which we think for lab air environment, Cairo consensus, has also mentioned that the independent continuous monitoring of critical parameters of laboratory infrastructure and equipment is desirable at the very least and is mandatory for some accrediting and licensing authorities. So what are the other regulatory requirements? I mean, there are other things also, like even the ISA recently mentioned that the cryo storage vessels should have an alarm system to alert the staff. ASRM in its committee opinion has mentioned same. Even the HFEA, which is a UK regulatory body, has also mentioned that the center should have an adequate staff and funding for an on-call system for responding to alarms out of hours, an adequate spare storage facility capacity to enable transfer of samples if the DVAR fails. So it's regulatory bodies and guidelines also now started hinting towards the monitoring systems which should be in the place so that the audits can be taken care of and continuous monitoring doesn't leave any trail behind unnoticed. So are there any historical incidents why so much of liquid nitrogen guidelines and other things are also coming into the picture? I think most of us are aware of the historical incident which happened in 2018 with two of the clinics, University Hospitals Medical Center in Ohio, and also Pacific Fertility Center in California. And in the same year, there were thousands of embryos and eggs lost. Maybe a human error, the alarms were switched off, but something which led to a series of lawsuits. And you can see in the graph, the cases by incident category, it is mentioned in the paper that the embryos destroyed via storage tank failures are the highest, and that is where the alarm systems and monitoring systems comes into the picture, and it becomes a necessity to your IVF labs to make your practice better and standardize them. So don't wait for incident to happen. As I said earlier, all is well till accident happens. So we never should let that accident come into the picture, and always try to maintain all is well by adapting to the new things and bringing the things which are definitely better and makes our process SOP standardization much better to go ahead with. So now we have heard about the regulatory guidelines, the previous incidences, and why it is necessary to have the alarm systems. But what and why we require alarm and monitoring systems for? So let's take you through that journey now. So what can you do with the alarm and monitoring system? Definitely, you can have a timely alert. So anything is going wrong, you can quickly react to that. These all systems are adaptable so that the system works according to you, your process, your setup. You can categorize the alerts that this is the one which I want as a major, minor, severe, moderate. You can activate DND. That is, if you are in lab, you don't want alarms unnecessarily. So if you're in lab, you can just activate a do not disturb facility so that the alarms don't rise when you're in the lab. And once you leave the lab, the alarms may come if required. You can download the data which is required for auditing purpose. Now that even India passing the ART bill in Lok Sabha and Rajya Sabha, it becomes a mandate because we know that in future, the audit system may also come into the place which will further regulate our bodies. So hence it is required to have reports which can be used for your audit purposes. Yes, you need to you can assign an instrument to the user. Everything is like you can take care of if we have such systems in the place. You can set your limits and the delay time. What is this? I'll come to the temperature graph later on in the presentation to let you know what is this. And most importantly, you can monitor everything on a go live without any human error into that. Why are alarms required? It will also help you verify your equipment functioning. It also helps you to detect the drift in your sensor. So there are two types of alarm systems. One which reads the incubator reading and gives you on your dashboard, and second which also have an independent sensor. So if there are two sensors, then the drift can be recorded, and if the equipment sensor is not working well, it can immediately catch it. Also, what leads to the transparency is that the verification of the manufacturer's claim. Obviously, everyone while selling gives us a lot of assurances and promises that this machine does this, this equipment does this, but are they real? You can come to know that with the alarm systems or the monitoring systems in the place, and that can be verified also. As discussed, for audit trail, it can help you also determine the environmental factors, like say suppose the VOC levels of lab for some reason have gone up, and I know that it has gone up, it has alarmed me. So I will not remove the gametes outside and I will wait for it to go down. If it is not going down, I also know that I have to do the quick work so that the gametes are not affected by the VOCs. So it helps you make your work better. And obviously any electrical failure in the equipment is also immediately identified, and which gives you an opportunity to save your soul in time. So that's why alarm systems are required. How can you have a perfect alarm systems in the place? As shown in the image, alarm systems comes with everything. They can get attached to the incubators, to the heating stage, to the laminar flow, to dry incubators, to cryosense. It can monitor the health. Everything can be in the place. But for that, you also have to work rightly to get these things into your system. So the data logging is very important. The functional requirements is according to your standards, which you can set. Sensors, as I said previously, there are different types of sensors. So which sensor should you decide? That is what is also very important before you select an alarm system for your lab. What is GUI? It is graphical user interface. You just don't want data. You also want data to analyze it in a right way. So if you have it graphically put across on your board, that will help you make your life easier to understand and decode it. So not only the system, but how it reports you is also very important. Most important, why is it in place? Alarms. Yes. So you need to know how the alarms come and what are the different formats of that. I'll show you one slide ahead in the presentation on that part also. It should be there to give you the reports, and everything what is logged into the system has to be secured. Now we can have 21 CRF secured, which is US FDA security, which is for the security of the data. So you also need to make sure that the systems which you are choosing are having a valid security. And at the end of the day, validations. Why validations? If the entire system is made for an IVF lab, still why do you need to validate? It is because the validations are required with regards to your process or protocol which you need to set into your lab. So why are validations required? You must all have heard the story of a boy who cried wolf, that the wolf is coming, the sheeps were there, he's crying, oh wolf, wolf is coming. The villagers come to his rescue and he makes a mockery of them. Oh, there was no wolf, I was just enjoying with having some fun. Twice, thrice it happened. And the next time when the wolf really came, villagers said, oh, he's just making mockery of us. They didn't came for rescue. And obviously the sheep was eaten up with the wolf. So that's a story which you need to replicate in the lab. Because if your system doesn't identify the false alarm, then at the end of the day, the entire alarm system is waste because it leads to the fatigue. The false alarms will lead to the fatigue of your users. And when the real alarm will come, or you would say that it is missed. That is where it comes to signal and response. That is, the signal is present, but you don't respond as shown in the quadrant below, you will miss the alarm. And you need to hit it every time, and you need to reduce the false alarms into your system. And that's why even the set alarm systems, when you put it in your system, you need to validate it before starting using the same in your system. Going ahead, how alarm system work and what are the examples? I'll just show you some data and the case study of how the alarm systems work. So this is the graph which I mentioned of the temperature. How do you have to set it in your process? Now here, say suppose the incubator door has opened and the temperature has started to fall down. If the temperature has started to fall down, you don't need alarm because that is a routine work. You will every time open the door, take the dish, close the door. The temperature will fall. But if it is falling beyond a particular range or after a particular time, that is called the delay time, which is a buffer. And if that buffer is crossed, that sets up the alarm and a trigger which you should have in your system to make sure, is there something going wrong in your system? So that's how you need to set up the process with regards to your work in your own organization or a clinic. So how is alert being sent? There are different modes: SMS, mail, and call. When any parameter crosses the set limit, it triggers a call, SMS, or an email, which has the center name, time of alert, instrument name, parameter name, current value, and the set value. So this is also customizable. You can have, with regards to your system, customize what kind of things you want as an alarm. And if the SMS and mails are ignored, it can automatically set up a call, and it can have a 1 layer, 2 layer, that one user, if it doesn't respond, goes to second, then goes to third. And if, whenever the call is picked up, it is registered that this particular user received my call for the alarm, and that is the one who then takes up the action. And this sequence can be customized from clinic to clinic. So here you can just see that maybe here it's the person who has responded to the call. So the alarm is acknowledged, it is logged, it is registered, and that person then immediately acts. It's a bidirectional feature, and both of them can act and get the things into the control. So here's the case study. Say suppose your lab has some around 30 cycles per month. You have a box incubator, a benchtop incubator, 2 cryo cans, a refrigerator, two doors, and a lab health which monitors your lab environment. If all of this is monitored and logged at a point of every 30 seconds, then in one day, you would be having 76,050 data points which are logged. Is this possible manually? No, but this only leads to the consistency and helps you improvise your results, your performance, and it helps you also have your KPIs into the control. And that is why it is very important, because manually certain things are not possible. But if you have an electronic system in the place, it will log and help you with everything. So here's just an example of data which we handled at Indira IVF. Just for namesake, if for last 2 years, there was 143 GB of data which was developed and around 1.5 billion data points. This is also the time when we were setting up this particular alarm systems in our organization, and hence there were a lot of alarms, but a post standardization, this dropped and came to the much realistic value. That's the amount of data which is also kept onto the cloud, so that we don't have to worry. There is no manual recording. Everything is safe, secured in a cloud, and you can use it whenever you want at your fingertips. So just for a example, these are the different types of incubators, and these are the different the number of alarms which actually occurred and the errors which we were captured into our system. This also helps us to make sure that is the user working it rightly. One user can quickly open and close it. Second user can do it in a very relaxed way, remove it, again keep it, and that sets an alarm. Or even if it is not setting an alarm, it's a monitoring that opening and closing and the time it is taking to come back to the normalcy. And this monitoring helps us to further standardize them, to let them know that you are taking time. Please close incubator closely, otherwise your results will dip. And it indirectly also helps us. So it's not only alarm system which helps, as the topic mentions, alarms and monitoring system. And this monitoring system helps you to standardize your protocols in your clinic. So it, at the end of the day, helps us to bring everything under one roof with the alarm system, so that your culture systems never get affected. Your results are generally up to the mark, and you can perform better and better every upcoming days with everything under one roof. So What are the features? We have spoken about why alarm systems are necessary, why monitoring systems are necessary, and indirectly we have spoken about its advantages. But let us see that why it is really advantageous. So what are the optimum features an alarm system may have? It should be seamless to all the devices. It should have a cascading features. The data should be downloaded. So something which we have already spoken about, that it should be compatible also to all the incubators and the devices, and the number of person and sequence for the notification should also be programmable. So these are all an optimum features which our alarm systems should have before you finalize the one which you want to take. And the advantages of this IoT based systems is that it gives you detailed reporting. It is cloud based so that your data is never lost. It improvises your efficiency, and it helps you further be more productive. It can be used for any devices. It is a time saver. We don't have to go through the boxes of papers if we have to do any, if I have to check anything retrospectively. I know I just have to set a date, I have to set a time, or I have to set a period, and the report is in front of me by saving my time. At the end of the day, paper is not used in the lab. So we are going towards a paperless labs in the future, and it starts with this also, and it is easy to install anywhere, right? With regards to other advantages, yes, it can have a good cost impact because you may reduce manpower, because something which is logged in has to be conventionally written down is now done automatically. It reduces the medical loss ratio by straight thought processing, and it reduces the cost of fault finding analysis also if you need to send a person to do that particular audit or analysis. It has a lot of advantages in the operationally. It will accurately help diagnose the lab condition, the results oriented analysis of success rate, gamete growth, correlated study. A lot of things operationally can be beneficial if you have alarm systems and a monitoring system at your place. Alerts will point out any faults, and you also maintain a good data documentation with regards to an audit trail. Overall, with all the standardization, it leads to the better result. It impacts on the results, and you can enhance the same with the monitoring system in the place. So just to take it here further here from onwards, we are also almost towards the end of the presentation, where evolution of monitoring system has evolved from a conventional writing to the data computing, collecting the data, computing the data, and then the machine learning. So now that everything is cloud based, from Internet of Things to cloud to machine learning, and this will definitely lead to artificial intelligence, because these are all precedents of artificial intelligence. And once we have that into the system, that is something which we are talking about a lot in the current times. Every conference you visit, artificial intelligence is definitely going to be the topic, a hot discussion, and the monitoring systems will definitely lead us to that, to further improvise our own clinics and the standardization of the same. So to conclude, it is a requirement, is what I feel. All the parameters are monitored and the alarms are logged. You have to go for it. It will save, as we say, stitch in time saves 9, and it is definitely at the end of the day life saving, because we are handling the gametes in the lab. So become a winner. Don't say, oh, I'll look at it later on and we'll bring it later on. No, be there at the first, make it happen, see the possibilities, and improvise your system now, right now onwards. So our take home message is that the IoT or a cloud-based computing, alarm and monitoring systems are definitely going to become an integral part of an embryology lab. And further, it will become maybe a golden standard with so much of regulations and bills and everything coming to the place. I think that is what which will help you and will also save you your precious time, and it will also help enhance your results. So just to end up, to give you a straight impact, if this were the past labs, we know how we used to work in the past lab and how the current labs are. So if we are improvising like this to the newer versions, if your past labs was still giving very good results, but yes, were a bit messy, and now we know that it impacts the result, and we have moved on to the current labs with the modular labs and a lot of other infrastructural abilities. Similarly, why not then to go from manual systems to the automated system? It will definitely help you. This automation will bring the standardization and will bring a piece to you, your organization, your users, and everyone associated to the same. And this all is possible only with the team. So I'll end up with thanking my team and also again, the organizers and Shivani for giving me this opportunity to speak up on such a topic, which is right now a current trend, that is alarm and monitoring system. Thank you.
Thank you, Mr. Naval. I better understand that for better QA and QSC, I guess very true, as elaborated by Mr. Naval Shah, the alarm and monitoring system is very, very necessary at every lab. And India, where we know there's a lot of IVF labs are now established, the smaller lab, the bigger lab, but it is a need in our that every lab has to be have that automated, basically monitoring system. And very rightly said, like it is better to have more advancement with a cloud-based paperless is a very good idea, which improve the accuracy to monitor the lab. Thank you so much.
Thank you.
Thank you, Dr. Naval. And next, I would request respected Picky ma'am.
Dr. Pooja, can I ask a question here, or we can take up keep the questions at the end of the session?
Ma'am, we'll keep the questions in the end of the session after.
Thank you.
Yep.
Thank you. So thank you, Dr. Pooja. It's indeed an honor to introduce and welcome Dr. David Gardner, who is an eminent personality and a well-known person in the field of reproductive biomedicine. He will be talking on antioxidants in human IVF. Dr. David Gardner is the scientific director of Melbourne IVF and a distinguished professor in the School of Biosciences, University of Melbourne. He has published over 300 papers and chapters and has edited 15 books. He is a highly cited scientist in reproductive medicine with over 30,000 citations and an H index of 99. So over to you, Dr. David Gardner.
So we have the recorded session of Dr. David.
Okay.
Hello, I'm David Gardner, and I'd like to start by thanking the organizers for their most kind invitation to speak at the 17th conference of the Indian Fertility Society. And today I'll be talking about antioxidants in human IVF. Here's my disclosure. So in vivo, the human embryo is exposed to a very dynamic environment as it develops from the fertilized egg up to the blastocyst stage. There's continuous exchange of nutrients, gases, signaling molecules as the embryo progresses and differentiates. And you can see it's in close proximity to the maternal tract at all times. And down here, we can see a cross-section of the human fallopian tube. You can see how close the oocyte and embryo would be to the mother. When we compare that to what we do in vitro, we grow our embryos in, historically, tissue culture incubators, and we would grow embryos in relatively large drops of medium under oil. Then came time-lapse microscopy and the development of specific dishes which have microwells, which help the embryo create microenvironments in which to grow. But I think we'd all agree that even that is a long way from the female reproductive tract. And as a result of which, we get stress. When we grow embryos in our laboratory, we induce stresses that we're not even aware of. So how do you know if you've got a stress in your laboratory? Well, some of the things you can see. Reduced cleavage rates, reduced development of the blastocyst, and altered blastocyst differentiation. In other words, you'd get a blastocyst, but it wouldn't have a very good inner cell mass development. Other things you can't see, such as metabolic function, gene expression, changes to imprinting, all of which culminate in reduced viability. So what are the sources of stress? Well, we've identified many over the years. We used to add serum to culture medium. We now know that serum is highly detrimental to embryo development. Inappropriate medium formulation, specifically those lacking amino acids, can cause a lot of stress. Ammonium. Ammonium is formed from the deamination of amino acids at 37 degrees and also by the metabolism by the embryo. And ammonium is highly detrimental, particularly at higher oxygen levels. And oxygen itself. Atmospheric oxygen is typically 20%, depending where you are above sea level, and is extremely toxic to our gametes and to our embryos. Premature replacement in the uterus, putting a cleavage stage embryo back into the uterus, that's asynchronous transfer, that's a stress. being too rigorous with our pipetting and allowing temperature and pH to shift, both of which have highly detrimental effects. So it's really important that we know what these sources of stresses are and we restrict them. And this is a very nice review on this very subject that I published a few years ago in the Journal of Developmental Origins of Health and Disease. And I would really encourage you to read through that to get a whole better grip on this context. So in order to grow healthy embryos, I think what you really need to do is take a more holistic approach. And that's because there are so many variables and parameters which impact embryo development and viability. And more, they interact with each other. And here's another very nice review that we wrote a few years ago, trying to explain that very concept of how you have all these different things interacting and how they can affect our beautiful embryos. So for many years, I proposed an embryo framework, whereby instead of just focusing on one aspect of the culture system, such as the culture media, you take a step back and look at the entire system, from the patient, its stimulation, age, etiology, genetics, and diet, all the way through to luteal support. But the laboratory is comprised of different incubators, your air quality, number of embryologists, and then within that is your culture system, and within that is the culture media. So there are many, many things. And as I said, many of them actually interact with each other. And one of those things is oxygen. Furthermore, it's important when you're optimizing your embryo culture to acknowledge that prior to compaction, the embryo is highly susceptible to stress. And these stresses are typically pH and temperature. So once you get to compaction, the morular stage, and the embryo forms an epithelium, it can regulate inside and out much better. So the blastocyst is a far more resilient stage of development than, say, the fertilized egg or the cleavage stages. So to facilitate the minimizing of stress, we've advocated for 30, 40 years the use of these isolettes, in which you can have a look at your eggs and your sperm and keep them at constant temperature and pH before they go into the incubator. So with regards to culture media, is there anything missing from the current generations? When we look at what we use, we have salts, amino acids, vitamins, carbohydrates, albumin, and hyaluronan. But when we compare that to the composition of the female tract, we're still missing quite a few things. And amongst those are antioxidants. So the male reproductive tract and the female reproductive tract provide antioxidants to protect the sperm, the egg, and of course the embryo. So I'd now like to focus on the role of antioxidants in human IVF. The significance of oxygen concentration can't be overstated. In vivo, the levels of oxygen within the female tract are much lower than that in the atmosphere. It's been estimated about 5 to 8%. In the uterus, it may drop a little more, but around 5 to 8% is the concentration of oxygen. It's been shown in all mammalian species that culture of embryos at 5% oxygen is better than culture at 20% oxygen. And indeed, it increases development and viability. And this has now been shown to be the case in human studies too. Oxygen can have lots of negative effects. In fact, I can't think of anything that has so many different and highly detrimental effects other than atmospheric oxygen on our embryos. And you can see from gene expression to affecting the very epigenetics, the proteome metabolism, cellular homeostasis, etc., all of which culminates in compromised embryo development. Making matters worse, exposing cells to 20% oxygen also increases their vulnerability to a second stress. So there might be a second stress in the system, but you get away with it because you're using 5% oxygen. But if you grow embryos and incubate at 20% oxygen, then you may find you've got another problem to deal with. And a good example of this came from these studies by my graduate student, Petra Whale. Petra was looking at the effects of oxygen on the metabolism of the mouse embryo. But interestingly, she showed not only did it affect the metabolism of the embryos, but it affected the physiologies of the embryos in such a way that they were no longer able to regulate their homeostasis. In this case, they could not protect themselves against a shock of ammonium. At 5% oxygen, they could. At 20% oxygen, they couldn't. These data look at the amino acid utilization by mouse blastocysts. Yellow is the 5%, blue is the 20% oxygen. And you can just simply see by quick looking at that graph that at 20% oxygen, the amino acid take-up by the embryos, or production, so consumption down here, production above the line, is altered significantly. And when we look at glucose uptake, now glucose uptake in the cow, the mouse, and the human is a positive biomarker for viability. In other words, the higher the glucose uptake, the higher the viability in those species. And what we can clearly see is that 20% oxygen is significantly reducing glucose uptake. So it's suppressing metabolism, as I showed you for the amino acids. When we look at the sources of oxidative stress, clearly atmospheric oxygen is one of them. And it's exposed our gametes during collection, during preparation in ICSI, FERT checks, grading, biopsy, and several labs still use 20% oxygen for culture. Reactive oxygen species formation is highly detrimental during sperm preparation and also in cryopreservation, as I'll show you. So what's the impact of reactive oxidation on our embryos? Well, it can have a detrimental effect straight off the bat. Poor embryo quality, high levels of peroxide leading to fragmentation, linked to apoptosis, cell and membrane damage, DNA damage, leading to delays in development, etc., etc. So ROS has a highly negative effect on both sperm, eggs, and embryos. And to show you that schematically, here we have oxidative stress inducing reactive oxygen species. So reactive oxygen species can be formed from endogenous metabolism in the mitochondria of the sperm and the embryos. Exogenous ROS can be formed by inappropriate oxygen concentration. The higher the oxygen concentration, the more ROS you're going to get. Inappropriate media formulations, ones with transitional metals, for example. During IVF, and I'm going to show you in cryopreservation, you get ROS. Here's the downstream effects of ROS: cell membrane damage, DNA damage, leading to delayed development. Increased peroxide, leading to apoptosis, and all of which leads to reduced viability. Can antioxidants prevent all of this? Historically, antioxidants have been studied for a long time. In fact, the first study, as you can see, was down here by Noda in 1991, looking at superoxide dismutase and its effect on mouse embryos, getting them through the two-cell block. And in fact, it was that paper that sparked our own interest in antioxidants. And we presented our first work on antioxidants in 1993. So we've been interested in this field for a very long time. Historically, though, we've added antioxidants individually. We've shown that they improve embryo development. But what we wanted to know more recently is what happens when you add groups of antioxidants, because in vivo, antioxidants don't exist in isolation. They work in functional groups. So for the last several years, we've been examining this. And I'm going to show you some animal data and some clinical data that we've obtained so far. So with regards to the mouse data, this is looking at pronucleate mouse oocytes, embryos fertilized in vivo, and then cultured to the blastocyst. We screened several antioxidants, but we focused on 3 in the end. Acetylcarnitine, it's abundant in seminal plasma, but it also improves embryo development. Alpha-lipoic acid, the antioxidant of all antioxidants. Not only is it an antioxidant, but it can reduce other antioxidants once they themselves have been oxidized. So it helps in many ways. And N-acetylcysteine itself is an antioxidant, but it's also the precursor for glutathione, the cell's main currency of protection against oxidative damage. So not only does this act as an antioxidant, but it increases glutathione levels as well. So we did dose-response experiments and showed that indeed each one had a beneficial effect. But what we then wanted to do is what happens when we use groups of antioxidants. So we took pronucleate mouse oocytes and grew them in culture. And we grew them in groups or individually at 5 and 20% oxygen. And you can see immediately here that there's a benefit to adding the combination of antioxidants, the A3, to group culture and to individual culture. But as you'll notice, there's a bigger benefit when the embryos are grown individually. And you can see also in the control group, there's a drop in cell numbers in these mouse blastocysts when they're grown individually. And this is this double stress situation when mouse embryos are cultured individually at 20% oxygen. That's highly damaging. So what we showed was that the triple antioxidants had a greater effect than the ones individually, and that triple antioxidants are greater in individual culture. They have a bigger effect when we were at 20%. But what happens when you do this at 5%? Well, you can see whether it's in group culture or individual culture, you get this increase in cell number when embryos are grown in the presence of antioxidants. But what you don't see is this problem of individual culture that's gone away. So again, that's really interesting observations. But the fact is, we're getting a significant increase in cell numbers in the presence of antioxidants when embryos themselves are grown at 5% oxygen, which confirms that the reactive oxygen species has been formed from endogenous sources. We then went on to show that when you compare to in vivo, when you incubated embryos in the presence of the antioxidants, they maintained their levels of glutathione. However, if you held the embryos at 20% oxygen in the absence of the antioxidants, they started to lose their glutathione. We then did embryo transfers on day 4. So this is our control group. This is the presence of antioxidants. And what we showed quite clearly was that there was an increase in fetal weights, placental weights, and crown rump length. And there's a 10% difference in implantation. Now, this isn't overweight. These are not large for gestational age mouse embryos, far from it. In fact, they're slightly lighter than in vivo developed fetuses, but they are closer to in vivo weight when we've grown them in the presence of antioxidants. So this is really exciting data. Culture is translated over into fetal development. We then wanted to know what happens when we did IVF in the presence of antioxidants. So using, again, the mouse model, we were able to collect our gametes and do IVF with or without the antioxidants. So we were able to set up a matrix whereby, as you can see, we have a control group here. Antioxidants are missing from the control group. And in the culture, so we go control, or control to antioxidants in culture. Antioxidants in the IVF, but not in the culture, antioxidants in the IVF and in the culture. So we had this nice 4-way group, 2 by 2. And then we grew the embryos on. And what we could see quite clearly is that when we had antioxidants in the culture, but not in the IVF medium, we got a beneficial effect on resultant blastocyst cell numbers. And this is the trophectoderm inner cell mass. When we looked at just adding the antioxidants to the IVF medium alone, we still got a beneficial effect. But it was clear that when we have the antioxidants in both IVF and culture is where we get the greatest beneficial effect. What about other aspects of the IVF cycle? These transient exposures to atmospheric oxygen can be highly damaging, and the negative effects are cumulative. So what we wanted to do was look at what happens when we just hold mouse embryos on the bench in holding medium in atmospheric oxygen. Do antioxidants have a beneficial effect? And the answer was yes. By simply holding the embryos in the absence of antioxidants, just for 20-30 minutes, there was a decrease in cell numbers at the blastocyst stage. And we also showed that there was a significant decrease in the level of intracellular hydrogen peroxide in the presence of the A3. So very exciting data. We then wanted to look at cryopreservation. Cryopreservation is growing in human ART, so it's essential that we optimize what we do. We also know that there are cryo-induced traumas, and some of which could be manifest downstream. So when we look at cryopreservation, we can see there are high levels of cryoprotectants, which increase osmolalities. We have extreme temperature changes. This leads to oxidative stress, generation of reactive oxygen species, cryo damage. And again, we see the same cascade of events, all these detrimental effects. induced. And down here, I've also listed modification of histone methylation and acetylation. These are the epigenetic effects. Interestingly, once we have all these problems caused by cryo, the embryo tries to repair itself, and by doing so, uses energy, and that in itself generates more ROS. So we wanted to know, can we add antioxidants, and will this help? So again, using our mouse model, we were able to look at the effects of antioxidants in the vitrification solutions and in the warming solutions, and break out which is more beneficial, if there is, or was it required for both. So we grew embryos to the blastocyst stage, cryopreserved them by vitrification, warmed them and grew them to day 5, did cell number analysis and embryo transfers. So here's our control group. And you can see that when we added the A3, the antioxidants, to the vitrification solutions, we get a significant increase in the blastocysts. Same thing happens when we have both. But what was interesting is that when we add it to warming solutions, when we add antioxidants to the warming solutions alone, we don't get the beneficial effects. So we conclude that adding the antioxidants to the vitrification solutions is the most important thing. We looked at acetylation. This is markers of epigenetic state. And what we showed quite clearly is in 2 markers of H3, K27, and H3, K9, there was a significant decrease in the acetylation of these histones. So vitrification is having an epigenetic effect. It's changing acetylation, which will affect gene expression. When we added the antioxidants, however, we got an increase, significant increase in acetylation levels. However, you can see that they're still far below the control values. So there's still some work to be done. But it is clear that antioxidants have a beneficial effect. We then did embryo transfers again from such embryos, and you can see there's highly beneficial effects. By having antioxidants during the vitrification solutions, we increased the fetal weight, placental weight, etc., etc., etc. So again, what happens during cryopreservation has a downstream effect post-transfer. And we saw the same again, whether the embryos had been cultured in 5 or 20% oxygen. This is some really exciting data that's in press in RBM Online, whereby we've looked at gene expression using next generation sequencing of blastocysts and fetuses and placentas. And what we found is when we grew embryos in 20% oxygen and when we vitrified blastocysts, when we had antioxidants present, we got a more normal gene expression profile than in their absence. So culture at 20% oxygen had a detrimental effect on gene expression compared to the in vivo embryos, as did vitrification. But when we added the antioxidants, it had a normalizing effect on gene expression in the fetal and placental tissue, which is really exciting. So to summarize the basic research, adding this combination of antioxidants had a highly beneficial effect at both 5 and 20% oxygen, inferring that a lot of the oxidative damage is done through endogenous sources of oxidative stress. When you're looking at IVF, the antioxidants have the greatest effect when you had them in the IVF solutions and the culture. We've shown that it maintains glutathione levels and decreases peroxide. We've shown a benefit post-transfer and during cryopreservation. And now, when we look at gene expression through next-gen sequencing, we reduce the number of differentially expressed genes altered by culture and cryopreservation. Really exciting. So what about clinical studies? Well, I've got a few clinical studies to share with you. The first one being this prospective randomized multicenter sibling oocyte comparison. So the sperm never saw the antioxidants, but oocytes were split and the embryos saw the antioxidants. And what we saw was when we looked at these younger age groups here, this was the clinical pregnancy rate, and this is our standard culture median. And then when we looked at the older age groups, we see this characteristic decline in pregnancy rates. But when we looked at the same phenomenon with antioxidants, we did not see the characteristic decrease in pregnancy rates associated with age. So it could be that in older patients, the antioxidants are protecting a cell that's already been exposed to cumulative oxidative damage over its lifetime. These are data from Hardarson and colleagues in Sweden. This was a multi-center 2PN split, so the sperm and the eggs did not see the antioxidants. Similar to our data from Japan, there's no difference in ongoing pregnancy rate in the young patients, but in the older group, there's a trend to higher pregnancy rates. And these data from Japan, again, presented at the ESHRE, show that when sperm, eggs, and embryos are exposed to the antioxidants, here represented by X on the suffix of the media, so the GX media is the antioxidant media, there's an increase in good quality blastocysts, and again, this trend to higher ongoing pregnancy rates. So if we put all of these clinical studies together, these pilot studies together, you can see from this little meta-analysis put together that there is definitely an apparent advantage of having antioxidants in the older age groups, but not in the younger age groups in terms of pregnancy rate. So in summary, I think it's important that to maintain the developmental potential of embryos, you need to take a holistic approach. Embryo is so much more than just buying a culture medium. You need to understand the interactions. You need to invest in comprehensive quality control to make sure the systems work. In a mouse model, we have shown that antioxidants improve IVF, embryo culture, embryo transfer outcomes, and vitrification. Excitingly, we've shown that antioxidants help to maintain a more in vivo-like pattern of gene expression following culture in 20% oxygen and following vitrification. In the human, it looks like antioxidants may assist in alleviating the age-related decline in human viability, but we have to wait for further studies to confirm those observations. And I think one of the things that's important to get across is that embryo culture has not been optimized. We and many labs around the world are working hard to constantly improve that. So I'd like to thank you for your attention. I'd like to send you my very best wishes from Melbourne, Australia. I hope you can keep safe during these difficult times, and I really do look forward to a time in the near future where we can all be together in the same room and have really good and robust discussions in person. So thank you very much.
Thank you. Thank you very much, sir, for such a wonderful presentation. And now I would like to invite Dr. Shilpi ma'am and Dr. P.K. Saxena ma'am to open for the discussion. So now I can see Dr. Gardner is with us. Hello, sir. Good afternoon.
Hello. Hi.
Nice to see you, sir.
Nice
So
to be with you.
now we are going for the discussion session, sir. Dr. P.K. Saxena, do you?
Yeah, I'm trying to. Can you hear me?
Yes, ma'am. You are audible.
Okay. So that was an outstanding talk by both Dr. Naval Shah and Dr. Gardner. Very enlightening and wonderful talks. So thank you very much. First, I would like to ask Dr. Naval, what is the cost of this automated alarm system that you have been telling us and you have used in the IVF?
Right. Thanks for the question. Yes, that is one of the basic questions which everyone generally goes for. But to answer that is not that easy, because the entire setup, what all things you require, like you do require lab care, lab health, lab sense, cryosense, they have multiple products. And that also depends upon the number of sensors and the number of equipments which you have. So with regards to number of incubators, with regards to number of sensors, everything changes. So I think the best would be to approach the vendor and talk about the cost, because that is something which is not very standardized, and from company to company, equipment to equipment, and numbers, everything changes. So I think maybe may not be the right thing to give any standard cost to that.
How frequently do you need to monitor your automated system? That also will require some sort
Yes.
of audit.
Definitely, yes. So we have an audit system in a place. We have auditors who are coming from quality assurance backgrounds. They are auditing, they are different zonal auditors. So they do the audits, and this is reviewed every month. I also do a monthly review of all the centers from time to time. And it helps us, because if the user is saying something, if the report, if the success are going down, and with regards to the monitoring system, if we come to know what were the trends in opening incubator or having the time of temperature and gases and everything again coming back to the same line, it definitely helps. So we have a monthly review system where we review it, and we also review it with the team. So with the management also it is reviewed, and with the team also if it is reviewed.
So the monitoring and the alarm system will also have protect you from litigation. Is that so? If you have certain SOPs and you make, and if there is a mix-up of gametes, who is responsible, the embryologist, the director, or the clinician?
That's a very tricky question. I think with regards to the guidelines which have been passed right now, obviously we know that they will be responsible, the management and the directors, they are held basically the responsible. But yes, with regards to alarm system, that is basically for equipments. With regards to gamete mixing, we also have electronic witnessing system, and all our centers 100% is now equipped with electronic witnessing system. And that is where we are saving all those kind of accidents by having electronic witnessing system also into place. So that is also which is required, and I think mandatory with regards to monitoring. And with the bills passing now, it is a mandate. I think everyone today or tomorrow will have to go for some kind of automated monitoring system to avoid such accidents in the lab.
Yeah, very right. So there is a question in the chat box for Dr. Gardner. Why the antioxidants did not work or benefit when they were added to a warming solution?
That's a very good question. It seems that the stress caused by vitrification is where the reactive oxygen species or some oxidative stress is formed. So it's actually during the vitrification. So it seems the warming doesn't induce as much oxidative damage as we first thought. And that's my answer. I think it's because the most of the oxidative stress occurs when you actually plunge down into 196 degrees Celsius. Yeah.
And Dr. Gardner, would you recommend these triple antioxidants to be used in the culture only for women above 35 years, or should we use it for women, younger women also?
Right, the data looks like the beneficial effects appear to be for older patients, but we're just completed a randomized trial. So we're currently investigating all the data, and we don't know yet whether there are some benefits for the early patients with regards to, for example, are there increased fertilization rates, better sperm quality, et cetera, et cetera. So we're working on that right now.
Okay. And you have tried these 3 antioxidants, or are you working on a few more?
That's a great question. Yeah, no, we're working on a few more. We're working on a few more. This is something, like I said, I've been interested in this for over 30 years. And so we've tried a lot. These 3 were very effective, but we have a few more that we're playing with that look good as well. So we'll just keep on, you know me, I just like to keep doing the research and looking into the biology of how this all works. Yeah.
I guess Dr. Naval Shah has raised his hand. Do you want to say something?
Yeah, if there are no questions, I would just like to speak for a minute. Am I allowed?
Yes, please carry on.
So basically, from reading the books, what David Gardner sir had written, we have grown over the last 2-3 kids with him. And today I'm getting an opportunity to stand besides him being in the session and me over here. It's a kind of a dream come true. And I also realized that it's all his talks are generally he gives standing. And I kind of in a way ovation to you, sir. Today I also decided, and leaving the chair, I also did the entire talk today standing. And that actually gives a different energy. So thanks for inspiring us in the generations. And obviously we look up to you for everything. And thank you very much.
Well, thank you for your kind words. Very much appreciated. It's been a very exciting.
I must say, Naval. I must say, Naval has actually taken all my words, whatever there in my heart. I wanted to actually communicate the same feeling to you, sir.
Oh, thank
Sir,
you.
I have a question. Although we know we have very less time, but this question is not related to this particular talk. The question is about the antibiotics. I'm always confused about the gentamicin and the other antibiotics. Which one is the best when we use in the embryo culture medium?
That's a very good question. And it's not what we think is the best, it's what the legislative bodies let us use. So we use penicillin and streptomycin to great success, but the FDA were concerned about superbugs. And so they moderated and dictated that we had to go to gentamicin. So some of these things are not done because we want to. Some of these things are done because the FDA or the EU make us make changes. So yeah, that's hence the confusion, because yes, gentamicin is very broad spectrum. Yeah.
Right. Yes, sir. I have read somewhere that gentamicin is not embryo friendly, and that's why we are using streptomycin in penicillin instead of it. But now I am seeing that every product has the gentamicin as a.
I've never seen gentamicin been embryo unfriendly. I thought it was always very good with embryos. I don't think any of them are particularly embryo toxic at all. Like I said, it's really what, for example, the FDA in the United States would let us put in the culture medium. So.
Thank you so much.
I have a question with Professor Gardner. It's wonderful listening to your lecture. I would like to know whether these culture medias with antioxidants is being marketed now.
Yes, I do believe you can get it. Yeah, absolutely.
Yeah.
Yeah.
Thank you.
That's my understanding.
Once again, thank you so much, Gardner sir and Naval Shah and Vicky ma'am and Silpi Sood ma'am. Thank you for sharing a wonderful session. Thank you all. And moving towards to the next session, before going to that session, I would like to hand over this responsibility to my colleague, Dr. Nidhi Singh. And few words for Nidhi. She's a great friend and a clinical embryologist, IVF and Reproductive Biology Center, Maulana Azad Medical College, and LNJP Hospital, New Delhi. So Nidhi, over to you, and I will be free for some time. Thank you.
Hi, thank you so much, Pooja. And I would like to introduce you. She's a consultant embryologist and ex-director academics in embryology, ICET, and again a great friend. Thank you for this. And I would like to carry on the session. May I call the next slide? Yeah, it's a great honor to especially welcome the three chairpersons who have been my mentor. Dr. Ved Prakash Sir, he's the lab director of Nova Southern Fertility, New Delhi. He's also the president ACE India and the founder of IHERA. Dr. Gaurav Majumdar, lab director, Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi. And Dr. Shushma Ved ma'am, consultant embryologist at IVF centers like Maulana Azad Medical College, Life Care IVF, Delhi, MKW Hospital, MediWord Fertility Center, and Ashlok Hospital, New Delhi. Welcome to all the chairpersons. I would like Dr. Ved Prakash to welcome our first speaker, Dr. Danilo.
Thank you, Nidhi, for nice introduction. So our next session is with Dr. Danilo Simadamo. He is the scientific coordinator of Genera Center for Reproductive Medicine, Italy, and is a member of Executive Committee of SIERR Society, Italian Society of Embryology Research and Reproduction. So he's going to speak on beyond euploidy, what else shall we investigate in IVF? So over to Dr. Danilo.
So thank you for your very kind introduction and very kind invitation. And I want to share also Naval's word about how amazing it was to be standing nearby Professor Gardner and hearing his words. So here I will talk about beyond euploidy. What else shall we investigate in IVF? So here's my CV. I'm the science and research manager of General Life Network of IVF centers. And as a background, I'm a molecular biologist. So this is my agenda. Across the presentation, we will go through all the different putative reasons why a euploid blastocyst actually does not implant. So we will go through the different plethora of possible causes, such as maternal causes, paternal causes, laboratory causes, embryonic causes, and finally clinical causes. So let's start with the maternal perspective. We have age, lifestyle, and reproductive history. So is maternal age beyond euploidy in a way associated with the chance that the euploid blastocyst will not implant? This is something that Andres Reig in the group of Richard Scott published a few years ago, in which, as you can see, although minimal, there is a slight decrease in the live birth rate of euploid single blastocyst transfers across different maternal ages, the different shades of blue. And this is valuable for the implantation as well as for the live birth to term. Even when you adjust the results for the quality of the blastocyst that you transfer and the day of biopsy, the decrease is actually confirmed. So this 10%, I would say, absolute decrease in implantation between women younger than 35 and older than 42 when you transfer euploid blastocyst can be supported. But what about previous reproductive history? This is a paper that we published this year in Human Reproduction, in which we were clustering the results of euploid blastocyst transfer in terms of live birth, miscarriage, and implantation rate according to previous reproductive history for each given couple. In blue, you have couples that didn't have any miscarriage before, in green, one miscarriage, and in orange, more than one. And as you can see, when it comes to previous miscarriages, recurrent miscarriage is not associated to a lower implantation beyond euploidy itself. But what about RIF, repeated implantation failure? Again, in blue, no previous implantation failure, in green 1, in orange 2, and in purple more than 2. As you can see, in this case, there is a decreasing trend. Then that for women that we call RIF, so with more than 2 previous implantation failure, becomes significant. So there is definitely something else that is impacting the chance of implantation of a euploid embryo that is probably related with the endometrium. So what I normally, and also in the discussion of this paper, refer to try to explain this is the graph that Macklon and Brosens draft in their theory. What they think is that when you are dealing with a patient who is recurrent pregnancy loss, so RPL, the endometrium might have a defect in receptivity. In other terms, it is hyperreceptive. Which means that you transfer an aneuploid embryo or an untested embryo in general, it will more probably result in a miscarriage. But if you transfer a competent euploid embryo in a hyperreceptive endometrium, like we can see here, you are preventing in a way the issue of miscarriage. On the other way around, when you're dealing with recurrent implantation failure patients, the issue might be of hyperselectivity. In other terms, even transferring a euploid blastocyst or a competent blastocyst might result in an implantation failure that PGTA per se cannot solve. So that must be something else we should look at in order to solve the issue of RIF. Still, we must say that the real proportion of RIF patients is probably lower than we actually think. And if you see again the data from the group of Richard Scott, for those patients that do not drop out and are able to transfer at least 3 euploid blastocysts, you can achieve a cumulative live birth rate which is above 95%. That actually means that probably the real proportion of RIF patients is lower than 5%. So still they are existing, but probably is not that high as we think. What about maternal BMI? Different studies have been published across the years in which even when transferring euploid blastocyst, you could assess a lower live birth rate for patients obese, so with a BMI beyond 30. This is probably and mostly due to an increase in the miscarriage rate, which is not related to the aneuploidies. And this is something that we also confirmed and published this year in RBM Online, and that we assessed already for overweight women, so for BMIs beyond 25. So yes, definitely maternal BMI, it's associated with a lower chance that an embryo would implant. What about vitamin D and TSH? Again, I refer to the study of the group of Richard Scott in New Jersey. Deficient women with vitamin D lower than 20 nanograms ml, insufficient or normal, showed no association with euploid blastocyst implantation. So in this case, we can exclude an association, as we can do, apparently, again, according to Richard Scott's group publications, as we can say for TSH. So it seems that TSH levels are not associated with a higher risk of implantation failure when it comes to euploid blastocyst, even when you are referring to patients that are under a levothyroxine treatment or not. What about paternal characteristic? Paternal age is Ashley TX published this paper. She was clustering the patients, the paternal age according to less than 30, from 30 to 35, and so on, up until more than 35, but more than 45. And apparently the implantation rate, clinical pregnancy rate, and miscarriage rate is not associated with paternal age. What about inset sperm quality? In our study we published in 2017 of over 1,200 cycles, we clustered the patients according to normosospermic, moderate male factor, oligoastenoterato, or azoospermic because of obstructive or non-obstructive reasons. As you can see, there is no significant decrease, but still from ejaculated sperm versus surgically retrieved, you can see there is a trend towards a decreasing implantation. So the numbers were very limited back in 2017. Maybe we should conduct a more thorough study with bigger number nowadays in order to see whether there is actually an association or not. What about sperm DNA fragmentation? Well, in this case, there is still an open question. This is the only study, to my knowledge, that assessed the potential impact of sperm DNA fragmentation on the implantation of euploid blastocyst. And as you can see, there is no difference in any of the outcome investigated, but still for patients that have a DNA fragmentation index above 15%, the miscarriage rate is double as for patients whose DNA fragmentation index is below 15%. So the question is still open, and we also in this case we need more data. Let's then now move into the lab. What about culture media? Is culture media affecting the chance that a euploid embryo would implant? In this study, Werner and colleagues performed a non-selection study on sibling oocytes, in which half of them from the same patient were cultured in a sequential media, the other half in a continuous media. They were brought to blastocyst and biopsied. Then they transferred both embryos with a double embryo transfer approach. And in case they had singleton pregnancies, they used DNA fingerprinting on the baby born to assess which one of the two embryos implanted. In case of no implantation, none of them implanted. In case of twin pregnancy, both implanted. With this kind of very elegant study that they use also across several other papers I will show you in this presentation, they showed no impact of either sequential or continuous media on the implantation of euploid blastocyst. And this is something that we also confirmed with a quasi-randomized trial that we published in JARG, and also Deng showed in the same journal. So apparently the culture strategy in terms of continuous or sequential is not affecting the chance of implantation. And this other study from Junot, they showed that they compared with the same approach of sibling oocytes split into two, dynamic culture on an oscillating device versus static culture, then again double embryo transfer and fingerprinting in case of singleton on the baby born. The sustained implantation rate was absolutely the same, whether you use a dynamic culture or a static culture. So also in this case, no association. What about using time-lapse parameters? So is time-lapse adding some predictive value beyond euploid itself? According to the randomized control trial in 2014 by Young and colleagues, it seems that on the first transfer, if you select the embryos also based on a morphodynamic evaluation, it seems that you might have a higher chance of implantation. And also Momusoglu showed in RBM Online that apparently the time that an embryo takes from the start of blastulation up to full blastulation is associated to the implantation of euploid blastocyst. And our group, together with Ivi, together with Marcos Meseguei and Ivi, showed that the time of morulation, whether it is below 80 hours or beyond 80 hours, together with the quality of the trophectomy, also is associated with implantation of euploid blastocyst. So it's better to have an embryo of a high quality that makes the morula before 80 hours. What about the operators? Are the operators impacting differently on the chance that an embryo would implant? We published 2 papers across the last 5 years, one on biopsy operators and one on ICSI operators. And we show that different operators in different shades of blue when it comes to biopsy do not have different impact in terms of euploid blastocyst implantation. So obviously we are dealing with equally trained operators that before being habilitated to this kind of procedure, at least perform 30 biopsies with success. And then we have ICSI operators also, in this case 14 operators were compared. The cumulative live birth rate of the patients whose eggs were inseminated from these operators in terms of euploid implantation was absolutely the same, so no impact. What about the blastocyst biopsy protocol? You know that you mainly can have two, one that entails arching in day 3, in which you make the hole in the zona and you bring the embryos to the blastocyst stage, and then you just take these cells out of the embryo, or the one that we are using in our centers, in which we do not open the zona in day 3, but we do a sequential zona opening and trifecta biopsy procedure at the same time in day 5, 6, or 7. There is a randomized control trial from a Chinese group that showed that although there is a 10% higher implantation rate, live birth rate, when you use the protocol without arching, this difference was not statistically significant. Instead, according to the matched case control of Rubino and colleagues, there is a higher and significantly higher implantation when you do not open the zona in day 3. It's common sense, obviously, that when you take out cells from an embryo, you should limit the number of cells that you remove to no more than 15. This is the data from Shelby Neal that showed that implantation rate of euploid blastocyst is unaffected from 5 up to 15 cells, but if you take more than 15 cells out of an embryo, then you can assess this decrease of implantation. What about oocyte vitrification? Again, the group of Richard Scott, the first author is Foreman. They took sibling oocytes, again, divided into two. One was straight away inseminated, fresh. The other half instead was vitrified and warmed the same day in order to be inseminated. Again, paired double embryo transfer, DNA fingerprinting in case of a singleton pregnancy. And at the end of the day, you see again, whether the euploid blastocyst derives from a vitrified egg or a controlled fresh egg, the implantation rate and the live birth rate are absolutely the same. And this was confirmed also by the group of Jamie Griffo on long-term frozen eggs up to 1 year. When you match the patients according to the age, the live birth rate, whether the embryos derive from a fresh eggs or a frozen egg, is absolutely the same. What about prolonged cryostorage when it comes to human blastocysts? This is a paper that has been published this month from our group in RBM Online. We show that, as you can see, there is, according to the increasing days from the time of vitrification up to the time of warming, there is a decrease in terms of live birth beyond 3 months. Yet, this is imputable to the fact that the best quality embryos and the faster growing embryos are transferred as first in a sequence of embryos from the same, of transfers from the same patients. Therefore, in these groups here, you had lower quality embryos. So if you adjust these results for the quality and the day of biopsy, at the end of the day, the cryostorage duration is absolutely not associated with the live birth rate of euploid blastocyst, even up to more than 3 years. What about embryonic then characteristics? Well, we know that the quality and the day of biopsy are associated with implantation, and there is a decreasing trend. So the lower the quality of the embryo and the slower its development, even across euploid blastocysts, you can certify a decrease in implantation according to both Shear and Zahn. But I want to assess that still day 7 embryos and embryos of a poor quality, which means lower than BB according to Gardner and Schoolcraft, although they have a limited implantation competence, still they can implant and make babies, therefore representing a valuable source of putative live births for poor prognosis patients. What about abnormal cleavage patterns? I selected for you this one that probably is the most evident, direct unequal cleavage, in which one zygote goes into free cell, and it can happen directly instead of 2. It can happen at the first, second, or third mitosis. The biggest database, to my knowledge, is the one from Cornell University, with over 21,000 videos. 1/4 of the embryos, of the human embryos, show this kind of events. If you don't have any abnormal cleavage, you normally have 60% blastulation rate. If you have a direct unequal cleavage at third, second, or first mitosis, then there is a huge impact on the blastocyst rate, which is bigger the earlier the direct cleavage event occurred during post-zygotic divisions. But then the euploidy rate of the blastocyst that you can obtain is unaffected, as well as the live birth rate. So abnormal cleavage patterns have an impact on blastulation, but apparently not on implantation of euploid blastocyst. What about mitochondrial DNA? This has been used for several years, I would say, and then it disappeared as a possible approach complementary to PGTA. And this is probably due to the fact that 3 very high quality papers were published showing that there is absolutely an area under the curve of 0.5. So it's just like tossing a coin of the mitochondrial DNA level with respect to implantation competence of euploid embryos. So absolutely no association, even when you refer to paired embryos, one implanted and one not implanted from the same patient. What about intermediate copy number? So these kind of things that are used to call mosaic embryos based on a single biopsy. So normally each of these bars is a chromosome from 1 to X and Y. This is the threshold for monosomy. Here is chromosome X and Y in monosomy because it's a male embryo. This is the threshold for trisomy. And normally you have chromosomes which are in disomy. But if you have a chromosome like this that stands in between disomy and trisomy, or the other way around, disomy and monosomy, they are called intermediate copy number, and they are used to call mosaic embryos also in a clinical activity. Although it is true that this kind of events might be due to the presence of both euploid and aneuploid cells in a biopsy, these are also due to contamination of DNA, noisy results misinterpreted as intermediate copy number, preamplification bias that causes technical artifacts, cells in the synthesis phase of the cell cycle that physiologically have more DNA, and also poor quality of a biopsy. Also, all these biological and technical artifacts might result in intermediate copy numbers that can be used to misinterpret an euploid embryo as mosaic. So that's why we perform a non-selection study that has been published this month on the American Journal of Human Genetics, and Antonio Capalbo from iGenomics is the principal investigator. At iGenomics, they knew which embryos would have been called mosaic at other centers because of low-grade or medium-grade mosaic, but they called them euploid. So in a blinded fashion, our clinicians actually transferred these embryos without knowing their possibility they would be mosaic, called mosaic at other centers. So with this blinded approach, unbiased approach, we could show that euploid, the low-grade and medium-grade mosaic have absolutely the same chance of implant and miscarry and result in a live birth. So no difference. So at the end of the day, we think it's meaningless to call embryos mosaic based on intermediate copy numbers up to 50%. And I'm approaching the end of my presentation. So what about the clinical thing? Well, you can have ovarian stimulation. In this study from match case control from the group of Richard Scott, a natural cycle without without stimulation versus control ovarian stimulation, there is absolutely no impact in terms of the euploid implantation when you transfer euploid blastocyst. In our data set from dual stim group, so first and second stimulation in the same ovarian cycle, we compare the clinical results from embryos produced from eggs retrieved in the first stimulation versus the second stimulation, so in an anovulatory wave. And at the end of the day, the euploid blastocyst had the same chance to implant and result in a live birth, regardless of which phase of the ovarian cycle the eggs were retrieved from. What about trigger of ovulation? This is a paper from our group published this year, in which we showed that whether you use generate child agonist or urine HCG to trigger ovulation, the euploid blastocyst implantation rate is the same, so no impact. And this was confirmed a few years ago also from Maikiani and colleagues, no impact also for the miscarriage. What about the response to ovarian stimulation? Again, the group of Richard Scott, whether the euploid blastocyst derives from patients whose AMH is below the 10th percentile or between the 20th and the 70th percentile, the euploid blastocyst implantation rate is the same. Whether the eggs derives from patients that collect few eggs, let's say in the less than 10th percentile or between the 20th and 70th percentile, the euploid blastocyst implantation is absolutely the same. So poor ovarian response is not associated to a lower competence. What about fresh or frozen embryo transfer? To my knowledge, this is the only randomized controlled trials on euploid blastocyst. They showed that if you transfer the embryos after vitrification rather than fresh, the implantation rate after vitrification is higher with respect to fresh. This might be imputable to an embryo dyssynchrony issue. So the fact of transferring slower growing embryos fresh might impact the implantation potential. Instead, if you freeze slower growing embryos and you transfer them in a vitrified warmed single euploid blastocyst transfer, the implantation rate is the same as day 5, so faster growing embryos. These are the data I gained from the group of Scott. Franising is the first author, but it's in a way telling us that the advantage of freezing embryos, especially if they are slower in their growth rate, is mainly to re-establish the synchrony with the endometrium. Endometrial preparation, whether you use natural cycle or hormonal replacement, in this randomized controlled trial from Greco, euploid blastocysts show the same implantation potential. And this is our data we submitted to the ESHRE 2021, in which even when adjusting for the quality of the euploid blastocyst and the day of development, the chance of implantation
Sorry
was
to disturb
independent.
you, sir. Time's up, so please conclude soon.
Yeah. So I want just to conclude that also personalized AT, according to ERA test, did not show any benefit in terms of implantation of euploid blastocysts, according to these 3 studies. So to conclude, human embryos, the competence of an embryo derives from its developmental competence, which is the chance that it can make a blastocyst, its genetic competence, which is the chance that the chromosomal constitution is euploid, and then there is reproductive competence, which is another kind of competence, that is the chance to implant. You might have euploid blastocysts that do not implant. The factors that impact reproductive competence at present are probably maternal age and maternal BMI, previous experience of RIF, maybe sperm quality, we need more data on this, definitely the trophectoderm biopsy protocol that you use, and blastocyst quality and day of development. So with this, I thank you for your attention, and sorry if I was late.
Thank you so much, sir.
I think we will take a question at the end of session now.
Yes, sir. At the end of the session in discussion, sir. I would like to invite Dr. Gaurav Majumdar to please introduce our next speaker, Dr. N.C. Chimote, sir.
It is my privilege to now invite Dr. Chimote. He's the managing director and founder at the Vasundhara Fertility Center, Nagpur. And he's going to be talking on the topic blastocyst culture. Is it add-on or now a routine practice? Over to you, Dr. Chimote.
Thank you, Gaurav, for kind words for me. In fact, it's a very, very important subject because blastocyst transfer, whether it should be add-on or a routine practice, that's very important. Because that is the question, a $1 million question for every other clinic, for the clinician as well. Because, I mean, the endometrial response and the ovarian stimulation, that's very important. So I'm going to start with this, that yes, whether it should be add-on, it should be a routine practice. Now, as we know that since the advent of, you can say, Gardner, who started sequential media in culture system, and that really went into extended culture, the embryos. Because previously we used to do day 3 transfers only because we didn't have media to go to blastocyst stage. Now, this media is available very routinely by so many companies in the market. Now, let me tell you that the first pregnancy, the live birth, was reported in 1985 by Cohen et al. And then the first live birth was reported by Bolton in 1991. Now, let me add to this is that in 1998 itself, we produced blastocysts in the laboratory using no sequential media, yet using universal media, which was supplied by the local, you can say, agency. So what we thought was that, yes, of course, when you have the potential, to grow into blastocysts, only those embryos will go to blastocysts. That was the basic philosophy behind it. Now, since then, we have so much of blastocyst transfers. That is, in 2001, it was just 12%, and 2012 is documented. But yes, now it is almost 50%. Most of the centers do go in for blastocyst transfer. But when we think of blastocyst transfer, we'll have to think of risk and the benefits. So why do we go for blastocyst transfer, that is extended culture? It is basically the physical synchronization. What we think is that we have a very set philosophy in our mind, or the, you can say, science in our mind. Yes, it gives you better endometrial synchronization. And because of which you have high chances of implantation. Now, as in case of IVF, you have given the hormone injections, because of which you have physiological levels of estrogen and progesterone. That actually enhances the endometrial development, like day 5, like natural cycle. And therefore, when you have a very natural condition in the uterine cavity, obviously the implantation rate will improve. Again, in case of extended culture, when you go from day 3 to day 5, you have activation of embryonic genome. Only on day 3, you can see that all 8 cells, embryos, giving you at least a sign of compaction. And therefore, that is the activation of genome. Now, when you don't see such things, such embryos really will not survive, or they will not implant. So, extended culture allows embryos having potential to undergo activation of embryonic genome. That's how you can really screen out the poor quality embryo. But on day 3, if you see, say, the blastobest 5 or 6, maybe even 7, but if they are not aligned properly, if there is no communication in between them, obviously you can set them aside. Now, the question here is that these are in vitro culture. Whether the survival of the embryo, because it depends on so many things, so many oxidative stresses, so many laboratory stresses, and it cannot equate the in vivo survival. So it depends on your culture system, that's the media, the number and types of incubators, at the same time, oxygen tension. I have tried I have tried because you can say I'm working on this since 1986. And I saw that when there was a conventional, you can say, incubator, in such cases where you have the routine things and therefore the blastocyst formation was less, the percentage was less. But when it came to bench top small incubators, wherein you have a 5 to 6% oxygen, you have better formation of blastocyst. So, what is important in this is that you select the embryos for blastocyst formation, wherein you have 7 to 8 cells embryos on day 3. So you put them in culture fluid, which is sequential media for the development of blastocyst. Obviously, you are reducing the number of embryos. So you're losing some embryos. Now, these embryos, we do not know because we are not gods. We select them. What is important is that if such embryos, even before that, because since I'm a somewhat, a kind of a old school person, you can very well see that even such day 3 embryos, even before the blastocyst culture came into practice, yes, even the embryos which were not supposed to become blastocysts in the laboratory, they can get implanted and they can result in a pregnancy. So that's the thing, in case of blastocyst culture. Now, as you see that it improves the transfer of a viable embryo. That is what we say, reported by Hart in 2013. But this blastocyst, they cannot guarantee you euploidy. That is important. So far as whatever system we have given by, Gardner, Schulcraft, and all those people, either as blastocyst or stage is not accurate to identify whether there are chromosomal abnormalities. And chromosomally abnormal embryos can become blastocyst, even that was reported by 2014. That's an irony. So we have 12 meta-analysis in which it says that overall, it says that a significant increase in the live birth rate per started treatment. Remember this. When embryo transfer was carried out at blastocyst stage, compared to previous stage, the odds ratio is 1.4. There is another meta-analysis by 4 people saying that number of births from one egg collection, one OPU, are significantly higher. That is, odds ratio is 1.58, almost 1.6 in embryo transfer carried out at previous stage compared with those at blastocyst stage. So, with a decreased cumulative birth rate with extended culture, maybe because of number of embryos that do not reach blastocyst stage are discarded and not because of eligible transfer. So, who we are to decide which embryo is correct, which embryo is not correct for the transfer when you go for blastocyst culture. Because these embryos, if they are frozen at that particular stage and then frozen and then transferred successfully, they give you pregnancy. So it means that minimizing embryo wastage in vitro culture, it can lead to the possibility of more pregnancies, and therefore blastocyst culture is not preferred sub-school stream. Then again, what do we think of chromosomal anomalies? When you go for screening, well, of course, day 5 biopsy definitely gives you better screening, you can say, facilities that can improve the implantation and pregnancy rates. Many papers are there. So, effectively freezing all embryos, the routine use of the frozen and thawed embryo transfer that has been debated. No one says that once you produce the embryos, go for blast, freeze them, or day 3 embryos, freeze them all, and then transfer it. It has been debated. So what we think is that suppose if you go fresh cycles, then in case of fresh cycles, obviously, you will think of pros and cons of D5 versus D3. Now, when we think of blastocyst transfer, we always have this particular equation in our mind. What? That the one that goes to genome activation goes to blastocyst, and therefore that's the best embryo. After transferring that embryo, do we really get the best perinatal results? Does it happen? The conclusion is, in contrast with the findings of a number of other studies, blastocyst culture in Australia and New Zealand is not associated with an increased risk of preterm or low birth weight or HGA for significance. So it is very important. I mean, see, this is the report in 2015. Now I will give you a report from 2013-15. They said that all right, when you transfer at blastocyst stage, it is associated with a higher risk of preterm pregnancy. That is less than 37 weeks. And very preterm, that is less than 32 weeks, it is 1.22 compared to those with resulting from transfer cleavage embryos. So these are the reports. They are available. These are the papers which I am showing you on your screen. Now, the conclusion evidence for this increase in preterm delivery can only be provided by adequately powered RCTs. It means that we are falling short of studies, and therefore we always try to argue on certain things. You will have to believe in your own clinics research. You'll have to think of it. Now here, again, after its perinatal outcomes in single pregnancies resulting from blastocyst versus sterility. What it says? It says that blastocyst stage is associated with high risk of very preterm childbearing. But it does not confound with the outcome data, perinatal outcome data for the safety of ET of the blastocyst stage. So everybody is taking care while making the statement whether to do blastocyst transfer or not. Now, Again, I will show you some results. Here are the results. This is from Australia and New Zealand. They did not find any kind of preterm delivery. You can very well see singletons, SAT, twins. You will find almost the same percentage. Look at this. So there's no difference, day 3 or day 5. So why so much of chaos? Again, when it comes to blastocyst transfer, it comes to monozygous twins. Yes, it does give you more chance of monozygous twins in case of blastocyst transfer. Now, the reason could be alteration in zona pellucida induced by extended culture. Again, so the media which we use for blastocyst culture can be one of the reasons. One will have to think about it. All, not only clinicians, but also the employers will have to look at this. Then again, there is another paper in 2003, which is a kind of a hallmark. Reading my monozygote twinning to blastocyst transfer. Yes. Conclusion is that compared to day 3 ET, blastocyst transfer appears to significantly increase the incidence of monozygotic twins. Then in 2020, again, infertility, again this paper was released, and it said that yes, differences in monozygotic twins rates exist between individual IVF clinics. Individual IVF clinics suggesting that the variation in practice patterns may contribute to this debate. So their study actually noted that the sequential media is an independent risk factor of fresh, but not frozen cycles. Remember this, fresh and frozen cycles. So another, you can say, problem with blastocyst transfer is that large birth gestational age babies. Now you can see a gender-adjusted birth rate, Z scores, are higher for newborns after day 5 versus day 3 in cancers. So it's an increased proportion of large for gestational babies, age babies, may be the reason. That meta-analysis by Bhattacharya and Maheshwari, very important paper. They are quite conservative about this. They say that it is a decreased risk of intrauterine growth reduction in blastocyst transfer. And you can argue, yes, the type of culture media in the extended culture could be a responsible factor for large gestational age babies. But yes, DWOs in 2015.
Sorry to interrupt you, sir. Time's up, so please conclude.
Okay. I'll try to do that. Give me 2 minutes, sir, please. Please. So, in congenital anomalies as well, babies born after blastocyst transfer, they are on a higher side as compared to this thing in 2014. Now, also in case of female ratio, male-female ratio, yes, of course, it does alter blastocyst transfer. So why do we go for blastocyst transfer still now? This particular picture can show you that yes, it is the increased birth rate per fresh embryo transfer. Remaining things you will have to give away. And therefore, we'll have to change our focus. We'll have to change the status quo at the moment, change it for this thing. That is, when we report IVF success, it should be from live birth per cycle to ultimate cumulative healthy baby rate as per sorted. So follow-up studies are there. You will have to think about it. You'll have to have better selection on day 3 if you want to avoid day 5. And therefore, you will have to have time-lapse the thing, which you will have to think. We'll have to learn more about it. Now I will give you the result of ad-hoc sector. Let me tell you, there is no difference in preterm delivery so far as cleavage or blastocyst stage is concerned. So I conclude the transfer at blastocyst stage is preferred as it increases the rate of live birth as compared to day 3, number 1. Number 2, similar monozygotic twins produced in day 5 versus day of transfer, and the follow-up for chromosome anomalies is extremely challenging and it is difficult as yet. Thank you so much for giving me 2 minutes extra, and thank you so much.
Thank you, sir. Thank you for the wonderful presentation. I would like to invite Dr. Sushma Ved ma'am to please introduce the next speaker.
So our next topic is PGTA. Does it impact IVF success? The speaker, Dr. Jayesh Amin, Clinical Director of Wings IVF Women's Hospital, Ahmedabad, Secretary IFS, Gujarat Chapter, 1 Times Health Icon 2021. Welcome, sir. Over to you.
Sir, please unmute your mic, sir.
Yes, thank you so much for inviting me. And I'm just sharing my slide. I think so my slide is visible.
Yes, sir, it's visible, sir. Yes, sir.
Yes, yes. So basically, the topic is PGTA. Does it impact? I think so directly we can start this lecture. And the lecture is PGTA. Does it impact the IVF success rate? So let me tell you the evolution of the IVF success rate. And this is the first live birth which was occurred by the natural cycle IVF. And look at in 2004, the evaluations by the transvaginal sonography and cryopreservations and so what. And looking to that, our evolution, still we know that the 40%, that 30% of the tip of the pregnancy is having a live birth rate. Rest of the other things are having a 10% clinical miscarriage. The preclinical pregnancy loss is also 30% and implantation failure is 20%. So I think so this is the 60% where people are ending the complications, maybe because of the aneuploidy. That is what we can think about it. And to treat, I think so we have to find out this aneuploidy. This is the first live birth of 1978 of Louis Brown. And by that, if you see, consider the IVF success in the fresh cycle IVF success in agonist protocol will be around 21.3% will be that. So I think so whatever the data which was published, but still if I focus on my data and look at this Sankara et al. Which was published in 2008, that we can say something about the average live birth rate in all the age group in fresh cycle IVF is around 21 to 25% will be there. If you go by the freezing, which was launched with special vitrifications, and as we say, how many number of the oocyte is required. And this is a good publication that if you have a good prognostic factor like more than 15 is, then the success rate of IVF goes beyond 61.5%. So 60% will be there. And if you have a more embryo in a cryopreserve, might be possible in the good prognosis conditions, your success rate might be increasing. But why the other people are not going to succeed? What is the reason? And we know that is it the embryo is the reason, or it is the window period will be the reason. And look at the evolution, the registry, which is saying something about that. The whole world is shifting their practice. It's not about the publication. People or doctors or whatever the organization, it's not about all the publication they wait for IVF to ICSI. I think so India is the country where the ICSI for all since so many years. And we can also consider that people are shifting that practice from 5 embryo to 3 embryo to 2 embryo to 1 embryo. And if you ask me that, if you see the SART registry in 2016, that a lot of now centers are shifting their practice to freeze all. And I know that in COVID era also, and still at present also, the good clinic, those who are doing good vitrification, they're shifting their practice around 90% to freeze all strategy to improve the success rate. So what we are coming to conclude, because my basic funda is to improve the success rate. Until now, we all are approved that we are shifting our practice to multiple embryo to single embryo transfers, and our future is single embryo transfers, blastocyst transfers, and the IVF success rate. And that's why the need arise that how can we choose the single embryo transfers. Look at these publications of recurrent pregnancy loss and expected management. Why I'm saying that, the expected management will always have a higher time to get pregnancy interval. And this is the 5 years multi-center trial in 2020-21, which was published by the Simon. And what is the inference of this publications? They have a group, 3 group is there. One is personalized embryo transfer, one is freeze embryo transfers, and freeze cycle embryo transfers. So what is the difference that I want to tell you in this my lecture, to pitch it out to you, that the personalized embryo transfers do have a higher success rate compared to FET, compared to fresh, to per cycle embryo transfer success rate. So we are saying about the per embryo transfer attempt. We are saying about the per IVF cycle. So this is also intention to treat. So the another word which was adding in the IVF success rate is intention to treat to the patients, that getting the pregnancy output in per cycle also, and also the per IVF cycle as well as the per embryo transfer. So we are concluding that yes, this whole study will tell us that the personalized, more personalizations, more using all the genetic advances will improve the success rate. Not about that. Now factors affecting. So we need to see something about that. Is it PGTA? That means for aneuploidy. So which are the factors which are affecting the aneuploidy in the ART? Of course, we all people are knowing that age is increasing the aneuploidy. So female age is most responsible. And this is what the retrospective data of the 13,000 retrospective data of tropoectoderm biopsy, and which was says that aneuploidy rate is very higher when the age is less than 24 and when age is more than 35. And if you ask me the cutoff limit of the age, when the age is more than 43, almost 100% aneuploidy which was visible. So we need to understand that aneuploidy is always having increasing abortion, increasing the chance of the implantation also. So it's all about the patient, that to get the chance or the choice is more important. And this is also, again, this is one publication which is saying that as we go above 40, the almost about around 43, the aneuploidy rate is very high. It is similar. So cutoff value of 43 to 45 aneuploidy was visible around 90 to 100% aneuploidy is visible. And is also we know that when we have about the abortion, if it's spontaneous abortion, it was found about 50 to 60% aneuploidy is there, 6% in stillbirth, and 0.6% in live birth is there. So we need to focus about the aneuploidy will be there. What about the pro-PGRT argument? So before to start something that PGTA is really increase the success rate, the argument is that basically that embryo aneuploidy are mostly meiotic on origin, tropoectoderm biopsy is safe and reliable. So don't say something about your loss of embryo is there. And clinical outcomes are significantly superior for transfers, allowing the perform universal SCT policy. So people are more focusing on single embryo transfers. People want to reduce the complication like miscarriage rate. That is what the basic funda of the pro argument of the PGTA. And we know that at present, whatever you're using, the artificial intelligence or the time-lapse technology, which are still not at par, the alternative part of the PGTA. So PGTA still is a more sensitized treatment compared to the time-lapse technique, and as well as the other AI software which are available. It's not alternative. So still we need to depend on the biopsy or PGTA. And let me tell you something about this. Is a good circle which I took from some other slide. So I'm thankful to that guy who is making this circle. But this is a good thing that we are facing in our day-by-day practice. That what happened that patient is always in the demand of a per transfer success. They need a single embryo, might they need double embryo, but they need increase in the per cycle transfer success rate. They always in the search of decreased empirical treatment. They always in the search of something like that higher success rate. And being organizations, being a doctor, that what sometimes we are suggesting to that if the studies are not showing no effect, then we are choosing this alternative treatment. And also indirectly and directly the patient belief and risk of exploitations are going on. So we know that IVF is an industry and research funding is difficult. So until and even the publications will not go, there are a lot of community people where because of the demand we need to shift something a good technology which is called the PGTA. And also the aneuploidy, about the aneuploidy, we say if the abortion ratio is spontaneous and 40.6% abnormal aneuploidy, which was visible in out of 48.7% abnormal POCs. If you have a own oocyte, then 62.7% abnormal when the count is less than 5 million. So male factor is also important. Look at the ovum donations. There are a lot of studies, even you are doing ovum donation, there are 12 to 26% abnormal aneuploidy which is generated in the ART clinic, which is also responsible for or delaying the time to get pregnancy interval, delaying the per transfer success rate, even the egg donation cycle. We should believe that is it really, because when we are talking about that, then somebody is always saying that, doctor, you can do something mild stimulation, but nothing. Stimulation is never going to be increase your aneuploidy rate. Let me tell you something. This is also that number of the oocyte retried by the different stimulation technique and different stimulation protocol, they do not increase any aneuploidy at the end of the day. So what it will increase? The number of blastocysts? No, the number of blastocysts also not increase. This is also study which says that number of blastocysts will always having a sustained level of the aneuploidy, but when age increasing, the aneuploidy rate is increasing. Look at here, 40 to 42 years, then you can have a higher aneuploidy rate, is around 81.3%, 82% when the age is more than 40 years. So this is acceptable fact that yes, age is going to be increased. Is any other factor which is also going to be added? It's only maternal age factor, it's not paternal. Yes, this is the paternal age factors. And in our day-by-day practice, sometimes we also having a patient when the paternal age is more than 50, especially in the donor egg cycle. When you are using the paternal age, look at this publications of Javier Gracia, which says something when the more than 50 years, it again shows that the paternal age is higher than 50, then the chances of aneuploidy is higher when we are treating the couple when the age of the paternal age is less than 39. So it is also dependent that the PGTA is also important when the paternal age is higher. It's only the two factor. No, this is the third factor that where we are looking for the increasing aneuploidy. Where? So high rate of aneuploidy, mosaicisms, and abnormal morphokinetic development in case of low sperm count. And look at this publication, can have a distribution of less than 1 million per ml, 1.5 million testicular sperm and the normal sperm. By looking to that, we can easily say that when the count is less than 1 million and the testicular sperm, the aneuploidy rate is very higher. So in the testicular sperm and count, which is less than 1 million, so it's not like that in less than 5 million. So it's less than 5 million, the threshold might be changing. So less than 5 million, we can say, and the testicular sperm, which shows something about the aneuploidy. So need to arise to see PGTA also in the case where the count is less than 1 million, and also the testicular sperm with the miscarriage rate and ongoing pregnancy rates will be lower because of the higher aneuploidy rate. As far as concerns the difference in the pregnancy outcomes, donor rate. See, let me tell you, there are 2 publications of donor egg. Still, we are concluding that, but we cannot deny that 10 to 12% of minimum aneuploidy and more than 26% of aneuploidy rate, which was observed in the donor egg, which will be increased by the other factor. Maybe the paternal age will be there. So the days will be required when the paternal age and donor egg, paternal age is very higher and donor egg might for the single embryo transfers, might you improving success at PGTA will be the way forward. So to conclude, what I am saying that the aneuploidy rate is only increased by the advanced maternal age. Aneuploidy is also increased by the paternal factor, like age of the paternal factor more than 50 years of the age. Aneuploidy is also increased when the count is less than 1 million testicular sperm. It is not going to be increased for the other like gonadotrophins and ovarian stimulations, or the estradiol level, or the number of embryo generations, or long-term cryopreservations. So these are the things that it will be consistent when the aneuploidy, when the age is more than 43 years, we find out the consistency around 90 to 100% of the embryos are aneuploidy when the age crosses the threshold of 43 or 45. Looking at that means, should we opt PG to decrease the rate of miscarriage? So I'm talking about, it's only this indication. I'm also talking about that the recent publication of the ASRM. And this is what they previously, because availability of the fish and other technique, now the availability of the CGH array and the next generation sequencing, now we are able to find out the certain genetic factors which are responsible and considered as the idiopathic cause of the recurrent pregnancy loss. So by this publications and the implement of the CGH array, most of the 90% of the recurrent miscarriage, where we can find out the cause of the recurrent pregnancy loss. And what we want to say something, majority, it is always depending upon the genetic cause will be there. And that's why what ASRM is already say that where ASRM BOH workup, right? Pregnancy loss workup is even normal. You should go by the karyotyping of the husband and wife, and also you can suggest the genetic testing from aneuploidy, as this couple are very higher chances of the aneuploidy to prevent the next abortions. So this is about the recurrent pregnancy loss, that what we want to say something about it, right? Now, looking to about the the morphology, what are the limitations? That are we on the pitch that morphology is going to be a last answer, or the morphokinetics, which will be or the artificial intelligence which is preventing, or which is the alternate solution of the PGTA? And this is a good publication of Capalbo et al., and which is having a single embryo transfers with the double embryo transfers in different centers. And what it says, single embryo, double embryo transfers, also it says something day 5 transfers and day 6 and day 6. Time is also same. So as far as concerned the morphology and concerned the day of the embryo, what will be the conclusion? The conclusion is that whether the embryo is excellent, good, average, or poor, there are some chances of. So morphology cannot be raised on to ensure the transfer of chromosomally normal embryo. By this is the Capalbo et al. Studies when the patient ages, mean age is 37.5, the 956 euploid blastocyst which was observed, and taking a biopsy of the trophectoderm, it says that morphology will not going to be the answer regarding this alternative answer of the PGTA. So do we agree on the present genetic technology and detection? Because when we are talking about the pro PGT or PGT to improve the success or application of the PGT, what we are worried? We are worried about, are we on the page that these all technology are really good to give up for the less false positive and less false negative, so more sensitivity and more specificity result? And this is what I want to say. There are a lot of comprehensive chromosome screening techniques are available, and meta-analysis which say something about that it will be improves the embryo selection. So this is the meta-analysis which say that whatever the technique like CGH array and the NGS which was at present will improve the embryo selection. And these are the evaluation of the different techniques, and at present we are on the verge of NGS, high resolutions NGS. I think so iron torrent, which will be the choice of the treatment, which is fast, cheaper, and we can get the result as early as possible, especially in the PGTA. This is the advantage. This is the cheaper. This is the advantage of NGS, that is also always detect the segmented detections. And I know that because of the high resolution, that over detections of the mosaic embryo, which will create a noise in the industry, that how we can go forward to use this PGTA technique. But these are the some NGS and CGH area, that concordance ratio, when it is abnormal, embryo is abnormal, the sensitivity is 100% and specificity is 100%. So if the embryo is aneuploidy, so these are the different publications which are in favor that when the abnormal embryo by the NGS and CGS both is having a higher sensitivity of 100% to detecting its abnormal. Different evaluation in the biopsy. We all people are knowing about the day 5 biopsy. And when we come to the day 5 biopsy, and people, those who are opposing PGTA, they say something about the loss of the embryo. And this is about the equivalence, the biopsy blastocyst and non-biopsy blastocyst, the sustained implantation rate, which was found. So that will be something that by the loss ratios will be now minimum in the expert hand, that we are coming on the next slide when I'm showing my own data. Now, what about the consistency, means the last publication of different embryologists. So experienced embryologists, this is the publication of the 6 embryologists for the PGTA in a different laboratory, and saying that what is the output if they are really experienced. The output is there, the detection of the mosaic, detection of the segment, the no-call ratio will be the same. And if your all 6 embryologists are very trained, then their output will be remain same. So it is all depending on the how your clinic is experienced, right? How many years they have a good teamwork for detect the PGTA and having a sending the biopsy. By the sending the biopsy, we come to know that it may be a euploid, it may be aneuploid, it may be a mosaic, it may be a chaotic, it may be a multiple chromosome abnormality there. We are also putting all this, that mosaic ratio is more higher in day 3. We are also now concluded that day 3 biopsy is having a loss of embryo ratio is higher because of the 1 or 2 cell is required, where we are now concluding that day 5 is the forwarding answer to detect more survivability of the embryo in terms of the blastocyst biopsy. Now, what is the need of PGT? That means, now last question, that is what my topic is there in today's scenario. Of course, to increase the IVF success rate, of course, to decrease the abortion rate in advanced maternal age, of course, in the recurrent pregnancy loss, of course, I think so, to provide the healthy baby in carrier decision couple, that may be PGT-SR or PGT-M, and to answer the recurrent implantation failure, that what is next. So improve the success rate, that means single embryo transfers. The implantation potential of euploid embryo was the same despite different morphology and development rates. Implantation potential of euploid embryos was the same. So these are the studies which are in favor in a good prognosis. I think so. The Foreman et al., the Scott et al., the Young et al., they are having a good prognosis, more than 17 oocyte collected, and they are always in favor that PGTA will improve the time to improve the per embryo transfer success as well as time to decrease pregnancy interval will be there. And I will like to say something. It is also the last publication of the advanced maternal age, which is also in favor that 100 patient which was recruited for the PGDA and 105 patient which was recruited for the non-PGDA. And look at the time to pregnancy interval. Yes, it is reduced in the PGDA group. If you ask me the number of the transfer, it is reduced in the PGTA group. And so mean cost of the baby is also reduced. So what is the conclusion of this all publication? That first, it is significant increasing delivery rate, drastic decrease in the miscarriage rate, time to pregnancy, number of transfer was reduced, and theoretical and cost efficiency is also similar cost than the blastocyst transfer in advanced maternal age. What about the recurrent implantation failure? We don't have a lot of more data, but it is also saying this is a pilot study, which is a comparison of 45 patients of those who are having a recurrent implantation failure versus no recurrent implantation failure.
So time is up. If you could
only
conclude,
last 2 minutes. Last 2 minutes.
Okay, sir.
So no recurrent implantation failure versus PGS, which was not offered in the recurrent implantation failure.
and look at the success rate, I think so is a clinical pregnancy rate which was observed in PGS recurrent implantation failure 68.3, which was no offered PGS will be around 22%. It will be same as those who are having a no recurrent implantation failure. So it will be a going forward to improve the success rate, especially in the recurrent implantation failure. Male factor, I'm not going to discuss more, but this is also improving success rate by detecting the aneuploidy embryo, and also reduce time to get pregnancy interval, and also reducing the miscarriage rate, which is especially in the when male count is less than 5 million, and the azoospermia. So recurrent pregnancy loss, and this is the last my slide, which I say something recurrent pregnancy loss with PGTA. If you have a normal expected loss by this publication, the case series report, the normal expectation by SART data of recurrent more than 2 embryo loss, where the normal expectations of the pregnancy loss is around 27.1% when age is more than 35, which was after PGS only 8.6%. So it is also say that aneuploidy is more responsible in the recurrent pregnancy loss where PGTA will be offered. So I will like to say something to conclude my whole conclusion, that is it PGTA improve the success rate by putting this meta-analysis, and this meta-analysis is saying that no benefit of PGTA on clinical life, means overall live birth rate is no benefit, but it decreased miscarriage rate with PGTA, is decreased multiple pregnancy rate with PGTA, it improves sustained implantation with PGTA. And lastly, I can say something about that. My conclusion of my slide. This is my number of the embryos where people are creating a noise that around a lot of 20% or 25% embryos are mosaic. And this is my 2,520 patient which was sent in a single genetic center. 4,000, around 5,000 embryos was sent. And out of that, 52% embryos. This was the data of Gene Explore in Ahmedabad. I also sending around this much of embryo to iGenomics also. And I have also my data to sending on the Lilac Institute also. All clinics are given me a data regarding my own data, and what it says something that the mosaic embryo is only 4.57. So don't create more noise regarding the mosaic embryo. And the last publication, which was said by the faculty, international faculty, says that either you transfer low mosaic or high mosaic, the live birth rate is similar to the euploid blastocyst transfer. So this is no worry about the mosaic embryo, as people are coming with the negativity of the PGTA. So this is about the mosaic of ratio, which was given by the iGenomics. It is also 5%, 3.6% of the low mosaic, overall 5% mosaic ratio, which was blinked in all the publication, which is higher. So there is no worried about to say something PGTA. I like to say and conclude my conclusion lastly that PGTA will improve per embryo transfer success rate, might improve per IVF cycle success rate, will improve live birth rate, but more studies required, especially in advanced maternal age. Success rate is also depending on the intention to treat and also intention to get the treatment. At present, at the end of the day, I will just carry the message that should not be used for all, but should be used for specific group like advanced maternal age, recurrent pregnancy loss, male infertility, and recurrent implantation failure. Thank you so much.
Thank you, sir. Can we have the discussion slide, please? Swed, sir, please take the lead, sir.
So thank you, all the faculty. I think wonderful session it was, and we learned so many things from all the faculties. So my first question to Dr. Danilo. So as you told us about most of the factors which impact on embryo implantation potential, there is one factor, I think, epigenetic factors. Can you tell us something about that epigenetic factors also? Is there any study or any meta-analysis on that epigenetics?
Well, to my knowledge, there is only one study that was assessing the methylation signature across trifecta biopsies, so beyond UPRD. And it was associating it to implantation. There might be an association, but I think more data are required, especially also in terms of the techniques we may adopt. Because, as usually, the techniques might be validated and accurately shown to be clinically useful. So this is, there is room for investigation, definitely. I see a missing piece there. But still, I don't see, a quick implementation of this kind of possibility in the near future.
So there is one more question related to extracellular vesicles.
Ved, I'd like to ask
please.
Danilo one question. Congratulations, Danilo, on the exhaustive data that you showed us in your presentation, and I was really looking forward to listening to it. I have two questions from your presentation. One, so when a euploid blastocyst fails, then how do you counsel your patients? Taking from your data, what are the reassuring things that can be told to a patient where a euploid blastocyst has failed to transfer to implant? And second question of mine is that again, so there were lots of interesting snippets of information from your data, that which are the situations where prospectively, looking at the information that you provided, we can offer transfer of two euploid blastocysts for a patient.
Okay. No, thank you, Gaurav. It's always a pleasure, to be invited at this meeting and get the chance to talk with you guys. What we use to counsel the patients, it's only our data. So we normally refer to our data, and the paper that I showed, the one that we published in Human Reproduction this year, whose title was "Leave the Past Behind," is just because, we were referring to the fact the previous reproductive history doesn't seem to be much associated with the chance of UPRD, at least. But when it comes to, so it's just like different cohorts of eggs are independent in terms of from each other. And we could see also this with the dual stem approach within the same ovarian cycle. Now, the thing is that when it comes to implantation failure, it seems instead that an history of implantation failures of any kind, so not just euploid embryos, of any kind of embryo, is associated with a lower chance that a further embryo would implant. But the point is that still nowadays we don't have enough information in order to assess this. And in my view, if you're able to get to free embryo transfer, and Pirtea showed this in infertility and sterility, it's very, very unlikely that the patient will get pregnant. Now, the problem is that you need to have free euploid blastocysts, that we know, especially when it comes to advanced maternal age women, it's very, very uncommon.
I think you mentioned that with three euploid blastocysts, 95% of patients.
95%. It's the data from Pirtea, and it's again the group of Scott. But obviously, there's a bias in that. The fact that there were patients that were dropping out. So now the thing is that you must be able, those were patients that did not drop out and transferred free embryos. Now the thing is that we should have the parameters, the counseling ability to explain to the patients that if there is enough chance, it's better to stick to the treatment. But there's cost involved, there's chances and so on. So sometimes it's better counseling them towards an egg donor cycle or whatever. So it depends on which is the real chance of the patient.
At least for patients where there are multiple euploid blastocysts, we should tell them that you should not lose hope, because majority of people will make it.
It's just a matter of statistics in my view, and in epidemiology. I'm not saying that RIF do not exist, but I think that they account for a limited amount of patients, provided that there is no uterine patency and all these kind of issues that you should be should make sure they are okay before transferring a euploid embryo. So that's the point. Regarding your second question, we never transfer two euploid blastocysts, never. So if a patient asks to transfer two, she has to sign that she has been counseled against.
Yeah,
and
okay. So, but in the Indian setup, you have to advise us that, say, if it's a poor quality embryo.
Yeah, no, that's the point. It might be meaningful if you're dealing with poor quality blastocysts, by which I mean lower than BB, according to Gardner and Schoolcraft scheme. So these are embryos that normally, worldwide are discarded. In Italy, we have to use them because by law, we cannot discard any embryo that shows signs of viability. So as soon as it is not degenerated, you should use it. And we know that they have a live birth rate of 11%. So it's, it's limited. So it can make sense to transfer to when you're dealing with poor quality ones, but I have no experience. And in any case, I would advise
you also mentioned day 6. Did you mention also that day 6
Day
embryos?
7.
Day 7.
Day 7. Day 6 and day 5 are pretty much the same. Day 7 show a lower competence, but we really don't know which is the reason. And still they account for less than 5% of the embryos in our courts. So to the point we will get to the numbers to say that there is a real statistically significant impact, I think we should collect more data. So we're trying to do this in our network, and I've recently submitted a paper. So probably next week, the next year.
I think you showed a decreasing trend though, right?
There is.
So in case we have, this is for the audience, benefit of the audience, that in case we are dealing with euploid blastocysts, even though they are day 6 and maybe a BC or a CB, then it probably makes some justification for transferring to euploid blastocysts.
Well, I in day 6, I won't say so. I will just refer to the quality. Quality. If it is a very poor quality embryo, it can make sense, but I'm really against double embryo transfer in general, so it cannot be my words.
Thank you.
Can I ask one question to Dr. JS? Sir, do you have any experience of transferring two euploid embryo transfer?
Yes, we have a lot of experience of two euploid. Suppose we are transferring a one euploid transfer in a first IVF cycle, and if she's not conceiving, right? And also there are a lot of time when patient asking that because of the multiple IVF failure, recurrent implantation failure, in first cycle we transfer a single embryo, and if she is not getting pregnancy, we transfer a double embryo transfer, that where we are sometimes we have even after transferring, I have a 10 patient series. When this up the multiple IVF failure, when we transfer two, they will end up with the only single embryo, even the 2 PGT normal, right?
Okay.
So that is what we are basically putting one generation, one couple, those who are having a multiple IVF failure, recurrent implantation failure, one single euploid blastocyst transfer after ERA, because I'm doing ERA, especially all the patients, those who are in multiple implantation failure, right? And even though after single embryo transfer, they don't have a result, in a next cycle, we can always offer them to embryo transfer, because that is a very height of expectation of the patient after a lot of counseling and also expenditure. They are ready, and we are also mentally ready to embryo transfer it at this stage. That is what my suggestion. And I'm also saying that to Danilo that the number of the patients at present, I this is my unpublished data, but number of the patients also now increasing in my data is that when we transfer to an euploid blastocyst, also we have a more single pregnancy rather than what the published data, the twin pregnancy ratio is there. So where the endometrium is extraordinary, I'm not talking about the patient, those who are endometrium is 6 mm or 7 mm. When my all patients, those who I transfer, the series of the patient were also gone through the ERA, so window period is not any point of discussion. So by putting all this together, we always explain and counsel the patient of the two blastocysts. I do agree, we also always transfer single, but I do agree in the second cycle of the recurrent implantation failure, we need to transfer two embryo. That is what we are doing at present practice.
Great. That's a good, very good conclusion, sir. Yeah. We also do. We tend to try to do that because in India, cost is a big deterrent.
Yeah. Right. Can we ask one more question, or we have to conclude?
So you can ask one more question, sir.
So last question to both of you, Dr. Danilo and Dr. Jayesh. Nowadays that that MitoScore reporting is also there. So how do you select the embryo? On the basis of that mito score, or on the basis of that that morphology also? How do you decide to which embryo to transfer?
Shall I go first?
Yeah,
Yes, sir.
No, we don't use the mito score at all.
Okay.
We've never used it, and I showed you in the presentation at least 3 papers from top quality groups that show that there is absolutely no area under the cube. So you have a rock curve, it gives you 0.5. It's just like tossing a coin, so it's meaningful. It's meaningless. So we base ourselves mainly on blastocyst quality in terms of prioritization and day of biopsy. And among the two, blastocyst quality counts a little bit more. But it's very uncommon in our patient population. We have a patient population 40 years old. If you have 1 or 2 euploid embryos, you are already lucky. So it doesn't make that much of a difference. So whatever you have, you start with.
My answer is also same in the favor of Dr. Daniel is saying that we always on the morphology. Even I'm asking my embryologist that at the time of the biopsy, what about the proper ectoderm? Because it's most important part, that how it looks like and what is the during the laser technique, how difficulty they found. So according to that, and still so ultimately morphology, and the last answer is genetic testing. We combination of this thing. We never looked for the mitochondrial score because previously we tried to have a suppose 10 patient. Then my experience is saying that morphology and genetic test PGTA report will be more useful rather than the focusing on that mitochondrial score. So we never focus on mitochondrial score. Morphology and PGTA score. That's it. PGT output.
Thank you. Thank you, everyone. Thank you, Dr. Jayesh,
Right.
Dr. Danilo, and Dr. Chimote. Thank you. Thank you so much.
Thank you to all the chairpersons and speakers. I would like everyone to please move to the main hall for oration of Dr. Kedinia, sir, our President-elect IFS. Thank you again, and good evening to all.
Thank you.
For President Oration, you need to go
Go
to
to the main
website.
hall, sir. Main hall, sir.
From the website.
Yes, sir.
Yes, fertivision2021.com. So you can log in through your registered mail ID.
Right.
हेलो निधि मैम, अतुल दिस साइड।
हाँ, yes, बताइए।
मैम अब वही 6:30 पे स्टार्ट होगा अपना, है ना?
Yeah, sharp 6:30 next session.
यस मैम। तो हमारे पास सभी कौन कौन आ चुका है, एक बार मैं चेक कर लेता हूँ।
Sir, Himanshu sir is there. I could see, sir.
Himanshu sir is
Good evening,
there.
sir. Himanshu sir is there.
Yes, advocate.
Abhi actually I was just getting phone call from 2 of our panelists only, sir. I was just trying to.
Sure. Urbi Rathore is also here.
Yeah, Samandhi ma'am is there.
Yes, Samandhi ma'am is also here.
I think so. ये wings operation का ना जयेश sir का था.
Yes.
Puri ma'am is there. Should I call other people? Like give them 10-15 minutes. After 15 minutes, they will log in.
Yes. And after 15 minutes, if someone will not log in, I will call him.
Yes. Please do that. Thank you.
Yes, ma'am. Himanshu sir, will you share your screen at that time?
Yes.
So you can test right now. if you want.
Okay, okay.
Mr. Atul, ये जो wings का hospital है इसको out कर दीजिए. I think so. This was added last time. There was a disturbance also इसके कारण ना. इसको निकाल दीजिए. It's not needed in this session now.
Just I am confirming from him. Bings Hospital, are you?
Sir से confirm कर लीजिए because it started when
Yes,
sir
yes,
logged in.
yes. I think some of my team members said that Bings Hospital, some doctor's name I just forget. So that's why
I
I
am
allowed.
sharing my screen. Can you see?
Yeah,
Yes,
yes,
sir.
but
Very clearly, sir. Very
ma'am,
clearly.
sir, can you please open your PPT first, then share your screen? I think that will be better.
Mr. Jayesh, जो last speaker थे ना, अतुल
Yes,
जी,
sir. Yes, sir.
he was the one जो wing से है, sir.
Okay.
Just talk to Mr. Jayesh.
Okay, sir. Okay, so I am removing him and putting in waiting room.
Okay, so you could see the presentation, right?
Oh, no. Your screen or folders, but can't see your presentation. So first stop share your screen and open your slide first, then share your screen.
Okay.
Good evening, Dr. Bhavishi.
Hi, good evening.
Good evening. How are you?
Good.
Good evening, ma'am.
Good evening, Nidhi.
Okay, now?
Yes. Now I can see, and just at the time do it on slideshow mode. Yes,
You
perfect.
can see
Yes, perfect, sir.
Yes, sir. Visible very clearly.
Visible.
Okay.
Perfect.
Thank you. Hi, Dr. Samudhi Sankri. How are you?
Fine. How are you? How is everyone at home?
Everyone at home is very nice.
Oh.
Fortunately, things are better now. So
That
situation-
Omicron has not come.
Yeah,
to
Omicron is powerless.
Powerless, yeah. I think it'll come and go as a common cold or something like that.
Appears to be like that.
Yeah.
Cases have increased a bit, but no serious wave-like effect, No major admissions and kind of thing. So much better.
Here also, it's not like this. Yeah. Not like before. Not like the second wave. Yeah.
Second wave was very bad, very bad. But this one is still okay.
Yeah.
And lots of marriages going on, lots and lots of gatherings going on, but still, fortunately, no major problem. So that is an indication that the things may not be as worse.
Yeah. People were just waiting to come out of the house.
Yeah, so many have come out, like Dr. Nidhi generation is out. Only so she has attended a wedding. Yeah.
Yes, sir. Approve.
Hi, Dr. Bakshi. How are you?
Ma'am, your name is Dr. Rita Bakshi, am I right?
Yes.
So I am renaming her. That's why I didn't allow her. Yes.
Good evening, ma'am.
Hi, Dr. Rita.
Ma'am, your mic is mute, ma'am. Rita, your mic is mute.
Oh.
Good evening, sir. Good evening, Deepak, sir.
Hi,
good evening. Hi, hello. Good evening to everybody.
So nice to see you after a long time.
After a long time, sir.
Yeah. Long time. And
yes.
very well made PPT. I saw the PPT also in the morning.
Thank you so much.
Excellent work done.
Hello, Dr. Nair. How are you?
No, Nair is speaking. You can't talk to him.
He's doing his oration.
Sir is presenting right now.
But can we hear him?
Mr. Atul? Atul ji?
Yes, sir. Yes, ma'am.
Can sir be audible in this platform? Sir ka video chal raha hai. Can you hear
Just
him?
doing that.
Okay, thank you so much. Thank you so much.
You can give us 10 minutes before, then that will be enough.
And there is inconvenient to patient, we already explained, there is subcutaneous administration and high cost. So all these are the disadvantages of agonist and antagonist, both of them. So over the last few years, the research has focused on the replacement of analog by progestin for controlling the LS surge. Why progesterone? Progesterone is a key signal in mid-cycle dynamic. The exact neural mechanism through which progesterone interacts with estradiol to regulate LS surge is still not completely understood, but a critical factor in determining progesterone effect upon the pre-ovulatory gonadotropin secretion, like whether it is stimulating or inhibitory, it is the timing of administration of progesterone. We all know the endogenous progesterone could hinder the rise of LH in the event that no spontaneous LH surge is occurring during control ovarian stimulation in the luteal phase. When in the luteal phase, the progesterone level is, endogenous progesterone level is high, there is no more LH surge. The progesterone is acting by reducing the DNLH pulsatility from the hypothalamus. Thus, it is inhibiting the LH release associated with increased estradiol level. So, new strategy for control of ovarian stimulation, that is progesterone prime stimulation, was gradually investigated. In prior decades, before say 20 years, 30 years, the IVF was relied on only on the fresh ET. The progesterone could not be considered for use because it is known to have a negative effect on the endometrial receptivity. However, with the advanced vitrification techniques, the superior quality of cryopreserved embryo and reliable warming, it has become feasible to break through the standard sequence of ovarian stimulation, retrieval, and transfer. That is the key word. The standard sequence of ovarian stimulation, retrieval, and transfer. We have to break through this procedure. The progesterone was thought to be an alternative agent for suppression of premature LS surge during the controlled ovarian stimulation. This is how you can organize the progesterone prime ovarian stimulation. In the upper diagram is our routine antagonist cycle, and the lower figure is you add progesterone right from the day you start the gonadotropin. This is how you give the stimulation, do the ovum pickup. You can vitrify the oocytes, or you can make them the embryos, and you can vitrify the embryos. That is the issue with the progesterone prime ovarian stimulation. The progesteronic effect at the endometrial level and at the anti-gonadotropin effect of various progesterone available to us. That is the transformation, John. That is the transformation of endometrium from proliferative to secretory phase, or the ovulation inhibitory drug for that anti-gonadotropin effect. If you look at this chart, most of the drugs, they have the almost same dose for transformation and the ovulation inhibitory, almost same, very little difference. Progesterone, dydrogesterone 10 to 20 milligram. For ovulation inhibition, you need 30 milligram. And medroxyprogesterone 5 to 10 milligram. For ovulation inhibitory, you need 10 milligram. Practically almost the same dose you need for transformation and ovulation inhibitory. Now, there are various studies which have come about the clinical efficacy of progesterone for progesterone prime ovulation stimulation. The first study published was in 2015. It was by Kong, and he did a study on 300 patients undergoing IVF-HC. The study group was receiving HMG with medroxyprogesterone acetate, and the control group was a short protocol of agonist. And the results were the study group, the oocyte number was 9.9 and control group was 9. LS suppression persisted during ovarian stimulation, and clinical pregnancy rate, implantation rate, and live birth rate were almost similar in both study group and control group. This was again analysis of his results, that clinical pregnancy rate in the short protocol was slightly lower than the control group with HMV medroxyprogesterone. Similarly, live birth outcome was also higher in the study group. So basically, medroxyprogesterone acetate is an effective oral alternative for prevention of premature LSH in women undergoing COH. Then we have a analysis of all the various studies since 2015, which have been published. So you can see all the studies which have been published. They have a study group and control group. The study group was receiving medroxyprogesterone acetate and control was short protocol. Again, another one, same study group. Then we have another study group with 4 milligram medroxyprogesterone and 10 milligram of medroxyprogesterone, comparing both the doses. So they were all published from 2015 onwards, 2016, 2018, 2019. And till the time we had this systemic review and meta-analysis published in 2020, are progestin as effective as GNR analog for pituitary suppression. There are 3 studies comparing progestin with antagonist and 4 studies comparing progestin with agonist. The primary outcome was live birth rate, and secondary outcome was live birth rate or ongoing pregnancy rate. The progestin was similar to antagonist in effectiveness, significantly higher live birth rate or ongoing pregnancy rate per embryo transfer was compared with the short GNH agonist protocol, and progestin prime stimulation lasted significantly longer and required more gonadotropin than the short protocol. So basically, progestin can effectively prevent premature ovulation in ART cycles. We had another paper published in January 21 in Human Reproduction Update by Atta. He did a meta-analysis, 22 studies were included, 10 compared progestin with antagonist, 6 compared progestin with agonist, 4 compared progestin with other progestin, and 2 compared different doses of same progestin. Let us look at the result. Progestin versus antagonist 10 studies, response to ovarian stimulation, the similar duration of stimulation was needed. OHSS was significantly lower in progestin group. The progestin versus antagonist ET outcome, similar live birth rate. So this is the comparison of progestin with antagonist. When we compare progestin with agonist, 6 studies, response to ovarian stimulation, number of metaphase 2 oocytes was similar in both the groups. OHS was non-significantly lower in progestin group compared to agonist, and the ET outcome was similar live birth rate. Then he compared different progestin for progestin prime ovarian stimulation. There were different progestin. Medroxyprogesterone was compared with dihydrogesterone, 10 milligram versus 20 milligram. The duration, stimulation, gonadotropin consumption, everything was practically the same. The ET outcome, medroxyprogesterone with the dihydrogesterone, none of the studies reported live birth rate, ongoing pregnancy rate per woman starting stimulation, but live birth rate per ET was similar in both the studies. Overall, low quality evidence says that medroxyprogesterone 10 milligram or dihydrogesterone 20 milligram per day provide the same clinical outcome. Progestin can present as an effective option for women who do not contemplate a fresh ET. That is what we have to remember. Progestin can be effective option for women who do not contemplate a fresh ET, like fertility preservation, anticipated hyper-responder, patient needing pre-implantation genetic testing, or oocyte donor and double stimulation cycles. The same study in ATA, the last group was the different progestin for progestin prime ovarian stimulation, whether we compared medroxyprogesterone 10 milligram with micronized progesterone 200 milligram or dihydrogesterone 20 milligram with micronized progesterone 100 milligram. If you look at the result, duration of stimulation, gonadotropin consumption, number of oocytes collected, metaphase 2 oocytes, they were generally practically similar. The OHS rate was in one study was not reported, other cases were no cases of moderate. So basically, whether you use medroxyprogesterone or micronized progesterone, it is the same thing. The different dose of the same progestin, whether you use 10 milligram or 4 milligram medroxyprogesterone acetate, or you can use 100 milligram or 200 milligram of micronized progesterone, the result was practically the same. Duration, stimulation, gonadotropin consumption, the metaphase 2 M2 oocytes, the clinical pregnancy rate, the miscarriage rate, all were the same. So you can use any type of progesterone in any doses to prevent the pituitary suppression. What is the use of progesterone prime ovarian stimulation oocyte donor undergoing IVF? This was again published in 2021 August in Fertility Sterility. It was a 161 donor cycles receiving 10 milligram of progesterone, medroxyprogesterone acetate, and 156 patients were receiving antagonist, DNR antagonist. The donors included in the study were stimulated with recombinant FSH and medroxyprogesterone acetate 10 milligram. The outcome was number of oocytes and M2 oocytes retrieved. Secondary outcome was incidence of premature LS search. And this is the result of this thing. The total duration of recombinant FHS, duration of ovarian stimulation, endocrine profile were comparable. So there is no early ovulation was out in either group, whether they use medroxyprogesterone or antagonist. So medroxyprogesterone can be recommended for ovarian stimulation in oocyte donor because it is a more patient-friendly approach. It is oral drug. It is not to be injected. It is oral drug. And what is the role of progesterone prime ovarian stimulation in low ovarian reserve category, patient undergoing IVF? Now, patient with the low ovarian reserve category, can we use progesterone prime ovarian stimulation? We have many studies published. One study in 2021 in Frontier of Endocrinology from Lausanne, and he analyzed 1,885 cycles integrated in 9 studies, including 942 cycles for progesterone prime ovarian stimulation and 943 cycles for control group. And his results were in the diminished ovarian reserve subgroup, the progesterone prime ovarian stimulation protocol had a low rate of premature LS search. That is important. There is a low rate of premature LS search in cases of low ovarian reserve. And progesterone prime ovarian stimulation protocol has a low rate of. If you recollect my previous slide, we have mentioned one of the disadvantages of antagonists is that in patient with poor ovarian reserve, there can be still a possibility of having a premature LS search in 1.2 to 2% of the cases. So in such cases, it's better to use a progesterone prime ovarian stimulation. Again, the progesterone prime ovarian stimulation is an effective ovarian stimulation protocol and is beneficial for ovarian reserve with the different ovarian reserve functions. We had another publication in September 2021, 2 months back or 3 months back. It was a meta-analysis, 16 case control studies, 4,422 induction cycles were included. 3 studies compared progesterone with the antagonist and 4 studies compared progesterone with agonist. The number of mature eggs, the patient receiving progesterone prime ovarian stimulation had a higher number of mature eggs, and they also produce more embryos, and progesterone prime ovarian stimulation produce more optimal embryos, and patient receiving progesterone prime ovarian stimulation had a higher cumulative rate of pregnancy, and they had a fewer cycle cancellation. All these were the results from this big meta-analysis published 3 months back. If you look at this, the meta-analysis, the cycle cancellation rate was lower. The number of mature eggs was good with the progesterone prime ovarian stimulation, and the serum luteinizing hormone on the day of SCG injection. Basically, the conclusion was that progesterone prime ovarian stimulation can reduce the need for cycle cancellation, improve the follicles and embryos, and improve the pregnancy rate, thus can present an effective choice for IVF ICSI in patients with poor ovarian reserve. Again, another publication in September 21, a retrospective cohort study, a total of 1,329 patients who met the positive criteria. He analyzed all the positive group 1, group 2, group 3, and group 4. And the results were in group 1, the dose of gonadotropin was higher in progesterone prime ovarian stimulation than the antagonist group. The clinical live birth rate of progesterone prime ovarian stimulation was 54%, which was similar to the rate of 53.8% of the antagonist group. And for positive group 2, the number of available embryos were higher in progesterone prime ovarian stimulation. And similarly, in positive group 3 and 4, there were no statistical significant difference in the number of oocyte retrieved or number of embryos or clinical live birth rate. The conclusion was low prognosis patient diagnosed as per our Poseidon criteria. The clinical live birth rate of progesterone prime ovarian stimulation is comparable to antagonist protocol. And in Poseidon group 1 population, the antagonist protocol resulted in a shorter time to live birth. Again, another study, same study, and analysis was the time to pregnancy. You see in group Poseidon group 1 with the antagonist protocol, the time to pregnancy was shorter. It was 10.4 versus 13.1%. Whenever we have a new drug for ovarian stimulation, we have to check what is the safety profile, whether it can be given to the patient and it will not have an effect on the progeny. The baby is born to such patient and immediately at time of birth, any congenital anomalies or in a long-term follow-up. So we have to do evidence of safety data of neonatal outcome and congenital malformation. The current data shows that progesterone prime ovarian stimulation using medroxyprogesterone or utrogesterone or dydrogesterone did not compromise the neonatal outcome or increase the congenital malformation. It was again published in Drug in 2019, a retrospective cohort study, 3,556 live-born infants after IVF and vitrified embryo transfer during dydrogesterone and HMG protocol or agonist short protocol. They reported no difference in the neonatal outcomes such as preterm birth or low birth rate or major congenital anomalies. The incidence of major congenital anomalies for dydrogesterone plus HMG was similar to that of agonist short protocol. So basically no difference in congenital anomalies or other neonatal outcome like preterm birth or low birth weight. Another study published by Antonio in Human
Can we
Reproductive
remove this live feed of Holly?
comparison of unipolarity
Yes,
rate in
only
women
3
treated with
minutes
progesterone
remaining.
antagonist
Yes, yes. So,
hormone. The patient
okay.
undergoing IVF
So we have all moderator and all panelists.
Yeah.
All are here. So we will start on time at 6:30. So I will, ma'am, you will be introduced.
Yeah, I'll be introducing.
Okay, so I will give you the countdown at 6:30 sharp.
Okay.
Then you will start, ma'am. Okay?
Yeah, I'll be
Please
in
request everybody to switch on their
Yes,
videos
sir.
so we can confirm that they are there.
Sir, I am there, just that I've just moved out of office, so I'll take 5-10 minutes.
No
but
issue,
I'll be
but
there.
yeah. Okay.
But I'll be there.
Shivani,
Yeah.
Deepak, Anita.
Yeah, I am there. My video
I am
will take
here.
time.
Hi, Anita. Hi, Kaushal.
Hi, sir.
She's from US.
Yes.
So we have an international symposium.
Very early good morning,
All
ma'am.
Indian.
And Radhika is joining. Yes, Sudhir will not be able to join because, as Kaushal said, that he has inauguration of his own clinic today. So unfortunately, we'll miss him. So the questions which are targeted to Sudhir can be answered by anybody from us.
I want, can one by one say everyone hello after me?
Hello.
Hello.
Yes, perfect. Sound perfect.
Hello.
Rita, ma'am, yours is mute. Your mic is mute.
Hi.
Hello. Yeah. Hi. Hello.
Hello.
Hello, Dr. Rita. How are you?
Yes. Now all good.
All are good, but Anita ma'am, internet, I think some issue there.
Because this is going to be virtual, I have written name of the persons at the bottom of the question because we may not be able to see the face directly, or you may not be able to see the face directly. And, you know, just like in real conference, it is easy for us to point at somebody or and get an answer. However, everybody can contribute their own views. It's not that the person who has to answer only can share the views. Everybody can share their views.
Anita ma'am, you can just cross-check your video and mic, ma'am. You have not started it till now. Not Rita ma'am, Anita ma'am.
Anita.
Anita ma'am.
Anita ma'am is on iPhone, so she probably is traveling. Anita, are you on move?
Yeah, at some other place, so I have some issues with internet. I think, can you hear me?
Yes, ma'am, very clearly.
Yes.
Okay, so that should be fine.
Okay, so it's 6:30. So I will give you the countdown, Nidhi ma'am. I am requesting everyone to please be
Kaushal,
on
we
mute.
will go by the simpler questions which you have framed, and you can go with the data you already have. If we have time, I have that presentation also ready. Let's see if we have time, we'll incorporate that also. But I have taken most of the points from your presentation as well, and we'll get the opinion of people, right?
Okay, so slide, if at all it has to be put up, you will put up, no, sir?
Yes, yes, I'm going
We'll
to
just
share
do the
this.
questions, right?
Yes,
Okay,
yes.
fine, got it. Okay, so I'm not sharing screen or anything.
Yeah.
Okay.
You can start, Mr. Atul.
Okay, so I am giving the countdown. I am requesting everyone to please be on mute, else who need to be on mute. And I will give you the countdown. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. We are live, ma'am.
Good evening to all. I welcome you all back after a wonderful lecture from Dr. K.D. Naya, sir. And we start our next panel discussion, that is the C10 program. Here the moderators are Dr. Himanshu Bhavishi. Good evening, sir. Founder of Bhavishi Fertility Institute, Ahmedabad. Founder, President of Instar. Dr. Kaushal Kadam, ma'am, Medical Director of Korean Fertility Clinic, Andheri, Mumbai. Fertility Consultant at Women's Hospital, Khar. May I also have the slide for the panelist? Our esteemed panelists include Dr. Deeta Bakshi, ma'am, Founder and Chairperson, International Fertility Center, RISA IVF. Dr. Samundi Sankari, Founder and Chairperson of Shruti Hospital and Fertility Center, Chennai. Dr. Deepak Goenka, Director of Institute of Human Reproduction, Guwahati. Dr. Anita Mani, Director, IVF Specialist and Laparoscopic Surgeon, Gyno Specialty Hospital, Gift IVF Center, Kochi. Dr. Shivani Sachdev Gaur, Director, SCI IVF Hospital and Noida. Next slide. And I welcome Dr. Advocate Radhika Thapar, Advocate and Advisor, Fertility Law Care, and Advocate Urvi Rathore, President of UR Legals, an international law firm. Good evening and welcome to all of you. Sir, Himanshu sir, please take the stage.
Good evening, and first of all, thank you IFS for giving us this opportunity. This is really a wonderful conference going on, and we will be touching upon the most difficult topic, I would say, in ART, because this is going to be a very challenging subject day by day because of multiple things involved. Because when we talk of third party, not only the couple, the third party is also involved, and that brings about so many questions and difficulties as well. So challenges in donor egg IVF, challenges are for the recipient, for the donors, for the ART clinics, and for the banks. So we'd like to touch upon various topics one by one. So first question, Dr. Samundi, would you like to take that? What do you think is the major challenge for a couple to undergo egg donation IVF? Because normally everybody wants their own egg, their own sperm, and want to have their own child. When it comes to egg donation, there are multiple challenges. So would you like to throw some highlight as to what is the biggest challenge?
Yeah, the propagation of life is very important for the human race and the world. And everybody wants to have their own trait, that is their own children, their own genes actually. For women actually, if you look at, there is an increase in the incidence of infertility, mainly in the female infertility, because most of the women are now career minded. They want to pursue their career first and then only think about marriage and also the childbirth. Because of that, the ovaries get aged faster. And after 35, they lose their ovarian reserve. And after 40, it is more exhausted. Ovaries are exhausted. And our Indian women compared to Western women, they age, their ovaries age about 5 years ahead of the Western women, actually. Maybe because of environmental pollution, because of the lifestyle changes, maybe because of adulterated food and all that. But these days we see a lot of primary ovarian insufficiency coming up in our clinic, mainly for, I mean, the main indication for egg donation, actually. And there are other indications also about which, I mean, our speakers at a later time, they will talk about it. But for the main challenge for the woman would be, I mean, as a couple, the husband always, we have seen in many couples, the husband always wants his wife's eggs only to be used, because I don't know what is the psychology behind it. Even if the wife agrees for the egg donation, the husband always wants his wife's eggs to be used. But there is no possibility in cases of primary ovarian insufficiency or in other cases where there is repeated implantation failure, there is repeated miscarriage, and all that. They have to go for and whenever there is a genetic defect, they have to go in for a egg donation, which they agree with kind of not with full-heartedly, but they agree because they want to have a child.
Dr. Rita Bakshi, would you like to add anything as to the biggest challenge when the couple chooses donor egg?
I think the biggest challenge when the couple, chooses an egg is how you will select a donor. Secondly, what are the kind of testing you will do, and can we have a look at the photograph, or can we know the donor? So I think the biggest challenge lies, in telling the patient, how we choose a donor. And then, of course, the anonymity of not only the donor, they of course want to remain anonymous also. So I think, and the kind of similarity and their keenness to look at the donor is paramount. They really want to look at they want to know so many details, not only look, they want to know what are her hobbies, what are the kind of things. So I think there's no end of a list. So I think this is one of the major challenges as far as the recipients are concerned. The donor, I think we'll be talking on, of course.
Yes.
We have donor.
Yeah, Kaushal, you want to add
I would
something?
like to ask, yeah, that's what, to the panelists, have you ever come across, questions from recipients requesting that I would want my sister to donate, she's the closest to me, and, same genes and somewhat same looks, and I would prefer that. So this is a question we very often come across. So is that possible? Is that ethically right? Or does the law allow us, is my question to our panelists.
So I think, Kaushal, if I were to answer this, I would say that it is the commonest thing that happens, whether it is sperm donor or egg donor, to get your brother or your sister to donate. And they will be more than happy if we allow that. Of course, we have to keep telling them that anonymity of the donor is something, which is there embedded in the law. So we cannot use a donor who's known. I think that's where it all lies.
And what about sharing photographs? Is that allowed, or can we do it?
That's not allowed again. Of course,
we cannot do it, and we also we never show the photograph to the recipient.
Yeah.
Okay, and what about childhood photographs? This is also something that I get asked in my clinic. Okay, doc, if you can show me, this is how the child will look, when my child is born. So her childhood photograph. So is that allowed?
No. I
so if I say that, of course, donor part will come in more detail later as well, but the major challenges is, number one, that the ovarian reserve is reducing, and that's why we have to opt for donor egg more and more than probably what it was earlier. But at the same time, if every gynecologist is conscious about evaluating the ovarian reserve at the first visit of a patient in their clinics, maybe this problem can, be handled much better. Number two, genetics wise, now we have pre-implantation genetic diagnosis facility, PGTA and PGT-SR both, and PGT-M as well. So many of the conditions where we were not having an option of using their own eggs now are diagnosable and can still use their own eggs safely. So that also is a major change. And egg banking also is a major change. So if the women are voluntarily postponing the pregnancies, then they are getting more and more aware, and that also is an option. So probably it might help us in future as well. So, but the biggest problem was, the success rate, or is even the success rate. And in the tremendous competition of IVF field, multiple clinics coming up, low price IVF being offered, and assured or very high success rates claimed, it has become so tempting to offer donor egg because it gives always better pregnancy chance than the self eggs in most of the cases. And that is where we were more concerned as to how you will choose between self eggs and the donor eggs. Any counseling points you would like to highlight here, or any decision points? Dr. Anita, would you like to, Rita Bakshi, you would like to take this
Yeah.
question, please?
So, Anita, yeah, sorry, go ahead if you want to answer.
So, see, if you're looking at the age, I think we know that as gynecologists find that there's a wide variation in the age of fertility, because we sometimes have successful pregnancies at the age of 42 and 45. But at the same time, when we do IVF, even for a young patient like in their 30s, we may not get good quality eggs. So I don't think it is exactly the age that we'll be looking at. So we'll be looking at various factors like antral follicular count, AMH, and the health of the pelvis, etc., etc. But saying that, generally when they're around 40, we know the success is low. So a detailed counseling is very important to inform that when they go through so many injections and procedure, and they have to spend quite a lot of amount for the procedure, that the success can be quite low. So personally, I usually take them up to around of 45 years of age, and when we consider them as recipients, I think definitely 50 years will be the cutoff point. So I think the most important aspect is looking at the chance of getting successful eggs, and if they have any prior history of repeated IVF failures, then definitely they do have to consider donor egg.
Dr. Bakshi, what would you like to add here?
So I would say that I think Anita is really optimistic as far as giving success at the age of 45. We all know, and ASRM has given us a good tabulation on the kind of success. So we know that after 42 to 45, the success rate with self-egg is less than 4%. And it is very important then to counsel the patients, even though we have a PGT now in our armamentarium, but the number, the quantity and the quality, both we know is very poor in the elderly age group. That means after 40 itself. So I think I would be very cautious in giving them the success rate. And you see, and I also know that in a very fast moving world, people don't have the neither the means, financial, nor the patience to keep trying cycles of their own. And therefore, I would also like to put it in the basket of using an egg donation in case their AMH is say less than 0.5. So of course, I mean, this we are talking of elderly age group, but even if my patient was say 37, 38, and her egg reserve was poor, if she's had a multiple IVF failures, and then I would really offer her egg donor.
Okay, I would just like to ask a question to the panelists. Like, yes, of course, we say that, we should have some cutoff age, but very often we also get inquiries from patients, where they say they have just lost a son or just lost a daughter last year. They are already 50 plus. And now they want a child. They don't have any children. They want at least one child, but they are ready for it. They are absolutely physically fit and they want to do it. At that point of time, what is the challenge that we as clinicians face? How do you counsel that patient, or what do you do? Would you assist that patient?
Anita, you can take the age question because it's probably, you said your age
Okay.
limits, but now the
Yes.
Kaushal has created a different situation for you.
Yeah. So in that scenario, I'll definitely counsel them for a donor egg because, although they would
may
have
be
been
ready for the donor egg, as you said, they are 50s, You said 50s,
Yeah.
Kaushal, right?
Yeah,
Yes,
up
So
that's
donor
right.
egg is the
So
only option. Only thing is what she wants to say, would you offer the treatment
would
or
you
you would
offer?
not like?
only up to 50, because the thing is that, like, it's not just important that we actually kind of make the family happy with another baby. It is also important for the future of the baby. When the baby grows up, that they should be able to look after the baby. Like, the mother and the father ideally should be healthy enough to look after the child, and we know that the longevity, the life expectancy, all these things come down drastically after the age of 60. So if you are looking at a child growing up, studying, go to university, so you're looking at another 20 years. So, I think we are in a very difficult situation to offer treatment for patients above 50. So I generally keep upper limit of 50, just for the
Deepak?
reason that the child needs parents to grow up.
Yes,
I would like
yes.
to quote one incidence. One NRA from France, she was 50 years, but she was looking like 35. But she didn't want egg donation at all. So we stimulated her own ovaries, and she was positive for pregnancy. And after 3 months, she went back to France, but she had an abortion. So with this kind of elderly age, abortion is also a very common issue. So not only the aneuploidies, but abortions also.
Yes,
So,
it is. Yes, Dr. Samadhi ma'am, it is important that these patients who wants to go for self-egg in spite of whatever age, it is very, very important to go for PGTA in this case. That's number one. Without PGTA, we should not offer them any IVF in this particular age group. And sir, you were asking me something about my opinion about the age group.
Yeah, cutoff.
Yes,
Cutoff.
Dr. Goenka, we are asking if at higher age group and 50
No,
plus,
for
should we
me,
be
it is-
offering or not, and
For me,
counseling?
it is 50 years. I very vividly remember one of the social worker, long back we were discussing. So she just simply asked me, and this quote came in the media only, are we creating babies or are we creating orphans?
Absolutely, absolutely.
So that's a very strong statement, that are we creating orphans? No, we don't want to create orphans. We want to have a healthy family.
Probably we had this question, but Deepak, you can continue to answer. Any unreasonable expectations from the recipients? What are the most unreasonable expectations you might get from recipients when they go for donor
Sir,
eggs?
pregnancy हो जाएगी ना, 100% donor का ले रहे हैं.
Okay. अब तो donor egg भी ले लिया.
अब तो donor egg भी ले लिया, अब तो pregnancy हो जानी चाहिए. That's the most difficult sometimes to challenge them. कि नहीं, donor is not the only factor. There are so many other factors are there. That's the most unreasonable expectation I see. Gender selections, yes, we do get requests. That's another thing. Height कैसी रहेगी? Blood group request, we do get blood group request. That is acceptable.
Probably justifiable, yeah.
That is justifiable. Height, weight, intelligent होगा कि नहीं होगा? हमारा बच्चा की हमारा. I got a request, one reasonable request. If I say हमें एक डॉक्टर का egg चाहिए. So these are very difficult to counsel these patients.
Many patients, many recipients, they want their future child to be very intelligent, very fair, very beautiful, And
No, yeah, they feel they are making a big compromise. So when they
Yeah.
make a compromise, at least they should be rewarded with something better, you know.
And the media has also created a big confusion here. They
Yeah.
don't understand donor egg doesn't mean anything else. They have created the name for the donor egg, designer baby. This designer baby word is really misleading.
Exactly. And another situation now, practical question. Sometimes we also get requests where the lady has got ready or the husband is ready, where we're going to use donor eggs, but they don't want the partner to know. So I have requests where they come and say that, okay, madam, do donor egg IVF, don't let my wife know. And let her understand that, we are using her eggs and donor eggs, or don't tell her at all. This kind of a situation, I'm sure all of us have faced quite a lot. I just want to know how you
And they would
handle
say
it.
that I'll get her signature, don't worry. I'll tell you that as well. Yeah.
Yeah, exactly. That's what. So what do you do, or what do you counsel in such a
We have to
situation?
understand two situations, two things here. Number one, the legal aspect from our safety, and number two, the psychological aspect of the couple. Legally, yes, we cannot do it, and we are not doing. I don't think anybody is doing something like this. But simultaneously, we have to understand their fear, why they are requesting something like this. Why the wife is requesting the husband should not know, or husband is requesting the wife should not know. Husband is requesting because he cares about his wife. He doesn't want wife to undergo this stress that it is not her baby. Whereas wife is requesting such request because she has a fear. These are two different aspects. Wife has a fear and husband care about her. Two different aspects. Here the role of psychologist comes. Psychologist plays a very, very important role to understand, to explain them there is nothing wrong and you can still love her. Your husband is still loving her. If wife is taking the donor, nothing wrong in that. So we usually send them to our psychologist. Extra counseling sessions are important in such cases.
Yeah, absolutely. But I think more and more, many of our Indian couples are really not open to visiting a psychologist or a psychiatrist for any counseling. So often we as clinicians ourselves have to play a dual role where we help them with the treatment as well as do the counseling.
Yeah, one more thing, Kaushal. I already faced this from a UK couple who took an egg donor, and later on they separated. And the husband, of course, wanted the custody of the baby, and and he said, "Give us a proof that you used an egg donor." And so, especially for people, I mean, now of course it's not being done, but otherwise people who are coming, or I mean, even in IVF. So, once they are taking an egg donor, somewhere the laws of different countries, that also plays a big role. So because she was so attached to the baby, she kept asking us to give us the paper saying that he was ready, and the baby is going to be there and legally and all that.
Urvi, are you there?
Right.
So I think everybody agrees that both the partners must know about the donation. And I simply explain them that the baby does not belong to one partner. It's the mutual consent. Dono ka means it's your baby, not your husband's baby or wife's baby. And there cannot be any secrets because you are putting faith in us that we will be doing what you are telling to us. And if we do something else, we are breaching your trust, and we cannot breach your trust. And same way, your relationship is also based on the trust, and you should not breach each other's trust. So it's better that you do that way only. Yeah. So now the legal aspect, the ART Bill 21 says single mother can have a child with donor sperm. But a single father cannot have a child with donor eggs, even if he has an altruistic surrogate mother. So is it legally okay, Urvi?
Legally, though, there is always much gaga over female rights, women rights, and everything. Now, here the question arises: what about male rights? Like my son, he don't want to get married, so okay, he don't have a right to have a baby, right? So, ya to wo live-in relationship mein jaye, either he should get married. So it's a personal infringement of somebody's right, everybody has a right to have a baby. So what about a male who wanted to become a father who is not married? That is the question. Where is Radhika? What is yours, say, Radhika?
Yeah, I agree with Purvi. So basically, this seems to be little arbitrary. And if you've heard Parliament's discussion, the basis to exclude single men was very weird and strange. They said, but because in adoption, single male are not allowed, so we are not allowing them in surrogacy, to have a child through surrogacy also. Now, my question is that one, you are kind of punishing a single male by all means for not having a family or a child of their own. You cannot keep adoption. First of all, I feel it's wrong to keep single male even, out of the prelim or out of the domain of even in adoption. But in adoption, the single male will not be biologically related to the child.
Major difference. Yeah, it's a major difference.
Here, the single male will be biologically allowed to child. And that's why surrogacy has increased. The surrogacy has increased so much because at least there is less chance of trafficking or exploitation of children in home. More as to adoption. So I agree with Urvi, single male should not be kept out of it. And I think that will be challenged in Supreme Court later on for sure.
100%.
Okay, so
And even
this is
Supreme
one
Court
more
will
thing.
understand
Have
the
you,
scenario.
sorry, anybody speaking? Somebody speaking?
I was speaking.
Yeah,
Even
yeah.
Supreme Court definitely will agree to the suggestions and the views, because the sitting judge must be male only. He only understands what the fatherhood means,
Yeah, yeah.
So
And you see bad fathers even in real life. The real daughters are also being raped by the fathers in society.
Yes,
So they cannot be made as precedents. Fathers are fathers and they sacrifice their entire life for their children.
Absolutely.
One bad incident and you claim that father-daughter relationship cannot be, a safe relationship is something too weird.
And with due respect,
parenting is something very different. Parenting is, in these days, even more when the society is becoming educated and evolved, it's not a gender role. It comes from, right? There are women who do not want to become mothers also, right? They are so they so want to have their life. And there are men who want to become parent and not a husband. So they should be allowed.
And lastly, to conclude,
one fear we have that probably because of it, as Dr. Rita Bakshi pointed out, if it's a donor egg, sometimes over a period of time, couple may get a feeling that, oh, ye to mera bacha, this child does not belong to me, and the child might get abandoned. As any such case has happened in India, in your knowledge, any of the advocates?
No, not really.
Not really. So that fear is a hypothetical fear. Once you get attached to a child, and if the couple is mentally prepared before they undertake the treatment, this does not happen. And same way, any case has happened where egg donors have made any claims on the baby or court cases are done or something?
Not
No,
really.
that also has not happened. So
No,
I think
not
that
really.
part of treatment or the notional fear of the couple, so many times they have, tomorrow the donor will come and ask for the baby or something, which has not happened. It is not real. And legally also, it's not a possibility. Now,
Or another scenario where, has it ever been where a couple has sued or questioned a clinic saying that they have an abnormal child because they use donor eggs? So can the lawyers shed some light over that? Can they do that? Or,
They
that
can't
cannot
also.
happen?
They can't definitely counsel.
Dr. Kadam,
You can't have a right to choose the baby. You should accept the baby the way it is coming. It's like a natural birth. Even in natural birth, if you have some defective child, you should accept it. It's your baby ultimately. We are not opening an orphanage that if you don't like the baby, just leave it. It's mandatory and you should take it. And to conclude up that first question, also the earlier question, nowadays the scenario is as such that most of the youngsters don't want to get married. So what about the young male who don't want to get married? So they don't have a right to become a father or what?
To this, can I add to this? So I will not, I'll be truthful in saying that it is not true also that nobody will question a donor egg baby. At times it may happen, if the baby, say autism or something else comes up and, they can, but then I think the cases are far and few in between, and we have to take them in our stride just like a natural birth, anything can happen. So,
So some defects are likely to be there in the babies, and some defects are diagnosed at an advanced age only, not even at birth. So this question always comes in the mind of the patient, that was the donor having this problem or not. But okay.
So mostly they don't disown the babies.
But Dr. Kadam, I would like to say in nutshell that there could be litigation of any sort. Nobody can stop anybody for any reason. It could be a justified or an unjustified reason. You will get to know everything on the basis of the complaint that come across to you and the evidence or the file or record that we have with us. That's how we can, put across to a client who could be shadowed by some fathom of thought that, he was cheated or there is some wrong happened to because of the act of the doctor. So we can explain that also, but we cannot say that, there could not be any kind of such allegation on a clinic if the child is born abnormal. It could be.
I would also like to ask the moderators, do you think genetic testing should be done on every donor?
Oh, that's an important question. Now, ma'am, it's a very important thing. There is no limit to genetic testing, number one.
Exactly.
And no genetic testing, whatever is available, is foolproof against the defects in the child. So the best genetic testing would be a genetic history rather than doing a karyotype, because karyotype, the donor is otherwise healthy and live. So that even if minor karyotype variations are there, that would not be a serious problem.
Sir, a whole exome screening, not a karyotype. A whole exome screening, sir.
Yeah, a complete clinical exome. But even then, what we see is that mutations can happen even post-fertilization. So, in fact, like I always counsel my patients, we know that, okay, the donor has, maybe heterozygous for whatever particular gene or allele, and maybe your husband is not. But then if you really want a full proof, then you even do the PGT later on. So we create embryos, do the PGT, and even that has that 0.1% where we can have, and the, the test may be wrong and you may have a slight abnormality in the child.
So my question is, sir,
aneuploidies, no? Yes, ma'am.
So my question is, sir, are we happy if they give us the choice of doing a genetic test on everybody or carrier screening on every single person and PGT, which is probably coming in the bill? So do you think this will make...
No, it cannot be done, ma'am. When you say that a donor can donate only once in her lifetime, and you do the whole clinical genome and all this, how is it going to be practically possible? So,
very
and it is an endless
Yes.
thing. It's an endless thing. It cannot be a logical thing. Yes, Radhika?
So I soon all of you would be getting a synopsis of the entire bill. I have made the and we have given to Vicky Harger a publication for publication. So that will also. So I have done a thorough study of the entire. So probably if we read one particular section in a separate understanding, right? So that conveys the meaning that PGT has to be done in each and every donor case. Okay, but I see another section in the same bill which talks about PGT to be done only if there is application for the same. Okay, so now until or unless we don't get the rules right, so as a legal person, if I am the person who has to implement the rule, the logical reasoning of that would be I will read both the clause like this, I will not read them in separately. Okay, so they have clearly said not in every case, they have said that you will do only if it is an indicated case. So I believe when the ART bank will enroll or source a donor, then while taking the history, if on some basic parameters they get to know there is an inheritable disease or an indication of a disease, or the donor mentions itself, I think then that would become a case of PGT in that particular donor.
Yeah, but
Himanshu
very
sir,
important.
Yes, Deepak.
I would like to add few things here. The two things you have told, very, very important things. As first of all, Rita ma'am as has told about the exome sequencing, or nowadays we have carrier screening also. Carrier screening or exome sequencing can be done, can be offered. But as you rightly pointed out, at this point, we are worried whether how practical it is or not.
Yeah.
We are definitely worried, but I am sure in future we all will be offering these things, especially carrier screening. We will be offering,
So we
patients
do
will be
offer
demanding.
occasionally, but then
Yeah.
patient has to spend for it, you know.
Yes, definitely.
Exactly.
The expenses will keep on going up.
And not only that, if we are doing PGT, we need to start with a large number of eggs. We
Yes,
cannot deal, doing PGT with just 7 eggs.
it
We're not
will,
justifying.
it
We
will
won't
be a
get
big
that many
hit on the
embryos.
whole donor egg program itself.
Yes.
I think now we have 7 minutes, so we little bit quickly rest of the questions. Radhika, you wanted to say something, or I go to the
Yes.
next question?
I just wanted to add one last line. Also, when while in Parliament, when they said that they want to make it more economical, these procedures to be available to masses, but if they are making these provisions compulsory, I mean, how is that possible?
Just want to add one more sentence here.
Yes.
As the Bhavishi sir has told, history taking is very, very important. Unfortunately, I don't see pedigree chart in most of our cases. At my institute, we make pedigree, three generation pedigree chart, all cases.
Yes,
very, very important.
Genetic counseling and pedigree. Yes. It's very
So
important.
we have to learn how to make pedigree chart in each and every case. Very important.
Absolutely.
We normally make for every egg donor.
Yes,
Pedigree and
I'm talking about the egg donor as well as the recipient, both.
Okay. Now only quick answers. Do you use fresh or eggs or frozen eggs for donor egg, Dr. Bakshi? Shivani is not there. I think Shivani is not answering, right?
So fresh eggs at the moment, frozen only for people who've kept them frozen or cryopreserved. Otherwise, fresh.
Okay, ma'am. How do you synchronize the cycles? Would you like downregulated? Would you like HRT without downregulation, or would you like an natural cycle? How would you synchronize donor?
Normally, we synchronize both the recipient and the donor's cycle by giving either progesterone or oral contraceptive pill. But many a times, 1 or 2 days difference may be there. But we have to see that, and we can transfer a day 5 embryo to a day 6 this one recipient. All that, sometimes 1 or 2 days difference can happen, but still synchronization is also one method. And the other method would be whenever you get a very good egg donor, what the recipient wants, all the parameters, this one will fit into the recipient's requisition. Then in that case, when the husband's semen is stored, then we can make embryos, freeze them, and make a HRT for the recipient, and then transfer at on the 21st day.
Yes.
That would give better results actually. These
So, we have now completely moved to frozen embryos so far as the donors are concerned. You know, it makes life easy for everybody, for the donor, for the recipient, and for the clinic as well.
Yes.
And semen, frozen or fresh? Do you call the husband on the day of pickup of donor or frozen, Doctor?
I think the results are equal, sir, both with fresh or frozen. So it really doesn't matter. Especially for all tested males. We always keep a frozen sample anyway.
Yeah, that also makes life easy for the couple and for the clinic both.
Backup sample always is.
Top selection criteria, the couples we probably discussed. What are the risks to the couple actually when they go for donor eggs, Dr. Mani? What are the risks to the couple, means recipient, when they choose donor eggs?
Yeah, I feel that the biggest risk is actually failure, because even if it's donor egg, we all know that sometimes it doesn't work, and the patients are under the feeling that because you're going for a young egg, healthy egg, they have very high expectation even after counseling. So when it fails, actually it's pretty tough. Especially repeated failures from donor egg is very tough to counsel. And of course, The other biggest risk is age related, because they tend to be older. So you have all the array of complications related to age. It could be diabetes, hypertension, thrombosis, especially with donor preeclampsia is more common. And there's always a higher chance of cesarean section, IUGR, preterm delivery, etc., all related to the age. Increase in cost due to admissions, increase in cost related to the cesarean or NICU admissions. So it's not just the cost of IVF, but also the cost of pregnancy kind of goes up. And if they belong to kind of middle class or lower class, I have seen a lot of patients suffer, especially if they end up with twin pregnancy.
I understand.
So I
Very
always try to
rightly.
put single
Sometimes even
embryos.
triplets.
Yeah.
So we have to restrict the
So now
number
we are
of
only 2
embryos.
minutes, so maybe we go to the
Yeah.
concluding part because we are only 2 minutes. So
Okay, so just one, I thought this was
yeah,
also an important question. How do we, what precautions does each one of you all take so that we prevent complications in the donor? I think since we are discussing this, this is one important thing. If I could have one thing that you all practice in your clinic, to prevent this, panelists.
An agonist trigger with an antagonist cycle. I think that itself will, since that's major.
Initial thorough investigation of the donor.
If she is a case of PCOS, it's better to avoid them, because most of them with PCOS will land up in OHSs.
What did you
I
say,
think
Deepak?
let's talk about the bill, sir, because I think that's very, very important.
So what are the most misappropriate thing you find in the bill? One each. Dr. Bakshi, we start with you.
Yeah.
The most, in your opinion.
I think the penalties that they are saying are worse than any criminal or a murderer. So I think the penalties are too huge.
Okay, Dr. Deepak.
7x. How will I take out the 7x? I don't
You
know.
will have to master class of 7x. Yeah.
Yes.
I know.
Dr. Sankari.
Only once. I mean, there are most of the egg donors are giving. They may go to one center, give egg donation, and after 3 months or so, they go to another center. But the other center may not know that whether they've given already or not.
So it is difficult to manage. Anika?
Yeah, I feel that when we choose the donors, see, I don't know how far it is going to be successful, because when I get the donors coming in or surrogate mothers coming in, if around 20-30 people come in, I have a very stringent criteria. I look for healthy ones. I might choose 1 or 2. But what is going to happen when ART banks are choosing these people? I don't know how far it's going to be successful that they make the decision.
Right. Radhika?
So I will conclude like this, that I feel ambiguities are there here and there in the bill, so which may create bottlenecks in the smooth functioning of the ART clinics. For example, in one of the provisions, it's written that ART banks are going to do the entire process, collection of donor group. And on the other side, the government or the authority will prescribe to the ART clinics the way how they should retrieve the eggs, right? So now what does that mean?
Those ambiguities are the biggest issue. Urvi?
Yeah, to conclude, section 34, if you read, it says that contravention of any of the provision, it should be punished according to section 33(2), which is, the harsh punishment. मुझे नहीं मालूम डॉक्टर के पीछे क्यों पड़ गए सब. You are not the hardcore criminals, So they should tackle these things and, act accordingly. And example, just a little example. Example, one egg donor has come to your clinic, or, they had gone to any bank, and that is for the second time. So it's egg donor's responsibility, because she is having a major age. So declaration should be taken, and any criminal offense or any criminal activity or any action, it should be taken against her, not against you people. तो फ्यूचर में तो देखिए ना, बहुत केसेस आएंगे, आप सब सेफ निकलोगे, क्योंकि ये प्रोविजन सब एक जनरलाइज प्रोविजन और जनरलाइज पेनल्टी से कुछ नहीं होता है. Nothing is gonna happen. The civil law will apply.
So now the last question to the lawyers: from which date the ART fraternity should follow the so-called proposals of the new bill?
Sir, basically, shall I take
to the organizer, only last minute, last question.
Yeah. Radhika, just I conclude this. President consent is coming, then only this bill will become an act. But for that, the backing of your own authority should be there. ICMR should say that we allow this or we don't allow this, then it's okay. Otherwise, president consent should be there, then only it will become law. But if this bill is there, then you should follow the bill only. That's what I say. Because आपको कोई support नहीं करता है आगे पीछे.
So basically, from the day it will be notified in the official Gazette notification, which is clearly the bill, ART bill, that from the date it will be notified in the official Gazette. That will be the day it will be effective. I have spoken to the senior most officer of the health ministry. I've told them that the clinics would need a transitional stage. Because if supposedly the president signs it tomorrow and you notify day after tomorrow, then the pending cases, the pending stimulations or the donor retrievals, so how is that going to happen? So I think I've already put in a word to them that they have to give a transitional shifting and allowing. So I think they would be making a provision for that, and they have told me to write an application of their concern that the clinics
That's a great news. That's a great news. Yeah.
And you also
So,
please
Kaushal,
write,
can you
everybody please write.
Radhika, they will
The
also
time is
have
up.
the
We need
rules
to
and
finish.
regulations by that time.
Yes, tomorrow this Wiki is going to publish that. So I have made a very short 3-pager brief for everyone that could be circulated pan-India. This will tuck, the 10, 20, 15 main provisions you will get hands on. And then write one application where I will ask, I will write an email. So everyone just give me 1-2 pointers, that these are the things will matter the most, and then we'll put forward.
Okay, please sum up, Dr. Kaushal, because our time is up. Thank you so much, organizers, for giving us the opportunity, and all the panelists.
Thank you so much. Thank you so much.
Bye-bye.
Yeah, okay. Thank you, panelists.
Thank you.
Bye-bye. Thank you.
Okay, bye.
So thank you, everyone. And again, I welcome you all. And the next session would be very interesting, I must say. And we have very, very interesting moderators also. So this is panel discussion C11. And I would like to have the PPTs for the moderator introduction. Thank you. So we have moderator today with us, Colonel Sandeep Karnakaran. He is a director, ART Unit Craft Hospital and Research Center, Thrissur. And thank you, sir. Actually, it's an honor to introduce you in such a forum. And next, we have Dr. Saili Kandhari, and she is very good friend and a consultant embryologist and lab director to IVF Center across India on advisory panel, Embryonics AI Private Limited, Israel and India. So welcome both of you, and I would like to request Dr. Sally to please introduce our esteemed panelist. Thank you so much.
Hello.
Yes, you are audible.
Yeah, okay, lovely. So it's very lovely to be here on this panel discussion for sperm preparation. I'll be introducing the panelists one by one. So could you please display the panelist CVs?
It's visible.
They are already there in the, are you able to see them?
Okay. All right. So we have Dr. Manoj Chalani, who is Director of Ayush Hospital and Maternity Home as panelist. We have Dr. Geeta Goswami, who is Scientific Director at Ridge IVF and R&D Head at Lab India Life Sciences. We have Dr. Sudesh Kamar, sir, who is Lab Director at Bloom IVF and very, very well known in embryology as Dixie King. Dr. Sanket Dhumal is a very dear friend of mine. He's a senior clinical embryologist and assistant prof at IVF Fertility and Reproductive Medicine Center and Hegde Charitable Hospital, Bangalore. Dr. Nidhi Singh also, I know her well. She's a clinical embryologist in IVF and Reproductive Biology Center at Maulana Azad Medical College and LNJP Hospital, New Delhi.
Ma'am, there's a slight change in the panel. Bindu ma'am is coming here.
Oh, Dr.
Please,
Bindu,
yes, ma'am. She's joining us, ma'am, as a panelist, ma'am. Please.
Okay. So I don't need a CV for her. Dr. Bindu Chamote is a senior clinical embryologist, one of my mentors in the space, and she is laboratory director at multiple centers in Nagpur, and a very, very well-known reproductive biologist.
Good evening, everyone. I'm Dr. Sandeep, and thanks, Pooja, for introducing me. I'll just about share my screen, and hello to my dear friend, Sayali.
Hello, hi. So lovely to moderate here with you.
Absolutely. Okay, so, well, I mean, the entire day, it's been an academic feast, and we thank IFS for it to hold this Fertivision on a hybrid mode. And it's been actually a pleasure. A lot of, I mean, talks which have been very interactive, a lot of heated discussions, a lot of knowledge sharing. And even at a little before 8, I mean, I actually sleep early nowadays, but a little before 8, we are still discussing one of the hottest topics, how to prepare 50% of the genetics which involve our bread and butter, that is sperm preparation. And despite the rapid progress that we have made in over the past 40, 45, 50 years, I mean, actually semen preparation has been here more than half a century. Are we really getting the best? And the panelists have already been introduced, so I'll just skip this slide and move on without much ado to the first question. Well, I mean, this first question is for the benefit of the young audience that we actually tend to educate over a panel, and anyone could go on to this. What are the functions of the sperm? Dr. Manoj, would you just take it on? Dr. Chelani, you there? Dr. Geeta?
Yes, sir. Good evening, sir.
Good evening. How are you doing?
Yeah, I'm fine.
Yes, sir. Yes, sir. I'll take up it. So, as we all know, sir, the head it contains the sperm. It contains and the human the head is derived from the nucleus. It contains mainly DNA. It's covered by a cap-like structure. We know term there's acrosome. And then there's a neck, which is narrow. It contains a funnel-shaped basal body, and it has a spherical centriole. And the basal body is also called the connecting piece, which helps to establish between the union between the head and the remaining part of the spermatozoa. And then there's a middle part, which consists of mitochondrial spiral, and which provides the energy to the sperm to move ahead into the fallopian tube. And the tail is covered by the fibrous sheath. So these are the various structures. And as we all know, the main is the middle piece, which helps the sperm to move ahead, and the head, which contains the DNA. So these are the various functions which play an important role in the conception later on in the fertilization.
Well, I think you summed it up so well, Dr. Chelani. I mean, well, if you actually look at it, well, the sperm is basically a transportation for the genetic material. So you need DNA, and plus you need the motility. That's what actually the main function of the sperm is. And as Dr. Chelani has so vividly and aptly put it, giving every organ a certain specific function. There's, I think, one more thing the sperm does. I think it also provides a centromere for the embryo.
Centrioles.
Centrioles.
Centrioles, yeah. Okay. Sally, over to you.
Yes.
Sir, can I add a point here?
Please, why not?
Yes, apart from the genetic material, as Manoj already mentioned, centrioles, as mentioned rightly, 2 centrioles has been contributed by the sperm again. Apart from that, there is a certain thing called as oocyte activating factors like PLC zeta, and XOF, which is again contributed by the sperm. And also, if you look at the recent studies where they published, like the study was done on the proteome of sperm, where they showed that there are 103 proteins have been involved in the various different like developmental process, starting from fertilization to blastocyst development. To say like at the cleavage stage, genes like proteins like TOP1 and NOP are involved, and at blastocyst stage there is like SPAM1 and all involved. So like it's not only the genetic material and centrioles, but also proteins that has been contributed by the sperm for the normal development process.
Another thing I would like to add, sir.
Please.
As Sangeet rightly pointed out, proteins are there, DNA is there, centriole is there. And apart from that, recent studies have shown there are small non-coding regulatory RNAs, which also are contributed by sperm, and above all, the epigenome. Epigenome for the further development of the embryo is also contributed by the sperm.
So, I mean...
Can I add one point, please?
Yeah, please.
And of course, Dr. Sanket has rightly said, so it's not just about fertilization, but the overall embryo development right from cleavage to the blastocyst formation. But one basic thing is that it controls the oocyte also, because PLC-zeta are not just for activation, but to prevent polyspermy. I mean, at the very first stage, so not just to undergo the acrosome reaction and cause fertilization, but also to prevent polyspermy. And of course, as Dr. Sanket said, further on for embryo development, the contribution of centrioles, the epigenetic information also, that can affect the well-being of the offspring in the long term.
Even I read a paper where they say that even there are certain vesicles, like the protein coated like vesicles, which are contributed not only from the testicular origin, like they're not from the testicular origin, like from the peripheral sex organs, like accessory organs, as well as glands, which are also involved in contributing to the... Yes, ma'am. Like
this is very interesting, Sanket. This is very interesting. There's an interesting points that you have put across, because then it begs the question: is TISA sperm the same as ejaculated sperm? And should we be really doing TISAs for sperm DNA fragmentation? You know, the whole reason why we study the sperm, and you have all rightly pointed out that sperm has so many functions, and so do the accessory sex glands. Begs to that question. I think we will raise it at the end of the panel, and maybe we should go on to the next question.
It determines the sex of the offspring.
Yeah, I think we missed that.
Yeah, true. I mean, I'm already floored by the first question, because I'm so impressed by the panelists all trying to answer one over the other. And that's absolutely good. I mean, Shali, would you take up the second one?
Yeah, absolutely. I don't think this panel really needs moderators much, because we have very knowledgeable people. And so the next question: why do we really need sperm preparation? And this is another basic question for our audience. And it's open to the panel. I think we should start with Nidhi, and then we can go on to everybody.
Nidhi is not answered, and Dr. Kamath has not answered.
Dr. Kamath is not here. I'm filling up for him.
Oh, okay. I didn't know that. Sorry.
Dr. Kamath is not.
Dr. Kamath has not joined. Do we need to?
He's not coming. He has a personal commitment.
Okay.
Dr.
All right.
Hindu joined at his place, no?
Okay.
All
right. Okay, so it's open to the floor.
Yeah,
I think
let's give Nidhi a chance. Yeah.
Nidhi.
So basically, we need to do the sperm preparation, because we are not going to the biological route when you're doing an IVF or ICSI. So the sperm needs to undergo certain reactions before it is viable, like capacitation, which is a very initial step in which the seminal plasma has to be removed for the cortical reaction to take place when it fuses with the ovum. So this is one of the necessities why the sperm preparation is done. And otherwise, why sperm preparation is done is, if we see functionally, we need to have the most motile and viable sperms, which are morphologically also the best sperms. So we need to have that. And if you see a semen sample, it consists not only sperms. It has motile sperm, it has dead sperm, it has lot of debris, it has the seminal plasma, it has even sometimes microorganisms and leukocytes and other cells. So for the purpose of IVF, IUI or ICSI, we need the best quality sperms. So to remove these, we do the process of sperm preparation. So,
fantastic. Okay, I think that's the textbook answer. We didn't give them the answers, right?
Can I add? Most importantly, especially with respect to IUI, if you are talking, we need to remove the prostaglandins. Because if the prostaglandins are not removed, the patient has spasms and contractions, uterine contractions.
Absolutely.
So to remove the prostaglandins, and also to remove the anti-sperm antibodies. I mean, we are not just talking of any leukocytes or some pus cells present, but also of the anti-sperm antibodies. And this, I would say more with respect to IUI. So removal of prostaglandins, removal of the anti-sperm antibodies, and of course, as Dr. Nidhi has rightly pointed out, to remove all the inhibitory factors that would otherwise block the fertilization potential. So
Perfect.
The aim of
Perfect.
any sperm preparation is multifactorial. As you know, the exact, to extract a sperm population which improves sperm motility, sperm morphology, and DNA integrity. That is one. And to improve the seminal plasma, non-sperm cells, and other non-beneficial seminal detritus. And also to permit normal sperm function, including capacitation without the induction of the acrosome reaction prematurely. So I think these are few of the reasons. And to resist the magnification of reactive oxygen species, that can be the one reason.
Wonderful. I mean, we'll have to
be non-reprotoxic, can have no detrimental short or long-lasting effect on the sperm harvested or on subsequent embryos or fetal development. So these all, I think, are one of the reasons.
Thank you, Dr. Chalani. I mean,
thank you. Yeah.
We'll have to actually give a time limit, otherwise the set of 7.
This is gonna go on and on and on.
We'll not
But
be
yeah,
able
I think Dr. Sandeep, they have covered the major factors.
things,
The
yeah.
one being removal of inhibitory factors, removal of all the prostaglandins that can cause uterine contractions and anaphylactic shock. May I add, it could cause anaphylactic shock in your patients if you do not actually remove your seminal plasma and prostaglandins. That is a risk, 1% risk that is still there. That is why sperm preparation is so very important. Even people who are planning to start their IUI centers, make sure they are investing in the right the right equipment and the right person to do.
Absolutely, right person also is very important.
Yeah, I think our panelists have put all the points across
points.
that we need to remove these factors, and we also need to concentrate coming to the sperm enrichment part. And so sperm enrichment, I think, okay, I just wanted to ask the panel one question regarding this. Have you had any adverse events related to improper sperm preparation? It could be dead sperm, it could be anything. I just wanted to point to the panelists that this has clinical significance. It's not just theoretical.
Ma'am, I have seen a case of IUI preparation when the previous sample which was taken had a motility and good concentration of 40 million and 50% motility, adequate enough to get a decent sample for IUI. But after the preparation was done, samples was totally immotile. The sperms went immotile. So this was a very difficult situation for us to handle and what to do next.
So do you think this was a
sample?
Do you think this was a technical error, or do you think that was a genetic propensity of the patient? Because some patients do show complete immortality after preparation.
To be honest, ma'am, the second sample we prepared, we got a decent. So maybe something was technically wrong, which was done. Because the second sample, we got a decent sample because the IUI was done performed later on.
Okay.
What is your experience, ma'am?
So many. So basically, I would then I'm not in the panel. So basically, I want the panelists to talk about it. Just one case study, from one of the experienced.
Like I said, we need to remove prostaglandins because there have been times where some junior person may prepare the sample for IUI, and in one particular situation, she forgot to centrifuge twice. I mean, we usually do double centrifugation step, but then she did only a single centrifugation and the sample was taken for IUI, and that is how the patient had contractions after doing IUI. She reported pain and she had contractions. So yes, that was one case many years ago, but then yes, it did happen.
Yeah, but absolutely very important to prepare.
So how you prepare the sample and how you follow each step is extremely important.
Luckily, the medias today are so much better than what we really started off with. And if one actually follows the instructions or the inserts that they put into every media bottle, luckily things generally go the right way.
Actually, just I wanted to raise this point because there are many centers in tier 2 and tier 3 where the right information and the right QC is not followed, especially for centrifuges. Many times the centrifuges stop working properly and you end up not getting a clean portion of sperm preparation. So I just wanted to point out to wherever you are in India, wherever you are in the world, just to maintain all your equipment properly so that you don't have to worry about these things.
So
I would like to add one point here.
Yes, Dr.
Sometimes I've seen that these sperm washing media in some, like I've seen, sometimes the contamination comes in some kind of turbidity or something. If a junior embryologist who's preparing the sample is not able to see all these things, can end up in these kind of non-motile sperms in the end.
Very true.
Very nice. That's actually a very good point, Dr. Geeta, because I'm sure these practical issues do occur.
Yeah.
And the junior has to be educated as to what to look out for, because we put our whole IVF center in such automation, especially for IUI, that we do not look into these factors. So yeah, thanks for
right.
Yeah.
The entire concentration is on the IVF, that the IUI part is generally ignored.
Exactly.
Moving on, I think,
Moving on.
could anyone actually enumerate the various factors that affect sperm potential? I think we'll start with Dr. Chelani again, or rather Sanket has been quiet for the previous question.
Yeah.
So,
the answer has been already addressed because most of the factors have been covered by the panelists. Well, coming to the factors affecting the sperm potential, the list goes on actually. It starts from the temperature and the pH changes in the the media which is containing the spermatozoa, and also the things like DNA fragmentation or the oxidative stress, and the list goes on. There are so many factors that actually affects the sperm potential.
Well, I would rather.
So there may be genetic problems, undescended testes, then there is a torsion or varicocele also, affects the sperm potential, there are infections and hormonal imbalance, obviously we know. And most importantly, drugs and medicines. We should always take the history of any kind of drug or any medication that male is taking. So that is also one of the factors.
So if you actually divide the answer, I mean, for anyone who's going to write an exam in the near future, luckily most of us aren't, you could actually divide your answers into intrinsic factors and the extrinsic factors.
Yeah.
Those are ejaculated ones.
Go ahead. The intrinsic factor, of course, would be the volume, the count, the motility, etc., etc. And the extrinsic factors, so very well elaborated by Sanket. Right from the drugs to the environment that it's being made in. The preparation.
And the genetic factors also. Intrinsic factors will include the genetic factors.
Yeah, true. So
genetic factors, could somebody enumerated DFI as one? Anything else?
Yes.
Intrinsic factors.
Oxidative stress.
Yes.
Yeah.
The presence
Radiation,
of ROS, intrinsic
exposure.
factor, if we take into consideration the ROS, which eventually will also affect the DFI. So the ROS, then any kind of infection, even again, I would like to say presence of anti-sperm antibodies. And these in turns are dependent mostly on the extrinsic factor, including the lifestyle, patient lifestyle, like increase in ROS, the smoking, alcohol, all these stress, all these eventually can affect the intrinsic factors, which can affect the sperm fertilization.
And also if you're looking at the morphology, and if you find monomorphic teratozoospermia, then it always indicates a genetic basis for that.
I'm sorry. Could you repeat it again, Dr. Geeta?
When you do a semen analysis and you find monomorphic kind of teratozoospermia, like all the sperm having one kind of normal shape, or like globo or macro,
like globozoospermia.
So then it indicates a genetic basis on that there.
Okay. So globozoospermia, we know the only option you have is to do ICSI and activation.
Activation, yes.
Yeah.
Tayali, can I say one more point here?
Yes, please.
See, if you look at this, the factors which are affecting when you're processing the spermatozoa for whatever the IUI or IVF, one must be very careful, like whether the medium is containing HSA or not, because capacitation is a reversible process. If there is no cholesterol acceptor, then the sperms will not be capacitated. There will be no induction of capacitation. So, even that will affect the potential of the spermatozoa.
I wanted to come to that. What do you think about the media used? And do you specifically need to use sperm preparation media, or could you use other media for the same?
No,
so I think anything that,
like we should have like
calcium
ions.
Bicarbonate as well as albumin for the capacitation to take place.
And also proper energy source.
Yeah.
Yes, proper energy source. So amino acids, NEAs, AAs.
Right.
I mean, as an extension to what Sanket said about the presence of HSA, but that could be a big source of contamination, because human serum albumin containing media if it not handled properly, there may be contamination. So you need to be careful while using.
But now it is like synthetic albumin. I think the chances of contamination are very low.
Yeah.
Earlier we used to add HSA.
Yes, initially, correct.
Yes.
Yeah, I think one of the factors which we forgot is, I think, varicocele also.
I think Dr. Chelani did talk about it. He did. He mentioned it. Yeah.
Right. Shall we move on to the next question then?
Yes.
Yes.
So I'll just click off what is not required. Okay. I mean, this is one slide which I would actually like to talk about. You know, the entire the entire aim of sperm preparation is to find that niche area which gives you the best sperm, that is talking about the structure, the function, and the intrinsic factors, excluding the bad parts and just taking that potent aliquot of sperms to get the best results. Sally, over to you.
So now we want to discuss what are the principles of sperm preparation and what techniques that you would like to enumerate that you prefer.
We'll keep the techniques for the next part.
Keep the techniques for the next question.
Let's
So what are the principles of sperm preparation? I think I can open it to the panel.
Yeah.
The first principle is the motility. If I can just answer. First is the motility, which is the most important factor, and the concentration of the sperm, which also leads to the decision whether what type of preparation we are doing. Secondly, is the type of procedure which we need to do. So the principle of the sperm preparation depends on the type of preparation which we are doing. So both the questions go together. Like if I answer,
it would go hand in hand.
There are
hand in hand,
different ways. Like if you are talking about principles, then there are different. Like there is a sedimentation, migration based technique, membrane potential. Then you have full magnetic activated sorting. And then, so all these, there are different methods for sperm preparation. So it all depends what kind of sample we are dealing with and what kind of setup we have in our lab and the expense of the technique. So depending on that, generally what we see is in ART labs is most commonly used is double density gradient and a swim up technique. Nowadays, magnetic activated sorting is also coming in.
I agree with Dr. Nidhi and Dr. Geeta that it is basically method based. Like principle is like it differs from method to method, right? And also the sample based, like how the ejaculate, what is the concentration, what is the motility, how is the morphology. So basically, the principle again depends on the method, I feel.
Okay, I mean,
so as we all know, there are 4 methods like direct sperm washing, and then we've got the swim up and density gradient adaptive. So in case of direct swim up, it's like a simple means of removing seminal plasma without materially altering the characteristic of the sperm. And when you look up at the swim up, then there's it separates sperm based on motility with migration of highly motile sperm into a clean and harvestable layer of culture media. And in density gradient, then there's a selection of density using colloidal silica to trap lower density cells, whereas high density sperm with improved sperm function penetrates the column and form a pellet. And when you look at the adaptive infiltration, that it passes prepared sperms goes through a selection solution through an adaptive filter, like a magnet to further enhance yield quality. So these are the various principles as compared to the various methods used.
So
okay, perfect. I think that was the answer we were looking for.
So broadly speaking, we are eliminating the unwanted things, and this can basically be done by washing and density gradient. And then the second thing is to concentrate it. And concentration can be by different methods. One of the most common ones, of course, is centrifugation, and the other one, of course, you can use chemical methods, magnetic methods, and other ways to actually concentrate the good ones to a certain point. Well, I'll just go away from all these things because most of it. Okay, now there are many methods of sperm preparation, and similarly, there is a lot of audience with different level of experience. So I just want each panelist to pick up one method and explain everything in detail about it. And there is one for all, I guess. And there just so pros and cons. So yeah, Sanket, I thought you raised your hand. So
yes, sir.
What do you?
Yes, sir. First and foremost, I would like to talk about discontinuous density gradient, where we'll be using a different gradient of media, like starting from 40 to 80 or 45 to 90. So you want me to explain the procedure?
No, just the basic thing.
Basically, what we do here is like basically what this method does is it eliminates the seminal plasma and entire dead sperms and leukocytes and other things, where we are going to get only the motile fraction of the spermatozoa, which are like with good DNA integrity and good morphology.
Okay. Any pros and cons of the method?
Cons is like again, the only thing is we are subjecting it for centrifugation. Apart from that, I don't find any big disadvantages going for this double density gradient centrifugation.
Absolutely. I mean, one of the biggest thing is that the centrifugal force might actually increase the DFI or the ROS at times.
Yeah, iatrogenic DFI.
But I think the speed which we use for these sperm preparations are not going to affect that much. We're not using very high speeds.
That's very true, but despite that,
very subjective.
Yeah, it's a very thing.
It's a very debatable topic, I think.
Actually. Yeah, let's move on to the next method. Otherwise, we'll absolutely run out of time.
So I just read a study. I'll tell about the swim-up method. In the swim-up method, we take the direct sperm concentration, and either we can overlay the media or we can underlay the sperm inside the media. And the basic principle is that motile sperms will swim up into the media, and that media is collected. It is centrifuged, and the pellet is taken. So I read a study in which the two, that is the swim up as well as the density gradient, were compared. So they said that the density gradient had a higher rate of DNA fragmentation, whereas swim up has a better morphology and a lesser rate of DNA fragmentation and higher concentration of zinc. So they were correlating zinc concentration. So something like that study I studied. So it is very again the question is
very. I disagree with you because see the fraction of the spermatozoa what you're going to get after wash plus swim up is comparatively low when compared to density gradients.
Agreed, sir. Again, it depends on the quality of the sperm which you've got to choose the sample method of preparation. It depends on that.
Okay, duly noted.
Depends upon the concentration of the sperm count actually and the volume that you have. So if you have voluminous amount of semen with a good count, you can actually do swim up first and then the centrifugation or with the density gradient. So that will give a better result. And if it's a normal type of a sperm, semen that you received, you can do the other way, the way Sanket has been saying, double density and then a swim up.
Or you can do microfluidics in the dish itself and eliminate both. Altogether. Dr. Bindu wanted to say something. I think.
I just wanted to say that I somewhere agree with Dr. Nidhi. If it is a normal sample, I would still go for direct layering. What she mentioned about underlaying the sample in the media and then collecting the supernatant after incubation for 25 to 40 minutes. Collect the supernatant, centrifuge, but then it is 1200 to 1500 RPM, 5 minutes only. Then again collect the pellet and resuspend and recentrifuge and resuspend. So just 2 centrifugation steps, 5 minutes each. And if it is a normal sample, you get a clean sample. If the count is less, but the motility is very good, I pool the sample by taking, rather than 1 tube, I make 2-3 tubes and then I concentrate the sample. So that is how you get a very clean sample, especially in cases where there is a lot of infection. Rather than density will also give you some debris or something, but then direct layering method gives you a very clean sample, especially, but if it is a normal sample with a good motility, that doesn't matter the count overall. You can pool the sample and concentrate it. That is what I feel. And of course, do density as well.
Yeah. N raised to N number of methods of preparation.
Any other method of preparation, rather?
Any other difference in swim? So we have covered
Simple
density,
wash.
we have covered swim up.
Simple wash. It's a
Simple
basic
wash.
method.
Just
Simple wash.
spin it down.
It is mainly used in cases of either oats or tessa sample, pisa sample. If the count is very less, you can even use other methods for pisa sample. But especially for tessa and tessa sample, we use simple wash, ma'am.
Simple wash, yeah.
Yes, ma'am, simple wash.
Yes, we do
In
too.
this, we just take the media and we take the semen sample and we centrifuge it for 5 to 10 minutes at 300 G, and then the pellet is taken. Again, a second wash is given and then the sample is used. The pellet is used.
Okay. Okay.
Anyone would like to elaborate on that?
What I have seen is sometimes when we combine double density gradient with a wash and a swim up, we get a very good sample with the DFI being decreased to a great
extent, provided the sample is normal enough to
Yeah.
go through those many steps.
So sometimes what we do is that even if it is an OAT sample, we ask the patient to give a second sample and we pool the sample and then do it.
So may I ask the panelists, is it standard for you to ask for a lower abstinence nowadays, because it has become quite common?
Yes.
Yes.
I think everybody is following that.
Yes,
I'm pretty
ma'am.
sure
Yes,
everybody
ma'am. Definitely.
is following that. But then with the lower abstinence, you do have lower counts. So
Yes.
I think your density preparations and your number of steps would probably change.
But Sayali, I think the sample with 46 million coming to 35 million doesn't make any sense. Like,
doesn't make a
not much
difference.
of a
Yeah.
difference, right?
I think it's the OATs that we are worried about more
We are really
when we
worried
are
about.
doing preparations. The other ones we can manage with density or with swim up. When you get a severe OAT sample or a severe cryptozoospermia sample, other than the spin down procedure, is there any procedure? So because we are now specifically talking about, so IUI we have covered,
Max
because
is
if
there.
you have good counts, you can do density, you can do swim up, you can do density plus swim up, you can do density plus swim up plus pooling. Basically, but if you have cryptozoospermia sample, or if you have severe OAT sample or TISA or PISA samples, TISA or PISA is a different category. But if you have severe crypto and severe OAT samples, do you do any other procedures apart from the ones mentioned? Because there are many procedures that are directly can be done inside your ICSI dish now. Are any of you following any of those techniques, and do you want to share if you do any swim preparation methods that way?
I don't do another, like we do the different sperm preparation method, but one step we do extra is in the beginning only. We counsel the patient. We know that the patient is of severe OATS case. First of all, before the case only, we get one sample frozen in case of emergency. Secondly, on the day of the pickup, we take the sample and we counsel the patient to go and relax some, and we take another sample after 45 minutes to 1 hour, so that we have a good amount of count, especially in cases of severe OATS, ma'am, when the count is very low.
Yeah.
So the second sample is usually, it is said that the DNA fragmentation rate is comparatively low also in the second sample given. So these two are the benefits of taking a second sample.
Absolutely. Pooling, sperm pooling is a very good strategy for severe OAT and severe cryptozoospermia, like the panelists have said. And maybe we could, going ahead in the questions, we could look at other sperm preparation techniques which are directly done in the ICSI dish if we have time. We can, Dr. Sandeep, I think you should go on for the next question.
No. Okay, I mean, these are things which have already been said, so I'll just go ahead. Any opinion on Max? I mean, anyone could take on Max?
Yeah, anyone take on Max?
Yeah. So though I have not used Max, okay, go ahead, Sanket.
No, please go ahead, ma'am.
Yeah, you go ahead.
No, ma'am, please go ahead, ma'am.
Okay, so though whatever I have read and seen demos of this in different workshops, that Max selects the non-apoptotic sperms. So there are a combination of apoptotic sperms and non-apoptotic sperm in the sample. Okay, so what it does is it selects the there is an exon 5 which binds the externalized phosphatidylserine residues on the sperm which are apoptosing. Okay, so it just separates the non-apoptosing sperm from apoptosing, and that indirectly indicates that the non-apoptotic sperms will have good DNA integrity and will be more viable. So, but the negative point on this is that though it is giving very good results, people are saying, but there is, if you have a sample which is having lots of debris, round cells and other things, epithelial cells, then you need to do a density gradient and combine it with Max, then you get a very good sperm preparation.
Yeah.
So the only point is that Max cannot separate on its own these other types of cells. It needs to be separated for a good sperm preparation. That's it. Sanket, you can add on.
Yeah, just extending what Madam has said already. The only thing is, even this is like I'm discussing about unpublished data, where a couple of my friends are using this for oat samples, and they said that results are very promising. I think even Sayali also discussed once, I think, with respect to this Max, right?
Yeah, because I have used it for a few years, and Dr. Krishna also had a RCT on Max,
RCT on this,
which he did not find a difference.
Find any significant difference
ultimately.
Correct.
Ultimately,
Only the point is that it becomes expensive, right? Like say spending 15 to 20,000, 15, 20,000
No,
per.
it's not just that. It's not just the expense. It's the fact that there is a lot of iatrogenic damage as well, because there are too many centrifugation steps which are additional to Max. So maybe Max is very good in theory, and yes, it does work on few samples, but overall, we didn't see much differences. Even the Cochrane review agrees on Max. Dr. Sandeep, we have glass wool
Anyone have
filtration.
an experience on glass wool filtration? Because I
have absolutely never used this, so I'm very excited to know if anybody has.
Well,
I've
I mean,
never even seen
Nothing
it.
else. Yeah.
I've never even seen it.
I had a friend
Only
that
read in the
comes with a
textbooks.
sample.
Yeah.
Yeah, so it basically it's again something like based on microfluidics, wherein the movement through this glass wool would separate off most of the things, but it cannot actually separate out the chemical part of it. So you possibly have to again do a small centrifugation before using the semen sample.
Yeah. I think that's why it never took on.
It never took off actually, but
it never took off.
it's also a very good way. I mean, because the centrifugation required is actually very less.
Very less. Yeah. Because the
And
glass wool is doing the job.
any
And the newest kid on the block and the
microfluidics.
hippest kid on the block is microfluidics sperm sorting.
Bindu ma'am, have you used
Dr.
microfluidics?
Bindu Chimute.
Yes, I have used, and for high DFI patients I have used, but I cannot say whether it has really made a big difference because not too many I have done.
Not too many
to
cases.
report whether there has been really some significant difference. But I have used for patients with high DFI, and at least I got good fertilization rates. I can say that much.
So, Bindu ma'am, you have used the one with only laminar flow, or have you used the ones in the picture which contain membrane filtration also? Because there are so many different techniques.
No, not this one.
The laminar flow one.
Yes, the laminar flow one.
This
Yes,
one.
this
Yeah,
one.
yeah,
Yes.
Polis.
With the what I have faced a problem with microfluidics is the samples having lots of aggregation and agglutination.
Yeah.
They do not work well with these.
No, they do not. And another problem have the panelists faced this, because I have. You don't actually get the microfluidic chip from the company that you just displayed. That is actually meant for severe OAT samples. They give you the one for IUI processing.
Yeah, the IUI ones. There are different microfluidics. Actually, now people have started moving into microfluidics, and you can actually use microfluidics to even separate testicular aspirate samples. But the technology be a little more purse friendly, if I can use that.
Fantastic paper on doing the density gradient within the dish itself. It was lovely. It's not commercially available yet, but I think they're all excited. No, it's not commercially available at all. I think it will be in the market in the next 5 years. But that would be game changing. I think the dish to do vitrification, micro VD, I think that was quite game changing for TISA samples. Because we have been sperm VD, yes. So that was quite radical, because we ended up freezing a lot of TISA sperm directly from the raw sample. I think.
And that too, in sperm VD, you can select the sperms and choose the good ones and keep.
Absolutely.
Okay.
So
two more. I mean, I'll ask this to Dr. Chelani. I mean, processing of retrograde ejaculation samples.
Yeah, exciting. Yes. Dr. Chelani, your expertise, please.
I think my embryologist colleague could throw light on it.
Yeah.
To be better.
No, I mean, what are the clinical part that you do before even collecting the retrograde ejaculation sample? Because that's so much more, as important as doing the processing.
Yeah. So we have to see whether we are getting a proper sample or not, what's happening, and do the urine test also, and just find out what exactly is the problem. That's it.
And do you give alkalizers before you ask the patient to collect the sample? And how far apart do you give them? 48 hours, 24 hours? What is the dose?
48 hours.
Yeah, minimum 48 hours. I think I'll move to the last part. Anyone has any personal experience on processing HIV samples?
Yes, sir.
Yes. Okay.
I just
Yes,
followed.
please.
Yeah, I did the double density gradient followed by double wash plus swim up.
Okay.
So
Before you even get the sample in the lab.
The only thing is, I didn't go for conventional insemination. I did ICSI for this patient, just not to minimize the risk again.
And
also,
even
before doing preparing the sample in your lab, one should ensure that the titer is very low while you're doing it.
Exactly.
The viral load is
that
very
was the
low.
point. That was the point.
If it is IUI, we can postpone it. But in IVF, I think we need to make sure about this viral load thing before going.
Is it even ethical to do IUI in a HIV positive sample, regardless of how low the titer is?
Now, with the newer drugs, if the viral load is less, CD count 4 is good, CD4 count is good. Even actually ask the patient to have natural intercourse, which are timed according to the ovulation, and give a post-exposure prophylaxis also. I mean, that's what the guideline says now.
They do. Okay. So that's interesting. That's interesting. If your CD4 counts are good enough and your titers are at the lowest point, then under physician control, I mean, yes.
And one more thing, what you can do is you can even check on the prepared sample. It hardly takes 2 hours for the reporting. If you send it for
That's a great point. That's a great
the viral
point.
load in the semen sample.
The viral load, yeah. That's a great point, because 2 hours you can just keep the sample at room temperature to avoid any iatrogenic DNA damage or sperm over capacity.
No, but in case of HIV sample, I will say that after preparing, if you're taking the load, the person who's doing it is at risk.
Not really, ma'am.
No,
because,
I mean, we're just sending it to the.
But the person who's preparing the sample, the person who's preparing the sample.
No, we have to take the precautions like how
you
we
have to be using
double
biosafety 3-level
Yes,
labs for handling such samples.
Correct. All those things. has to be-
Always, yeah. Always.
Anyway, we'll move ahead. I think they're already
Yeah, the time's up. I think
yeah, time is up, and we should actually conclude the.
Yeah, I would go to the last question. Are we there?
Yes. What's the answer? Not even close.
Yes. Maybe, but not optimal. Like
Every day we are learning something new, sir.
These methods are not looking at the functional aspects of the sperm. So we cannot exactly say that we are looking at the fertilization potential of the sperm, whatever we are preparing by these methods. It's all indirect evidences which we are getting through these methods.
I would take this opportunity, since the moderators and the organizers rather have shown the time this thing. I would like to thank the panelists firstly, my co-moderator Sayali, for contributing, and it's been actually wonderful to put our heads together and give the audience a bit of our two pence of our advice. Thanks a lot. I mean,
thank you, sir.
Yeah, thank you so much, everybody.
Both the moderators, Dr.
Let me
Sandeep
say
and Dr.
that
Sally, it was really wonderful.
Thank you.
Great.
Thank you.
so much.
And I would like to give the last courtesy in terms of that Dr. Sandeep was responsible for making all the questions and coordinating everything. And he's been absolutely wonderful, a resource, as well as he's taken over the whole panel very well. And I am just so glad to just be here and talk about sperm preparation. It is a very basic topic, but so important. And thank you, panelists, for all your inputs. We really
Thank
loved
you so
having
much,
you.
Dr. Sandeep and Dr. Saili. I had to leave at during the last question because I had a bad bout of cough.
It's completely all right.
But I think one thing that we need to discuss while discussing about sperm preparation is the temperature at which you centrifuge, and after centrifugation, before use, where do you keep your sample? That is one thing that people, I mean, that could be one of the reasons, Dr. Nidhi, where you found that all of them were immotile, probably because we have this habit of collecting the sample even before the pickup and as a standby have a frozen sample. After you get the sample in the morning, obviously you are going to prepare it soon. And then if you leave it at 37 degrees centigrade till the time you use it, it is definitely going to affect.
Yep.
So that
Room temperature
we need to discuss the
very nice point.
The centrifugation. I mean, I feel it is not necessary to even centrifuge at 37.
No.
I would do it at room
Right,
temperature.
right. Yes.
So this is one thing which people really do not understand. The companies provide you 37 degrees centigrade centrifuge, everyone does it, and they don't know how to maintain it till the time.
But that is required in cases of like Kashmir and Srinagar. There, they might
the room
require
temperature is, yes. Or
Yeah, I guess temperature control is key, not 27. Like if you could just control the temperatures to bring it between 25 to 27, that would be great.
That would be the best.
Like,
So room
yeah, that would be the
temperature
best.
is the key. How do you define room temperature?
Thank you. Thank you for
Thank
your
you, all
insight.
of you, for having such a wonderful talk and discussion over such a small but very important issue. Thank you so much. It was
Thank you, Pooja. It's
Sangeeta
always a
and
pleasure.
Sailis. Yes. So now I will hand over the entire thing to Dr. Nidhi again, and she will be moderating the. She will be introducing the next session chairpersons. Dr. Nidhi.
Yeah. Again, welcome back. I would like to invite the chairpersons, Dr. Rajvi Mehta ma'am. She's a consultant, Corpo Surgicals India and Trivector Biomed. Dr. Anupama Bahadur, Professor and Unit Head of Department of Obs and Gynae, AIMS Rishikesh. And Sandeep sir, again, so Director, ART Unit, Kraft Hospital and Research Center, Thrissur. Welcome back. The next slide. Yeah. So I would like to invite, hello, hello, am I audible?
Yes, you are audible.
Yeah, I'd like to invite Rajvi ma'am. Ma'am, could you please introduce our next speaker?
Thank you, Nidhi. And it's really a great pleasure for me to invite Dr. David Mortimer. He just spoke last week at the workshop and he gave an amazing talk on quality control. Dr. David Mortimer is really well known all across the world in the field of ART, and his work on quality control, his work on the various aspects of andrology and ART. Well, to introduce him, he is the president and co-owner of Uzoa Biomedicals. He's the honorary senior lecturer at the University of Dundee, Scotland, UK, and the member of the Canadian Standards Association and Standard Council of Canada. He will be speaking on sperm on drugs. So over to you, Dr. David, looking forward.
Thank you very much, Rajvi. Let me just get this started. There we go. And it's a great pleasure to be back speaking with many of my Indian friends again. It's a great pleasure to be part of Fertivision for this year. It's a shame we can't meet in person. It's always a good meeting, and it's always a pleasure to meet my friends and enjoy the amazing food in India. From the photographs you've just seen, you'll probably be realizing now that I spent my COVID lockdown growing my beard. I'm very pleased to be able to speak today. My title is Sperm on Drugs. This is a topic that we put together a number of years ago as part of a review. I should start with the usual conflict of interest. No commercial or financial interest has influenced this presentation, so let's just move straight on from there. Throughout this talk, we're going to consider things about pharmaceuticals and nutraceuticals. These are all chemical substances that affect people. I mean, pharmaceuticals are used to cure, prevent, or diagnose a disease, promote well-being. For nutraceuticals are things that have extra health benefits in addition to their basic nutritional value. I should point out that whereas pharmaceuticals are very heavily regulated, nutraceuticals have much less regulation governing their production and sale. But it came to our notice a number of years ago that many products that come into direct contact with human sperm lack adequate testing for the absence of adverse effects. And so a group of us, like-minded individuals, put together this large review that was published in Human Reproduction Update. And the field has evolved a bit since then, but the main conclusion, I think, is probably that we still need a lot more investigation. So drugs can have effects on sperm production, where they'll obviously affect the count and sperm concentration in the semen sample. They can affect sperm differentiation, which affects morphology and function, sperm maturation and storage in the epididymis. They affect sperm normality and function, and sperm post-ejaculation will affect their longevity and their function. One of the key things here, of course, is function. And sperm function is to do with things like motility kinematics, capacitation, zone of binding ability, acrosome reaction, and fertilization itself. Sperm assessment of reproductive toxicological effects or side effects must involve functional testing rather than just simple descriptive semen analysis. If we just look at descriptive semen analysis, we're not going to get all the information we need. Now, we do semen analysis for various reasons, but whether it's just specifically for looking at reproductive toxicology evaluations or whether it's part of our infertility workup or treatment in terms of ART, the basic analysis really only looks at semen liquefaction, viscosity, volume, pH, concentration, motility progression, morphology, and vitality. I'd like to point out that there is now an ISO standard for doing a basic semen analysis. It was published just a few months ago, ISO 23162, and these are the reference methods. But the great news is that WHO 6 actually conforms to these methods. So there is no longer the discrepancy between reference methods, some of the details put in WHO 6, things in other textbooks. The problem is that these characteristics examined in a basic semen analysis have nothing about sperm function, which is not surprising because this is not the natural environment for a human sperm. In fact, the human ejaculate as collected at this point is not actually physiological. It's a complete artifact to the fact it's collected into a jar like this. The natural environment for human sperm is the female reproductive tract. This is where they do all their fun stuff, all the interesting stuff. But the first thing that happens is sperm are deposited around the external cervical os, suspended in the prostatic fluid, no vesicular fluid, prostatic fluid. These sperm, at this point, they contain the dead sperm, the dying sperm, immature sperm, ugly sperm, sperm stuck together, and a few, relatively small number, of handsome, fast-swimming sperm. But these are the only sperm that get into the upper reach of the female tract. So if you want to look at a clinical purpose for semen analysis, we really try to find out, in terms of infertility diagnosis, whether the man's ejaculate contains enough good sperm to colonize the female reproductive tract. We know this is related to sperm morphology, and it's not just the head, because here, in fact, the neck, but particularly the midpiece and the tail, are far more important in terms of where the sperm get from the semen into the cervical mucus. And this is why the transospermia index is a very useful thing to look at, because if you just look at head morphology alone, you miss a large part of the useful information. The other thing is that progressive motility, particularly the kinematics of the sperm, the patterns of their motility are really important. And we have used a definition for a number of years that's derived from quite old research in terms of trying to find the population of sperm that are showing the right characteristics to get into cervical mucus, sperm with the right stuff. I'm going to cover a few little bits of basic sperm function. We'll move on to the main topic, sperm morphology. This is not what sperm look like. It's not surprising people have problems understanding sperm morphology when you see all these cartoons that look nothing like a real human sperm. This is a diagram that was produced for the new ISO standard, and it clarifies the definitions. But the main thing is we're looking at the various regions of the sperm and deciding are they normal or not. And the important thing here is that if the sperm head is normal, it must also have a normal midpiece and a normal tail in order to have proper function. And even at that level, there could be molecular problems inside the sperm that cause problems as well. And a lot of these compounds we're going to talk about do affect the sperm inside. We do know that sperm with an abnormal head shape have at least twice as many coexisting midpiece and or tail defects. So if you select sperm by motility, you also select for normal morphology. If you think about all the processes that are essential for conception, what happens in the male is sperm production and maturation and storage. At ejaculation, the sperm are inseminated or provided for semen analysis, which is the end of their lives. But in biological terms, they're expected to penetrate cervical mucus. At this level of female tract, then we've got sperm transport and storage. There is probably a reservoir, but it's not in the cervical mucus. It's probably in this intramural portion of the isthmus just above the uterotubal junction. And during this time, the female tract sperm capacitate and show hyperactivated motility. But there's all these other specific aspects of sperm function that must occur when the sperm get near the egg in order to achieve syngamy. And anything that interferes with any of these processes will affect sperm function and sperm hence fertility. Hyperactivation is essential because it's a concomitant capacitation all eutherian sperm, that's placental mammals, and it allows the sperm to push their way through the zona pellucida. And if you don't have hyperactivation, then you can actually predict IVF fertilization failure, obviously, as well as fertilization in vivo will fail. And it's a flagella phenomenon, so changing the way the sperm tail beats. And in fact, if you look at the non-capacitated and capacitated sperm, you will see a very large difference in the flagella beat envelope. And this clearly differentiates the patterns of sperm. Now, if you separate sperm based on flagellar analysis and then define carcinematic methods for separating the two populations, you can do extremely well in defining them. But you say, why would they change this pattern of motility? Well, it's very simple. This pattern of motility, when you see it, which looks silly when they're just sitting in a suspension, when the sperm are bound to the zona pellucida, this pattern of beating produces more than 10 times the power required to break covalent bonds. So sperm push their way through the zona pellucida. And so with algae anaerobes, we can actually analyze and identify these hyperactive tracts very accurately by CASA. The aquasperm reaction is how the sperm release enzymes that soften the zona pellucida. They only soften, they don't dissolve it, because you don't look at IVF eggs and see a dissolved zona, but the sperm push their way through. And assessing aquasperm reactions in vitro is possible, but it's quite complex and a bit more expensive, so it's very rarely done. So let's go into some effects on sperm. There are very, very large numbers of drugs and other compounds that affect sperm, mostly in terms of motility, but also in terms of capacitation, hyperactivation, morphology, sperm DNA fragmentation, the aquasperm reaction. There's a lot of things can affect, what ways in which the sperm can be affected by different chemicals and drugs. So androgens, anti-androgens, anabolic steroids are one major class that will affect sperm production and to some extent function. I still put this in. Testosterone treatment is not a simple therapy for men presenting with low sperm count. I don't know what medical schools teach in some cases, because some doctors, particularly GPs, seem to think this is a good drug to use for affecting low sperm count. It actually has quite the opposite effect and is actually contraceptive. Raised prolactin will have an effect, associated with long-term chlorpromazine use. Sulfasalazine for inflammatory bowel disease had a bad effect on sperm production. Many chemotherapeutic agents obviously affect sperm production. Anti-epileptic drugs, gout prophylaxis, all affect sperm production. Cannabis affects sperm production, but also motility and the aquasperm reaction. So if you just give very, very small amounts of the active compound of cannabis, THC, tetrahydrocannabinol, then you can substantially change sperm motility very, very quickly. Finasteride is an interesting problem. Propecia, it causes male infertility. It's an anti-androgen, and it's frequently prescribed in the management of male pattern hair loss, which is an increasingly common treatment by specialized dedicated clinics in some countries. It can also be used to manage prostatic cancer. But there are many, many side effects of Propecia, and even in small doses, it can interfere with sexual function, resulting in ED and disturbances in ejaculation, and causes reduced sperm production. Unfortunately, this is often not recognized in infertility clinics. It is something that needs to be investigated as part of the workup to see if a man, particularly an older man with his second wife, may have been taking this drug to improve his hair pattern. And unless it's identified, this is quite often the problem of low sperm production in those men. Tobacco smoke, everybody knows tobacco is bad for you. It affects sperm production, increases oxidative stress, liver oxidation. Sperm from smokers have got reduced fertilizing capacity. And in fact, embryos from those sperm display lower implantation rates, obviously related to sperm DNA damage. And we know that studies of cigarette smoke extracts in vitro affect many aspects of sperm. Caffeine at low concentrations will stimulate sperm motility and kinematics of poorly motile sperm, and it will also even promote capacitation as a phosphodiesterase inhibitor. But it also adversely affects the more motile sperm, so it's a double-edged sword. And caffeine stimulation of cryopreserved sperm prior to insemination might actually be deleterious. This was tried many years ago, found not to improve, in fact, possibly even decrease fertility with IUI. Peroxyphyllin is a more powerful phosphodiesterase inhibitor, can be beneficially used in ART treatment, but its indiscriminate use has got no benefit, and Herman Tournay was publishing this 27 years ago. Peroxyphyllin does promote capacitation hyperactivation, but it can decrease sperm longevity by burning out the sperm. It just promotes their metabolism too much. And of course, you've got to be careful not to inadvertently expose oocytes to it in treatment protocols. There's a lot of suggestions that statins will affect sperm, and it's been suggested on lots of bulletin boards, list servers, but major in vivo adverse side effects of statins on semen quality or sperm function have not been identified. More powerful cholesterol sequestering drugs like beta-cyclodextrin will promote capacitation at low doses by pulling the cholesterol, which is sequestered into this hole in the middle of the molecule, out of the sperm membranes. But longer exposure reduces high levels of non-physiological spontaneous acrosome reactions and subsequently affects sperm vitality. In fact, high exposure to cyclodextrins, particularly things like methyl beta-cyclodextrin, can cause impaired sperm fertilizing ability. And in fact, they've even been considered as possible contraceptive agents. Statins, the ones that are used for hypercholesterolemia, seem to be safe, but I think the final decision is yet to be made. But certainly, when you start looking at more powerful compounds of this class, they do have adverse effects. Calcium channel blockers, this has been suggested for many years. These are obviously commonly used as antihypertensives, and we know that voltage-gated calcium channels are involved in the regulation of sperm capacitation, hyperactivation, and the acrosome reaction. So calcium channel blockers certainly can impair sperm fertilizing ability both in vivo and during IVF via destruction of the acrosome reaction. And again, this is old work from the 1990s. As a corollary, extreme elevation of calcium, intracellular calcium, can adversely affect sperm vitality, even to the extent that the mechanism might have contraceptive potential. So obviously, it's a question of dose. And they always said that the whole effect of a poison is in its dosage. So caution would dictate that any chemical, whether a pharmaceutical or naturally occurring compound that affects calcium homeostasis, is likely to affect sperm function. So if you've got men on calcium channel blockers, it may affect their sperm. But the question is, and no one's investigated this, what happens if it's the female who's on calcium channel blockers and those molecules may be in the female reproductive tract fluids? This has never been investigated as far as I'm aware. The renin-angiotensin system could also affect sperm. So angiotensin 2 receptors are on the sperm head, and they relocate there during capacitation, then influence the acrosome reaction. Studies on bull sperm, human sperm, mouse sperm, this system will affect acrosome reaction, affect zona binding to hamster oocytes, but not binding to zona-free hamster oocytes, but not necessarily to acrosome intact eggs, because this is actually a sperm ooleber fusion event. John Aitken has suggested in the last year or so that a question whether this angiotensin 2 system might turn sperm from being a gamete of usefulness into a vector for SARS-CoV-2, but there certainly doesn't seem to be a great deal of evidence for that, although the angiotensin 2 system is involved in SARS-CoV-2 infection. Endocrine disruptors, CAT-SPR, which is those calcium channels and sperm function. Obviously, the next speaker is going to talk about EDCs in more detail. But there's an interesting thing that's been discovered in the last few years, which is many structurally diverse EDCs activate CAT-SPR, and therefore invoke a calcium spike inside the cells. You get a Matilda response and acrosomal exocytosis. You can see from these images here, you're seeing this very much this hyperactive pattern of sperm tail beating. So we know that these drugs will affect sperm function, but again, it would be inside the female tract, not so much inside the male. And the more scary thing is that a lot of the UV filter molecules used in sunscreens and other personal care products are also endocrine disruptor molecules. So things where you don't expect to have seen endocrine disruptors or effects on sperm, like sunscreens, can affect sperm. And again, it wouldn't be inside the male, it would be inside the female. Astaxanthin is one of these modern magic molecules. It's just a red pigment, it's a carotenoid, and it's what causes the pink color in salmon. It has many recognized properties. It's an antioxidant, it's anti-cancer, anti-diabetic, anti-inflammatory, and it promotes skin health. So yes, it's a magic molecule. And it's put into many dietary supplements. And there's even a suggestion from some work about 15 years ago that it might improve semen quality in men. But in vitro experiments show a very clear dose response to astaxanthin in terms of inducing the acrosome reaction in human sperm. So again, this is something that would not happen in the man, it would happen inside the female. So perhaps if the woman is taking this substance as part of a nutraceutical, for example, this could be affecting sperm function inside the female tract. And the problem is if you stimulate the acrosome reaction before sperm reach the cumulus oocyte complex, this is a problem because only acrosome intact human sperm can bind to the zona and fertilize. So if they've undergone the acrosome reaction, in the female tract before they reach the egg, then they're not going to be able to fertilize it. There are many other drugs that affect sperm, like opioid analgesics. They affect sperm motility, and at high concentrations, they can be effectively contraceptives. Anti-epileptic drugs cause ED and alter semen quality in almost all men, decrease progressive motility and impaired sperm morphology even. Propranolol and related beta blockers, apart from doing wonderful things to your brain, will inhibit sperm motility in vitro, as shown by these very old work from the 80s. And in fact, it's also been shown that propranolol will act as a contraceptive if it's administered intravaginally. I have no idea what it does to brain function, but it certainly affects the sperm. There are many aspects of personal hygiene or skincare products beyond these other compounds that I've talked about. The typical formulations of such products are hyperosmotic due to small molecular weight alcohols such as glycerol, propylene glycol, and or oils. But a lot of these molecules are toxic to sperm, and like soap and detergents, can permeabilize and dissolve the sperm plasma membrane, causing sperm death. Of course, sperm are not exposed to these products during normal reproductive activities, but the concern is when these products are misused during intercourse by couples who are trying to conceive and during semen collection for fertility evaluation treatment. You all know the problem if the man gets soap into the semen collection container or mixed with ejaculate at collection. Lubricants, commercial water-soluble lubricants, even ones labeled as non-spermicidal, are typically harmful to sperm. They contain glycerol and or propylene glycol, which makes them hyperosmotic, often 5 to 10 times the acceptable level for normal sperm function. And elevated concentrations of permeating cryoptectins like glycerol are spermatoxic. We know that if we put too much glycerol with sperm or mix it improperly during preparation for freezing, we affect sperm function. These lubricants often balance the vaginal pH, which is outside the functional range for sperm. They often contain preservatives such as parabens and calcium chelators that can alter sperm function. And they might contain a substance called phenoxyethanol, which I'll talk about later. Important thing to know is that non-spermicidal is a drug classification, meaning the product does not contain a spermicidal drug. It's got nothing to do whether this thing has actually been tested for safe use with sperm. So it may actually kill all the sperm, but if it doesn't contain a spermicidal drug, it is not normally labeled as a spermicide and can be called non-spermicidal. It's a strange definition. And many gynecologists and even fertility professionals are still unaware of the studies showing that many of these lubricants actually affect sperm. So for couples who are trying to conceive need to use products that are known to be sperm safe if they're trying to deal with their vaginal dryness problem. And you can see things like KY jelly, Astroglide, Replens, all certainly affect sperm function very quickly, whereas this particular product, Pre-Seed, is good. So great care must be taken to ensure that these formulations of these products are safe. And there's this thing called GRAS, which I'll come back to in a moment. So when you're making these products, the formulations and the manufacturing must be compatible with sperm longevity and proven safe by validated testing methods. It's not just good enough to have a product that's good formulation. The manufacturing process, by introducing lots of endotoxins, for example, can affect their compatibility. GRAS is generally regarded as safe. So in the absence of specific information of chemical safety for use with sperm, assumptions of presumed safety are made on the basis of whether a chemical is generally regarded as safe. And a good example here is glycerol. It's a presumed safe component of vaginal lubricant because it's commonly used in skin creams and other lotions, and it's safe. And it's used in sperm freezing media as the permeating cryoprotectant. But as I've just said, if you have too much of it, it's not a good thing and it can kill the sperm. Preservatives such as parabens, we'll come back to them again in a moment, and nutraceuticals and other health food components, we've already talked about some of these, are considered safe in general terms, but they're not tested for effects on sperm. So how do we know if they're affecting sperm or not? It's an assumption, which may well be an over-assumption. Remember that to assume is to make an ass out of you and me. So best practice requires that we avoid presumed comparability with similar, supposedly similar predicate products during the regulatory process. We've got to avoid false perceptions of physiology, such as you might be finding in the lay literature. We've got to avoid inadequate testing on human sperm. Just looking at sperm motility in vitro is inadequate because it could be affecting other aspects of sperm function related to capacitation of fertilization itself. And we've got to be careful about invalid extrapolation from testing other species. Informal lubricants, this is the home remedies, baby oil, mineral oil, canola oil. These can also be toxic to sperm, and they obviously have concentration and time-dependent effects. I said oils interact with the lipophilic membrane constituents, cause permeabilization and dissolution of the sperm plasma membrane. And in fact, some of these contain pro-oxidant byproducts that can limit sperm function. So these are the things up here. So they don't have massive effects by comparison to some of these lubricants, but they are still significantly reducing sperm motility. Canola oil a little bit, baby oil more, and sesame oil more than that. The interesting thing about these, KY sensitive, KY warming, KY tingling, whatever they're putting in there may apparently increase the pleasant feelings, but it's certainly not good for the sperm. Parabens. Parabens have been widely used as preservatives in many foods, cosmetics, toiletries, and pharmaceuticals due to their relatively low toxicity profile, in a general sense, and a long history of safe use. But they are synthetic estrogens, and hence they're endocrine disruptors. When used as an antimicrobial in sperm cryo-medium, parabens cause decreased sperm motility. Parabens can exert cytotoxic effects via the mitochondrial respiratory chain and mitochondrial membrane function on sperm, so they're not good. And in fact, at sufficient concentrations, parabens are actually effective spermicides. They can also interfere with acrosin, impair sperm function, and it's even suggested that they could be developed for use as a vaginal contraceptive. So in fact, parabens are being removed from many products these days because they're EDCs, but it's a good news for us because it will reduce these risks to sperm function. There are some issues caused by chemicals having multiple names. Now, to avoid confusion, whether it's inadvertent or intentional, people use different names for the same chemical. And we need agreement on the use of specific chemical nomenclature rather than these trivial names. I'm going to give one example of this to show how much this can be a problem. So phenoxyethanol is a preservative used in many cosmetics, lotions, and personal moisturizer products. And you can see it's heavily used. Your armor of protection, it's called here. And it's in this body lotion, for example. But phenoxyethanol has got two other names. If you call it by its chemical name, ethylene glycol monomethyl ether, known as EGME, it has significant reproductive toxicology or toxicity in humans, including suspicions of reduced sperm counts. And there are also reports of exposure affecting female offspring in future generations. Obviously not in humans, but there's been rodents. But EGME is known not to be safe. Phenoxyethanol is considered to be safe by general regarded as safe principles. But this compound, the same compound, has another name, spermicide 741. And I'm not going to say anymore, it's fairly obvious the conclusion to be drawn from that. So take-home messages. Sperm function occurs within the female reproductive tract. We need to be aware of the effects that drugs and chemicals have not just on sperm production, but also on sperm function. We need to minimize unnecessary exposures to reduce possible adverse effects on fertility. And there's just not enough testing done of these things. They're used quite happily, blithely, without any knowledge that they are safe in of these chemicals. And we propose some approaches for future sperm safety, which requires developing biologically appropriate strategies for evaluating possible sperm toxicity in all sorts of chemicals that could come into contact with sperm in some way or another, either by use of a lubricant or by inadvertent use during trying to conceive couples, or that they're just getting into the female reproductive tract. We don't know if they do, but if they do, we've got problems, so we should be finding out. We need some standardized testing protocols based on reference analytical methods, not poor quality semen analyses. And we need to get some expert groups together, which be ideally convened by an international professional body, perhaps a government regulatory agency, but they never agree with each other anyway. So we should be looking with some expert groups, let the science make the decision, and get some minimum standards for in vitro bioassays of human sperm function, which means technical standardization, validation of the assay, objective analysis, operator training competence as appropriate, followed by valid statistical analysis and physiological interpretation results. If we don't do this, we're going to have an ever-increasing number of risks to fertility, whether it's inadvertent or just completely because we're ignorant of what we're doing. And so sperm on drugs, they're not making the choice. We're making the choice for them. And certainly we should be much, much more careful about the chemicals that we are allowing to come into contact with sperm, because whether or not the sperm count is falling with time due to the endocrine disruptor environment, we will have an increasing problem with sperm function. So the fewer sperm we might have, they're potentially going to be less functional in their native environment of the female reproductive tract. Thank you very much indeed. And I'm going to stop the share.
Thank you, sir, for this highly educative and eye-opening lecture. Ma'am, we have 5 minutes for questions.
Yeah,
Rajima?
thank you, Dr. Mortimer. I mean, I've been a regular follower of yours. I read your books, and it's been an absolute pleasure actually to listen to you and moreover to moderate a session. I do have a question. Some of the drugs that you actually enlisted here today, unfortunately, cannot be avoided. So just in case a person is exposed to a certain drug, how do we prevent its effects, like say in sperm preparation, or is there any way to actually mitigate its effect?
Well, colchicine for gout, I've been on it for many years, but there are other drugs that you can take instead of it. Things like febuxostat is a much better way of controlling gout than colchicine, much safer. So you can swap the drugs, for example. There are antihypertensives that are used in some respects. Losartan, Cozar is one of them. But if somebody needs certain particular class of antihypertensives because they work for them, like ACE inhibitors or calcium channel blockers, you might not be able to find alternatives because other compounds within the same class may have similar effects. So we need to know if some of these particular compounds have lower effects on sperm, but no one's testing them. So we need to encourage the testing to find out. I suspect what it's going to mean is that we are going to have to be much more careful when we're finding out what people are taking when they come for infertility treatment. If the man is on Propecia, that's easy. Stop taking it. You've already got your second younger wife. She probably doesn't care about your hair pattern. So you can stop taking the drug now and you'll get your sperm back. So some of those lifestyle things. But what concerns me most is these drugs that are hiding in our natural environment. The things like parabens to a lesser extent, but still used in many parts of the world. But the things like astaxanthin and the sunscreen UV filter molecules that may be getting into the body. Well, obviously they are getting into the body, but are they getting into the female reproductive tract? Are they actually going to have an effect on sperm there? We don't know. These are important things to find out, because if that is the case, that people need to be aware of these things, and these are optional things. They could stop using these things for a period of time if they're trying to conceive naturally and decrease the need to go for ART treatment. But if we're going for ART treatment, we're bypassing things, so we end up going for ICSI if we've got problems with sperm function. But ICSI is not harmless. There are many aspects of ICSI that are not optimal. Embryos are less functional. You get fewer embryos by ICSI compared to properly performed IVF. So we have ways of bypassing the problems, but we should be looking more holistically. And the whole problem of male infertility or male factor infertility, sperm function, and all the things that can influence it, and work out better strategies, not just simply saying, oh, as long as he's got more sperm than she's got eggs, we're fine, we're going to do ICSI anyway. It's inappropriate to pass the burden of male infertility onto the female partner by forcing her to go through a stimulation, an egg retrieval. We should be looking much more what we're doing, what the males are suffering in the environment, and can we reduce that need for ART in those patients?
That's actually a fabulous thought process. I mean, thanks for the time and answer.
No, thank you.
Rajvi, any?
Yeah, just one question. What do you think about the antibiotics, especially the antibiotics which act on bacterial protein synthesis? So some of those, would they also be acting on sperm mitochondria?
They could well be, but if they're being used inside the body on the entire body, then we should be getting to all the cells. I assume their effect is not going to be too substantial. But as everything, it's a concentration effect, and we don't know. So the answer is, if we don't know, we're scientists. We should do experiments to find out. And if we have a suspicion of something, someone should do some research to find out. And rather than assuming it's safe or worrying unnecessarily, like turning sperm to SARS-CoV-2 vectors, it was a valid concern, but it seems not to be a problem. So we find out these things with time. As scientists, we accumulate data. But in this case, I think we need to do some direct experiments to find a real answer.
Thank you. So I think that was a wonderful.
Any question from Anupama, ma'am?
No, that was a brilliant lecture by Sir. Absolutely brilliant, and it's a pleasure to hear him always. Thank you.
Thank you very much.
Thank you.
Thank you, sir. Thank you, all the chairpersons. I would like to now, let's move to the hall A for our oration. And and one more announcement for all the students and people who are interested for the quiz. The quiz is at 9 p.m. in Hall A. So see you all soon. And thank you, sir, again. It was a great honor to hear you, sir. Thank you, sir. Bye,
Great
sir.
pleasure to be invited. Thank you very much.
Thank you.
very much. Thanks.
Thank you. Bye-bye.
Bye-bye.
Mr. Atul?
Yes, ma'am.
Can you just start the oration in this section also? There's no program
No.
right now running here.
Actually, from front end, you can watch the origin or anything from not here because this link will be for GBM.
Okay, then it's okay. Okay.
Yes, ma'am. Yes,
Thank you so much. Okay, bye.
Okay, thank you, ma'am.
Bye.
ESRM origin in Hall A, Hall B, Hall C is relaying through the front end fertivision2021.com. Anyone want to watch, you can log in through the website with your registered email ID. Thank you. This link will be start at 9 o'clock for GBM.
Um, Varun, can
Yes,
you hear
ma'am.
me?
Yes, ma'am.
This is
Atul,
the
this side.
hall meeting for the GBM, am I right? Is this the
Yes.
same hall?
Yes, ma'am. Yes, ma'am. Yes.
Actually, we just wanted to announce here that we are rescheduling the GBM because the quorum is not complete. We have just, I think, 24, 25 people logged in. So I just got a message from Dr. Sudha Prasad and Dr. K.D. Nair that we would reschedule this meeting because there are sessions going on with Prof. Taylor's just continuing. And also that there is a talk by Dr. Dean Morbeck and the quiz. So we'll reschedule it for tomorrow afternoon at 12:30. And we'll give the link, Zoom link, it will be in Hall C. So apologies because there is a parallel session and the quorum doesn't seem to be complete. We are just, if I look at the number, 25 people. So we'll come back because there are parallel sessions which are going a little late and also the quiz is there. So we're rescheduling the GBM for tomorrow. Apologies for same.
Okay, ma'am. Okay, ma'am.
And tomorrow we will have, because there's still, all the senior people are still in the other hall. So I just got this message to convey from Dr. K.D. Nair and Dr. Sudha Prasad that we'll have to reschedule it and keep it at 12:30. So we'll just send a separate link because we want the quorum to be complete with the adequate number of members to join for the GBM.
Okay, ma'am. Okay, ma'am. Okay, then.
Apologies for this inconvenience.
Okay, ma'am. So we exit, right, ma'am, now?
Yes, yes, because
ma'am, we are posting the Zoom link for your reference.
Yes.
You can see the Zoom link, faculty link to join for tomorrow GBM.
ये अभी circulate कर देंगे Varun. We'll circulate to everybody just now on all the groups, and we request you to join back tomorrow at 12:45.
Okay.
Yeah, 12 to 12:45, not 12:30.
Okay, okay. Bye, ma'am.
Okay, thank you so much.
Bye.
Thank you, ma'am.
Is anything happening on this in this hall now? Varun?
GVM is rescheduled till.
No, not the GBM. There was a
nothing,
lecture.
nothing,
There was a
ma'am,
lecture
nothing,
from 9 to 9:30, na?
9 to 9:30. It's quiz from
नहीं
Hall
नहीं
A.
quiz तो है hall A में, but there was a lecture in B and C by a doctor that has been reached.
Doctor, yes. That is from Hall B. So you can log in through the Fertivision
Hall B.
website.
Hall
Yes.
B.
Hall B or Fertivision website through.
Fertivision website. Okay.
Yes.
Thank you.
There is no further session in Hall C, so you can join through the front end for quiz session or for for when Dean Movek talk in Hall B from the front end. There is no more session in Hall C, and also GBM rescheduled till tomorrow. Thank you. So we are ending 11th Hall C today, and see you tomorrow, 12th at 12 p.m. for GBM and from 1 p.m. for the sessions. Thank you.